Assalamu alaikum, hello and welcome to day 2 of the Emirates Thyroid Virtual Congress 2022. You're joined again for the pre-Congress symposium, this day brought to you by Lily. So thank you for your support for the pre-Congress symposium. The title of the symposium will be Role of Retevmo in RET Altered Thyroid Cancers. And again, we're brought to you by a very eminent speaker here in the UAE, Dr. Sonia Otzman. I'll give you a brief bio of her. She's consultant medical oncologist and hematologist since 2004. She's completed various courses in oncology from the Institute of Pierre and Marie Curie in 1999. She has been in the UAE since 2006 at Tawam, to 2013, and then 2013 to 2019 at Mafraq. 2019, she joined SSMC, and then 2021, she joined Cleveland Clinic. She's involved in several clinical research projects. She's a member of the Oncology Society and Algerian Order of Physicians. She's a member of the Emirates Oncology and Hematology Society, and she's an ESMO and ASCO member. She has several abstracts and publications, and she's a speaker in several local and international meetings. And we're delighted to have her join and present the pre-Congress symposium for day 2, sponsored by Lily. So, Dr. Sonia, I invite you to join us, switch on your camera and microphone, and begin the pre-Congress symposium. Thank you.
Assalamu alaikum. Thank you for this nice introduction. And thank you for Lily giving me opportunity to share this talk, and thank you for the audience as well. I hope I will not be long, and this will be a really interesting talk in regards to the Retevmo in RET altered patients, thyroid cancer, metastatic and advanced disease. With that, I will start my my lecture. So next, please. So these are my disclosure. I have been speaker for many companies, and including Novartis, Roche, Sanofi, Lilly, Seddeeqi, Merck, and PMS and MSD. And so we're going to talk about the salperquetinib precision oncology treatment for patients with the certain RET-driven cancers, knowing that there was a lot of unmet needs in matter of thyroid cancer. We are facing specifically in UAE a lot of patients with advanced and metastatic and differentiated and medullary carcinoma are although rare, but still we were facing a kind of like unmet needs in the treatment for those patients, specifically when they are young and they are progressing. Next, please. So this is the table of my content. We're going to start to have a talk about selective inhibition of RET guidelines placement, the unmet needs in RET fusion and mutations, the salperquetinib mode of action, and the clinical trials and efficacy for LIBER-2 trial 001 in non-medullary thyroid cancer efficacy and medullary thyroid cancer efficacy, safety, dosing, testing, summary, and references. Starting with the selective inhibition for RET guidelines placement. We know, like since 2000, we have started actually, and the science and the progress of the science has been studying different mutations. The first one that have been given really a good improvement for CML patients. I remember when I was just finishing my courses of oncology was the BCR-ABL fusion for CML patients, and then we had subsequently the EGFR positive mutations for non-small cell lung cancer. That was like an explosion in the treatment for those patients and improving the free survival with the tyrosine kinase inhibitors. Then 2005 to 2009 up to 2014 we have the ALK positive non-small cell lung cancer, the BRAF mutations in melanoma. The RET fusion was discovered initially for non-small cell lung cancer, and subsequently we have the IDH1 mutations in AML, INTARC fusions, ROS, ALK, BRAF. All those have been given us a lot of hints to improve the free survival, and in many cases eventually the overall survival for many diseases which we were really stuck for treatment. So in 2021, recently we have the RET mutation in medullary thyroid cancer and the RET fusion in non-small cell lung cancer and other thyroid subtypes. The ISMO guidelines, actually recommendations for thyroid cancer, include use of selected multi-targeted kinase inhibitors. The current recommendations for thyroid cancer, including use of select multi-targeted kinase inhibitors, typically in locally advanced or metastatic disease. For patients who present actually with radioiodine refractory disease with thyroid cancer dedifferentiated, the ISMO recommends lenvatinib preferred or sorafenib as a standard first-line systemic therapy. For patients with anaplastic thyroid cancer, the preferred systemic options for advanced disease include the BRAF inhibitor, as we know all, the dabrafenib and trametinib for BRAF mutations positive tumors. For patients with progressive metastatic medullary thyroid cancer, the ISMO recommended cabozantinib or vendatinib as a first-line systemic therapy, and active surveillance may be appropriate in asymptomatic patients with a stable disease for whom kinase inhibitor therapy might not be appropriated. Historically, there have been any therapies approved specifically for patients with RET-driven thyroid cancer, and then we have the NCCN guidelines as well, which are leading to thyroid cancer type, whether we have dealing with the papillary carcinoma, follicular carcinoma, or Hürthle cell, that are the differentiated type that we are seeing mostly in our clinics, the medullary carcinoma that are rare, but still we see some of them in our daily clinics, and finally the most aggressive that are the anaplastic carcinoma. The treatment settings as per the NCCN guidelines show that treatment of locally recurrent advanced or metastatic disease non-amendable for radioablation therapy for those diseases, or unresectable locoregional recurrent persistent papillary carcinoma or follicular carcinoma. For soft tissue metastasis, lung, liver, muscles, excluding CNS metastasis, or for bone metastasis, or eventually for CNS metastasis. The recommendations for systemic therapy for progressive and symptomatic disease, we consider as a first-line lenvatinib preferred to sorafenib, larotrectinib or entrectinib for patients with INTARC gene fusions, advanced solid tumors, and salperquetinib for patients who express the RET fusion positive tumors. The pembrolizumab as well has been agreed by the NCCN guidelines for patients who have high burden tumor more than 10. For the medullary carcinoma who were treated or recurrent or persistent disease, treatment for locoregional disease, asymptomatic or symptomatic disease, we have to consider systemic therapy for unresectable disease that is symptomatic or progressing by RECIST criteria. The preferred regimens for medullary carcinoma when they are recurrence or persistent metastatic disease, preferred regimen is vendatinib category 1, cabozantinib category 1, and salperquetinib has been approved with RET mutations positive patients. Useful in certain circumstances, eventually pembrolizumab for the patient who have high burden tumor more than 10. For the anaplastic carcinoma, we have to consider initially dabrafenib and trametinib if BRAF V600E mutation is positive, and larotrectinib or entrectinib in INTARC fusion patients, the salperquetinib if RET fusion is positive, or pembrolizumab if we have a high burden tumor. Next, please. What are the unmet needs in matter of thyroid cancer? The RET fusion and mutations have been longly studied, and we have achieved actually a good answers for our questions for those patients with RET fusion or mutations. Please, next. The RET fusion and mutations promote and control cell proliferation and tumor survival in certain tumor types. You see in the left side, if we have a RET fusion patients with non-small cell lung cancer, that is representing almost 1 to 2% of those patients, but we have almost 10 to 20% of the patients with papillary thyroid cancer who present actually the RET fusion. And if we consider this percentage of 10 to 20% for patients with RET fusion, so literally we're going to have an arm how to treat those patients in metastatic or progressing disease. The RET mutations actually in medullary thyroid cancer for sporadic is represented by a number of 60% and 98% for germline medullary thyroid cancer. So the RET mutations may be present in other tumors as well, but we believe that only in driver medullary thyroid carcinoma, the medications can be used. So the RET driver alterations are predominantly maturely exclusive for other oncogenic types drivers. So here we can see in these illustrations for the multiple method of oncogenic activations for the RET, we have the RET fusion that is found in many tumor types. In non-small cell lung cancer, 1 to 2%. In papillary and other thyroid cancer, we can see the number is eventually 10 to 20%, which we will not consider treatment if we didn't have these studies for the RET fusion. For pancreatic cancer and other diseases like Spitz tumor, colorectal, salivary gland, ovarian, and myeloproliferative disorders, and many others, we can see that the fusion is very low. So actually the CCD6 or NCO4A are the most common in thyroid cancer in kinase mutations. So the RET activity mutations are found in medullary thyroid cancer in almost, as I say, sporadic cases, more than 60%, and this is really considerable, and hereditary by more than 90%. And this is really to keep in mind that those mutations in medullary cancer give us a very, very interesting reasons and good hands for controlling the disease and eventually having a good response with using the retivmo. So you can see here the activation by ligand and dependent dimerizations in covalent disulfide bonds in cysteine-rich region in this codon, and we can see here the kinase domain mutations. The common mutations is RET M918T by name. The RET fusion might promote and control cell proliferation and tumor survival. So the fusion partners that are known for RET, you can see here, the fusion is very well known in this codon, and the common RET fusion partners are the KIF5B, most common in the lung and in the thyroid that are the papillary or other subtypes differentiated, the CCD6 or NCO4. The RET fusion are oncogenic drivers through two main RET activations mechanisms. The first one is ligand independent dimerizations, and the second one is constructive RET kinase activation. The RET mutation as well is increased in the RET kinase activity. The RET mutations are oncogenic driver through two main RET activation mechanisms, the ligand independent dimerization and the constructive RET kinase activations. And the common mutations in the RET is called M918T. What is the mode of action of salperquetinib? The salperquetinib was designed actually as a targeted RET, the primary driver of certain RET driver cancers. We have the driver mutations and we have the driver fusion. The driver fusion actually can be used as a tool for treatment for non-small cell lung cancer. As I mentioned before, 1 to 2% from the general populations with non-small cell lung cancer will have actually fusion in the RET, and for the thyroid cancer patients, not the medullary type, but the papillary, the polydifferentiated, the anaplastic, and the Hürtel cell tumors. In matter of medullary thyroid cancer, we have the RET-driven, that is the mutated RET that have been, as I mentioned before, in the sporadic population, almost 60%, and in the hereditary population, more than 90%. In the thyroid cancer that are different from the medullary type or in the non-small cell lung cancer, we are not studying the mutations, but we are not studying, the fusion, but only counting on the driven mutated RET. So the RET mutations may be present in other tumors such as non-small cell lung cancer, but they are not actionable. And this is very important to remember, fusion and mutation and which type of cancer. Next, please. So the salpercatinib demonstrated highly selective and potent RET inhibition. We can see this in these three graphs, the therapy, which is kinase inhibition selectively. The non-selective activity you can see here in this cell is genome is all over. The selective kinase activity is somehow dispatched in the specific areas, but you can see the highly selective kinase activity for the RET that is specifically compromised with only specific genes. So the images actually depict the human kinome exactly, which is a map for the 518 protein kinase that compose 1.7% of all human genes. The circles indicates the position of the specific kinase targeted. Next, please. So the mechanism of action is well described as well in the schema. We can see that the direct kinase activation is going through the activation of the RET kinase to RAS, RAF, and ARC, and some other mutations activated by the lung, by the ligand-independent dimerization. And the salpercatinib will come and will just stick to this activation by ligand-independent dimerization, and it will lead to apoptosis. The LIBER-2001 was the largest trial of patients with RET-driven cancer. The number of the patients included was 702, and it was a phase 1/2 trial. Actually, the randomized trial was including four kind of randomized trial between RET fusion positive metastatic non-small cell lung cancer. The patient number was 332. The RET fusion positive advanced or metastatic thyroid cancer, non-medullary type, the number was 38. And the RET point mutation advanced or metastatic medullary thyroid cancer with a big number of 306, or other solid tumors that were included. Treatment naive patients were 39, and previously treated with platinum chemotherapy 105, systemic therapy naive number 8, and previously treated patients was with a number of 19. Patients treated initially with cabozantinib and vandatinib, treatment naive was 88, and previously treated with cabozantinib and vandatinib for the other solid tumors was 55. The major efficacy outcomes was overall response rate and durability of response, and other efficacy outcomes was free survival, overall survival, CNS disease, and overall response rate. And we don't forget here that the overall response rate was defined, in fact, by complete response plus partial response. Next, please. The clinical trials actually for LIBER-2001 in non-medullary thyroid cancer efficacy has been proven. So this is the phase 2/3 trial, as I mentioned before, for 702 patients. I will not go through it with detail because it's the same slide as I mentioned before. Next, please. The RET fusion positive thyroid cancer in LIBER-2001 molecular features and patients characteristic, as you can see, is well defined, and the RET fusion partners in thyroid cancer non-medullary in the clinical trial who presented with CCD6 was 52% and NCOA4 was 33% and others was 15%. So the patient characteristics, whether they are male and female, the number was almost equal. Here we have the RET fusion positive patients that are non-medullary thyroid cancer, systemic therapy naive, and on the right side we have the proportion of patients who have been initially treated with primary therapy. Performance status for those patients was in general between 0 to 2, and prior systemic therapy was allowed. The brain metastases for the patients non-treated with systemic therapy were 1, and patients who were treated initially with systemic therapy was a number of 6. Next, please. Efficacy in patients with advanced metastatic red fusion positive thyroid cancer. You can see here this amazing overall response for systemic therapy for patients who are naive treatment is represented almost by 100% of overall response rate. We have here 89% partial response and 12.5% with complete response. And the median durability of response is not yet reached. The median follow-up is 8.8 months, and you can see that there was 100% durability of complete response. From those 100%, 88% expressed partial response and 12.5% expressed complete response. So we are here talking about patients who are metastatic disease naive treatment. Now, if we go further with previously treated patients with a number of 19 patients, that is a double from the patients who were systemic therapy naive, still we can see an amazing number with 79% of overall response rate. From this 79%, we have 74% that are expressing partial response, and we have 5.3% that are still in complete remission. And for the median durability of response over 18.4 months, the median follow-up was 17.5 months. We have 100% of durability of complete response. From those, 74% express partial response and 5.3 complete remission. So with this, I think we can have a new pathway and a new treatment that we can consider for those patients with metastatic thyroid cancer that are actually expressing the red fusion in non-medullary type cancer. The overall response rate and maximum change in tumor size as well.
Two minutes left, please.
Okay, I will go fast. So this is the previously treated red fusion positive patients. We can see this nice water plot that is expressing actually how much we have the treated red fusion positive cancer patients. Next, please. So this is the durability of response actually in previously treated patients with red fusion positive. Next, please. The Liberto 001 actually for medullary thyroid cancer efficacy as well is well established and seen. Next, please. So the phase 2 trial, including the same number as mentioned before, this slide has been already seen. Next, please. So the red mutant medullary thyroid cancer in Liberto 001 study has mentioned as well for the mutations, other mutations 18%, the red extracellular cystine 13%, and the red V804ML mutations 9%, and the red that is most important, as I mentioned before, the M918T mutation 16%. The characteristic of the patients for the patients who are expressing red alterations, whether prior treated by cabozantinib and vendatinib or whether the patients were naive treatment, we can see the characteristics are almost the same, males and females, echo performance stages. Patients who were treated with prior cabozantinib and vendatinib, the numbers are here. Patients naive treatment were 0, and prior multikinase inhibitor treatment, you can see the characteristic of the patients, and prior non-multikinase inhibitor systemic therapy were 17 against 9 for the vendatinib naive patients. Brain metastases as well were allowed. We have 4 patients for patients treated with the vendatinib and 2 patients for other criteria. Next, please. We have here as well the same as I mentioned for the non-medullary. We have the medullary patients expressing the red mutations in extraordinary numbers. The patients who were treated with cabozantinib, the overall response rate is 73%. The median duration of response over 22 months is 95%. Previously treated patients as well have an excellent response with 69 patients, with 69% for the overall response rate and 95% for durability of response. And the median durability of response is not reached yet. Next, please. So I will escape those slides, please. Next, please. So here we have the durability of response and free survival in prior treated patients with cabozantinib and vendatinib treated red mutant medullary thyroid cancer, just to show you that durability of response is there for a big number of patients, and the durability and sustained response started eventually from the 2nd month. Next, please. The prior cabozantinib and vondatinib patients, you can see here the nice water plot with the overall response rate, the complete response and partial response as well. The overall response rate was 66%. Next, please. The 1 year survival actually is expressed by a number of 86% of responder were ongoing in patients with medullary thyroid cancer previously treated with the first-line treatment with vondatinib and cabozantinib. Next, please. We're going to go fast, and here we are just facing the safety of Retivmo. We know, like, the criteria for the National Cancer Institute defines adverse reaction from 1 to 3 to 4 and 5, and those are very well known to all of us, so I will go fast, please. So the salpercatinib was shown to be generally tolerated in patients with non-small cell lung cancer, and we have mainly the expression of dry mouth, diarrhea, constipation with grade 1. We didn't see any of the grade 4 for all the patients for non-small cell lung cancer. Hypertension with grade 3 was seen in 17 patients, and fatigue and other side effects were expressed. We can just go fast here for the dosing of the salpercatinib that is well known with 160 milligram administered twice a day. There is no restrictions with the food, but it should be swallowed without being crushed, and salpercatinib can be taken without diarrhea restrictions. So the recommended dose modifications is very important to know. If there is intolerability grade 1 or 2, no actions required. But if we have intolerability that is 3 to 4, the dose can be de-escalated. And this is specifically for elevated liver enzymes, hypersensitivity, hypertension, or patients who are on CYP3/4 inhibitors. Next, please. So the molecular testing is recommended to identify the RET alterations. We have been through this in some of our meetings with guidelines recommendations for RET alterations. That is the CAP, that is used the CAP, IASL, and AAMP updated molecular testing. Recommended 2 options: comprehensive cancer panel, that is the EGFR ALK-ROS mutations, and the targeted testing. In this case, then expand panel containing the second category genes that are BRAF, MET, HER2, and RET for patients who are suitable candidate for clinical trials. The ESMO precision guidelines working recommended that all tumors or plasma samples from patients with advanced non-small cell lung cancer profiling using NGS technology is ordered to detect level 1 alterations. The ESMO clinical practice guidelines as well recommend examination of fine needle aspiration tissue for molecular alterations specifically associated with malignancies like BRAF mutations and RET fusions and other novel alterations. All patients with medullary thyroid cancer should benefit and offered genetic counseling and be screened for germline RET mutations. Next, please.
Sonia, we have to finish in 1 minute, please.
Yes. So, yep. So I will just emphasize for next generation sequencing to be accurate and tissue sufficient method to test the RET alterations and other targeted biomarkers. Next, please. The testing for methods for RET fusion in non-small cell lung cancer and non-medullary thyroid cancer are well known at the NGS, FISH, and reverse transcription. The most efficacy one is the next generation sequencing. Next, please. The RET testing as well, tissue requirement for RET is as described for medullary thyroid cancer. We need the tissue actually, and liquid biopsy might be considered as well. For the RET mutations, germline RET testing requires blood samples, and testing for somatic RET mutations can be performed with the FFFP tumor samples. Next, please. In summary, so the salpercatinib targeted treatment approved in UAE specifically for patients with certain RET-driven cancers. Salpercatinib indications is for adult patients with metastatic RET fusion positive non-small cell lung cancer, adult and pediatric patients more than 12 years of age and older with advanced or metastatic RET mutant medullary thyroid cancer who required systemic therapy, adult and pediatric patients more than 12 years old and with advanced RET fusion positive thyroid cancer who required systemic therapy and who are radioactive iodine refractory, and indication is approved under accelerated approval based on overall response rate and duration sustained response, and this is continued approval for this indication might be contingent upon verifications and descriptions of clinical benefit in confirmatory trials. With that, I think this is have been showed the overall response rate and the complete response rate for the patients, whether they are advanced rate mutant or fusion for certain kind of thyroid. And we can see here something that is amazing, 79% overall response for the patients who are advanced metastatic red fusion positive, and 69% overall response rate, median durability not yet achieved. And with that, I thank you, and I apologize for taking more than my time.
No problem. Thank you, Dr. Sonia, and thank you to Lily for the pre-Congress symposium. That concludes our pre-Congress symposium. And thank you to Dr. Sonia once again. We will move swiftly on, and I will do some very brief housekeeping before we start the official opening for day 2. I'd like to welcome everybody. My name is Gerard Moore, the support manager for today's conference. If you didn't join us yesterday, you missed an excellent show. We had over 1,000 registered and 500 plus live attendees, and we're expecting we have around that logged on already today. So we're expecting a very engaging and insightful day today. This event has been accredited for 9 CME hours. And if you want to submit a question, you can see on the right hand side of your screen there is a submit a question box, and that will go through to the moderators who will put them to the speakers on your behalf. If you have any technical issues, you will see a yellow digital man in the bottom corner. If you click on that, that will take you directly through to our tech support team to answer any technical questions that you may have. You'll also see a networking button there. You can click on that and message any guests or speakers that are live one-on-one direct messaging. That concludes my housekeeping notes. I will now hand over to Dr. Eiman Seddeeqi. If you weren't here yesterday, I will just read a brief bio of Dr. Eiman. She's a staff endocrinologist at SKMC in Abu Dhabi and assistant professor at UAE University. She's the president-elect of the Arab Thyroid Association, and she has completed internal medicine residency programs and fellowship programs in endocrinology at the University of Toronto in Canada. She's board certified in internal medicine from the United States and Canada, and she has an endocrine fellowship certified from the USA and Canada. Dr. Eiman, the floor is yours for day 2.
Thanks, Gerard, and good day, everyone. I'd like to thank our organizer and my colleagues, ENT team members, for making yesterday a great interaction. Today, we begin day 2 with an exciting program as well. We shall begin our first lecture, which is a surgical lecture by an eminent speaker, Dr. Tufano. Dr. Tufano is a professor in the Department of Otolaryngology, Head and Neck Surgery at the Johns Hopkins University School of Medicine. Dr. Tufano is an active board member of the American Thyroid Association. He was the recent past chair of the American Academy of Otolaryngology's Endocrine Surgery Committee. His research interest is revolving around clinical outcomes in the transoral thyroid and the parathyroid surgery. Dr. Tufano currently is a director of the Sarasota Memorial Healthcare System, which is a multidisciplinary system of the Head and Neck Endocrine Center that will consist of a dedicated thyroid and parathyroid center serving patients with these conditions. Please welcome me, Dr. Tufano, and the floor is yours.
Thank you very much. Can everybody see the screen here? Can anybody hear me?
Yes, the screen is clear.
All right, thank you. I'll share my screen there and then use this to get the speaker presentation. All right, very good. Well, thank you for the kind introduction. It is a pleasure to be here with you all. It's the morning here in the USA. So I'm happy to share my thoughts on thyroidectomy, the essential elements necessary for achieving optimal outcomes. I want to thank the organizers for inviting me, and I was very happy for the invitation. So this will be a very practical talk because we need practicality and we need to intervene for our patients in the best way possible to get the best outcomes possible. So I hope that you will take some pearls from this. And then later during the panel session, I hope to be available to answer any questions as it relates to this specific area and whatever else I'm presenting on. So the areas that we're going to cover today are preserving the external branch of the superior laryngeal nerve function, which I think is very important if you endeavor to treat patients, especially our speakers who are, in the public eye, or even singers, but even the general population. This is very, very important for people to go on about their daily activities. Of course, preserving the recurrent laryngeal nerve function. We'll cover parathyroid preservation and some of the newer techniques. I know later on, Dr. Randolph will be speaking a little bit more about the details of autofluorescence, but we'll talk about practical management surgically, and then maybe just a little bit about autofluorescence as a complement. Management of the nerve, especially at Barry's ligament, the recurrent laryngeal nerve. I think that this is an area where I see too much variability. And unfortunately, if we have a recurrence there, it's very problematic. So we need to deal with it appropriately at the first surgery. This is incredibly important. And then I will opine a little bit on central neck dissection as it relates to treating, of course, thyroid cancer, and the importance of making sure that if you are surprised by nodal disease in the central neck, or even if you know there's nodal disease prior to your surgery, that you're going to perform a comprehensive dissection to reduce the risk of recurrence. That's very important. So I often call the external branch of the superior laryngeal nerve the neglected nerve. When I was in training, I was told that all you need to do is just stay on the superior pole capsule and you'll be fine. I have often heard from a number of surgeons that, yes, that is the way that they were trained to do it as well. So I call it neglected because we spend so much time talking on the recurrent laryngeal nerve and how to protect the recurrent laryngeal nerve during our surgery, but this seems to get passed over. And I think that we know in our own surgeries, and especially as you do more and more surgeries, that this nerve has a very variable course. And in fact, we cannot just rely on staying on the superior pole to protect the nerve. We also can't just discount that this is only important for singers and public speakers, because we know that this nerve does cause problems with regard to daily activities, getting tired toward the end of the day, actually not being able to do things with inflection of your voice to emphasize your voice. And of course, the history of this is emphasized by Emilita Galli-Curci, who is an Italian operatic soprano. Of course, there's not so clear as to whether this was the exact cause of her loss of her singing career, but nonetheless, at least this nerve got attention finally as something that should be considered when we're doing thyroid surgery. We tend to think that if we preserve the recurrent laryngeal nerve and it's functioning beautifully, and we see a vocal fold moving after surgery in a very rudimentary way with flexible fiber optic laryngoscopy, for example, we're doing pretty good. But I can tell you that the patients who have an external branch injury are complaining. They have symptoms. You have to ask them. Sometimes they'll provide it, but if you don't care to ask, you won't know sometimes. So they can be hoarse, they can have a breathy voice, they can have increased throat clearing. This is very common, in fact. The vocal fatigue that I described before at the end of the day, especially, and of course, some of the things that we can tend to think of anyway is a decreased vocal frequency range and the issues with pitch. So I think one of the things we have to talk about is identification of this nerve, at least on every thyroidectomy, being considerate about the possible course of this nerve. And so this is a nice study done by Friedman, who looked at the external branch superior laryngeal nerve preservation, and he was able to identify it in 85% of the cases via a retrograde dissection from the entry point into the area of the cricothyroid muscle. Now we know that there's very different variations as far as how the nerve courses. The external branch can run superficially to the inferior constrictor muscle. And quite frankly, this is the most common variant. So if you start to see the inferior constrictor muscle, you can bet that within a millimeter or two, you're probably going to find that the external branch running in a parallel course to those fibers. So just right in this area, you'll start to find it If you see that sleeve of the constrictor right there, that is going to be a warning sign that you are very close. And obviously that anatomy varies on patient to patient. And sometimes if you're not able to see the actual insertion of the nerve into the cricothyroid muscle, or you see it at its very distal portion, that's because it can pierce the inferior constrictor. So one of the things you can do in that circumstance is really go ahead and make sure that you're retracting underneath the sternothyroid muscle. And if you're doing that, you can actually try to find it near the inferior constrictor. And if you're utilizing nerve monitoring, you certainly can stimulate in that area at about 0.5 to 1 milliamp away from the cricothyroid muscle, so you're not fooled by a contraction of direct stimulation of the muscle, but a far enough away that you know that you're stimulating this area of the entry point. And that's another nice way to figure out if you are in that situation. And then finally, this is the third variant where it runs very deep to the constrictor early on in the passage. And so this still is not necessarily protected. You don't know if this is the case when you're doing your surgery. And I think that dissection that I was talking about, by retracting that sternothyroid muscle gently superiorly, looking at the cricothyroid muscle, defining its fascial edge, and then looking for the nerve insertion point, or looking for the constrictor muscle, or using your nerve stimulator, or a combination of all of that, will endeavor and help you to be as good as possible at protecting that nerve. We know that nerve can, well, this is the ideal situation, and this is probably why we were taught this, is that that nerve can be very far away from the superior pole. It also can course within 1 centimeter, or it can run behind or just adjacent to the capsule. And I think one of the things that we see here is that, especially with the work done by Cernea to define the schemes here for the possible courses and the classification, that if we have a goiter, if we have a very large superior pole or a goitrous thyroid, then we're going to run into more problems with these kinds of scenarios. But again, even in the most routine of cases, and maybe the most routine of superior poles without any nodularity, a high projecting superior pole can also get us into trouble in these kinds of situations. This is not an uncommon scenario for us to identify intraoperatively. And as I was performing surgery very early in my career, I realized that this was something that, even though I was told by people I highly respected and very much were dear to me, that I wouldn't be able to just trust this dissection along the superior capsule, that this nerve had to be looked for, it had to be identified, and you had to make sure that you are going to find it to protect it. Just like the recurrent nerve. If we talk about finding that nerve all the time, and it's the best way to protect it, hands down, then why don't we do that for the external branch? And I think some of this has been very much defined by my dear friend Claudio Cernea in Brazil. He looked at this situation, and when he looked at this, he had a randomized study where you probably can't do this much of anymore, but identification in the EBSLM conferred with the nerve stimulator, no ID in dissection by the resident, and no ID by the surgeon performing number 1. And you can see the results there, that if you are not identifying that nerve, you are definitely going to run into problems. And this is what I was telling you before. I think that this combination really allows you to be as good as possible. That means the identification and the nerve stimulator away from the cricothyroid muscle allows you to do the best you can. So the practical approaches to preserving the external branch is look for the nerve when developing the plane between the gland and the cricothyroid muscle, that is the Joel space, and making sure that you see that nerve maybe entering the cricothyroid muscle. Look along the superior pole when retracting the sternothyroid muscle superiorly. If it's not visible, and if you're near the inferior constrictor muscle, you can stimulate in that area as you proceed before you take down any of those vessels. And I think that that's important, especially because we start to use more and more the thermal ligation technologies that are available. And so we know the heat emanates from those instruments, and we have to be careful about understanding the thermal profile. So knowing where the nerve is, again, will help you to better manipulate. Now, the inferior nerve or the recurrent laryngeal nerve, we talked about this and we said, of course, everybody knows that the best way to protect the nerve is really to identify it. And it's really quite remarkable that even amongst surgeons who do a lot of this surgery, there's sometimes a discussion of just basically finding it maybe at the nerve insertion point, or maybe just staying on the thyroid capsule. And I think that that is fraught with risk because we certainly know the variation of the branching and the arborization of the nerve. And all of us could talk about a scenario where we thought the nerve was not going to be in an area and it was. So I don't think that we can trust that implicitly. So routine identification of the nerve, even in my study where we were looking at this and examining everybody with laryngoscopy before and after the surgery, and this was all comers, we saw that our true incidence of having a transient vocal fold paresis was about 2.7%, and a permanent vocal fold paralysis, obviously in a teaching institution, is 0.2%. And this was over 10,000, if I remember correctly, nerves at risk. If you don't identify the nerve, then you know that this is much higher. And I can tell you, though, a lot of the literature, unfortunately, is very limited because it's relying on voice. And we all know that a voice after surgery can be pretty good and the vocal fold can still have motion impairment. So this is just another plea for if you really want to truly study the incidence of vocal fold motion impairment after your surgeries, which I think you should be doing to know your own rates, to discuss with your patients, you need to do a flexible fiber optic laryngoscopy at a minimum to look at the vocal fold motion. I think that's very important. Again, there's still a lot of debate on nerve monitoring. And it's funny that you see all around the world that nerve monitoring gets used most by high volume surgeons, not the low volume surgeons, where you would think that the low volume surgeons would find this as a help. But maybe it is not used because it's too maybe confounding. It's hard to appreciate actually what the nerve monitoring is telling you. It may be actually at a high volume level of expertise where there's value added, which is quite remarkable if you kind of think of it, because if you're building something to protect something, you want it for the people who are going to need it most. So anyway, I would say that, you know, nerve monitoring does help in these categories, and it certainly is going to help prognosticate postoperative vocal fold motion. And I think it does aid in neural dissection. I think that we have some very challenging cases. I'm not going to beat my chest and say, I don't need nerve monitoring. Oh, come on, I know where the nerve is. That's ridiculous. And that kind of surgeon I don't want to go to, actually. I want to go to a surgeon who's open-minded and is going to use complementary information. It's like when you're flying a plane, the weather's nice, you don't need the radar, but when there's the storm, the radar is nice to have. And that's important. So I think that we should consider how we implement nerve monitoring in a very cost-effective way, especially as it relates to our society. I think still there are less and less of these opponents, but still they're saying, you know, it's a reliance on technology, it's an additional cost. It really doesn't prevent you from hurting the nerve permanently. We're never going to get a study that's going to show this, right? So if you're waiting for that study, you're never going to implement nerve monitoring. And I do think that many have already demonstrated that the process of neural identification, confirmation, neural mapping, prognostication of postoperative neural function, helping to understand where you may have had an injury to the nerve, and also what has become more into vogue here and people talking about as well is that maybe you change your path. Like if you were going to perform a total thyroidectomy and, for example, you have a nerve that loses its signal, then you would say, do I really have to perform that contralateral lobectomy and put both sides at risk for the dreaded bilateral vocal fold paralysis? And I think that kind of information is helpful in making decisions that are going to achieve the best overall outcome for the patient. So what about intermittent versus continuous nerve monitoring? And I think that that's something that we have seen more and more of a discussion. I'm going to cover that in just a second, and there'll be some pros and cons. But I do think that where nerve monitoring is especially helpful is as we're working at the Barry's ligament, as we're stretching the thyroid and we're stretching the nerve possibly, that this is where we most often lose signal or even have a direct injury to the nerve. And most of the time in this study by Chang, who's in Taiwan, showed that out of the 16 signals lost at 173 nerves at risk, 12 were due to stretching and 5 regained signal before closing the wound. Why was that? Maybe because you have that stretch injury occurring, but it's not complete just yet. And so you're able to then alter your strategy, release that stretch or traction, and then that nerve function starts to return. And any of you who've used nerve monitoring in this way have been able to demonstrate that if I stop for a little while and maybe about 5 minutes and be patient, I will see the amplitude start to increase yet again. And I think that gives you valuable information in monitoring and also altering your approach. These nerves, as you know, the more you do, the more you see them in peculiar places and with more branching. Who knows why? This would be adherent to a small bleb cystic nodule, but now you have to dissect through the capsule, more trouble. Okay, big, horrible thyroid cancer, also this nerve running very close to the insertion point. You want to get all of this out. You got to know where the nerve is. It's so tiny. Boy, why did they make humans this way, right? You're asking during the surgery. And then what about the early arborization here? A nerve that you would find maybe a fellow or even the resident in your training program that says, yeah, I found the nerve. I don't know why it's not stimulating. It's because this is branched all the way down near the innominate artery. So that kind of valuable information, when you know that that nerve monitor is working perfectly and you've troubleshooted this, you go, well, that can't be the nerve then. It just can't. That can't be the motor branch, I would say. So what about the concept of continuous nerve monitoring? And I think that this is something that has a lot of advantages, but yet may be difficult, even more so than just routine nerve monitoring for many surgeons. And I think it's just a different level of technology and implementation. I can tell you personally, I don't use it. The reason I don't use it is because it gets a little bit too complicated to have that wire and the electrode get in the way. I make very small incisions. I do a lot of endoscopic work, so there's no real role for it in that situation. And sometimes I think it really just is too problematic. But I would say that in this recent study by Schneider et al., that there is demonstration that, in fact, what I was talking about before, trying to prevent that vocal fold paralysis temporarily, that by stretch, that it works. So the superiority of continuous over intermittent intraoperative nerve monitoring in vocal fold and preventing vocal fold palsy is pretty obvious. Continuous intraoperative nerve monitoring led to a 1.7-fold reduction in early postoperative vocal fold paralysis relative to intermittent. So fewer permanent vocal fold paralyses too with the continuous. So I think that this technology has to keep evolving. And I think what I would say is that it would be hopeful that as it evolves, you would see that it would be implemented more. I would love to be able to use this technology, but right now it just doesn't fit in what I do and for my operating room. And I also use intermittent nerve monitoring quite often as I'm stimulating after every move. So if I see a reduction in the amplitude from the stretch at the Barry's ligament, for example, then I know I need to change my retraction or my course. If you look at this and specifically the early postoperative vocal fold paralysis, 1.8-fold, and also permanent vocal fold paralysis, 29.4-fold. So the continuous independently reduced the issues there. I think the future challenges are, how do we use this technology with smaller incisions and remote access? And especially as we're going toward directed interventions like RFA, can we marry this technology and those kinds of considerations? I think it's very interesting. Now, if we look at an area where I think people are very uncomfortable, it would be the situation of dissecting the nerve all the way out into the insertion point, and that is to allow facilitation of clearance of Barry's ligament. And I'm not talking about in every thyroid surgery, but if you have a medullary thyroid cancer where you know the C cells are on the posterior aspect of the nerve, or if you have a very invasive papillary thyroid cancer and a tumor at the posterior medial capsule, you have to know how to wrestle with this area. Because if you're going to leave a little thyroid tissue behind, there's a higher risk of recurrence. And if you're going to leave a little gross disease behind in the hopes that radioactive iodine is going to take care of it, it's just not going to work. And then either you or somebody else will have to take care of the problem, which is always harder the second time. So obviously, this is the area at highest risk of injury. It's also the source of elevated serum thyroid globulin, which confounds surveillance of papillary thyroid cancer, and also may be a driving force to administer radioactive iodine in a low-risk papillary thyroid cancer that doesn't really need it, just to ablate the remnant. And then I think that this makes it more difficult to follow the patient just in general. And again, when we're dealing with medullary thyroid cancer, that is a different animal. You cannot leave a whole bunch of thyroid tissue at Barry's ligament. This is a mindset change. You have to shift gears. It's a different process. It's one thing to leave a little bit of thyroid remnant on the side contralateral to a thyroid cancer. You know there's no cancer there. If you want to do that to protect the nerve, by all means, go ahead. But medullary is a different animal. And I think that we see that these recommendations probably will continue to change. I'm an author on the next iteration of the American Thyroid Association guidelines, which hopefully will be coming out either later this year or early 2023. But I think what we see here is that since we are recommending radioactive iodine less, it's going to be our responsibility to do a more thorough surgery, and especially because not all endocrinologists feel comfortable with a small detectable thyroid globulin level, even in a patient who has a low-risk thyroid cancer. And so I think that we have to be very cognizant of this issue, because we're going to see a lot of patients where we're considering not using radioactive iodine. And if we're leaving a significant amount of thyroid tissue behind and the endocrinologist sees that there's still a significant thyroid globulin level, then at that point in time, the patient's going to get radioactive iodine regardless. What about central neck reoperation and how it relates to this? And so as I continue to move on in my career and do more and more of these cases, what it becomes very apparent is that we are not worried about nodal metastases in the central compartment. Any reoperation for central compartment nodal metastases, I think that the high volume surgeons and very experienced surgeons can do very, very safely as it relates to nerve function. But really what is most problematic is not the nodal recurrence. It is the tumor that is left at the Barry's ligament, that thyroid remnant intimately associated with the trachea and the esophagus, that intimately associates with the nerve. So when you're doing a reoperation, that area is incredibly challenging. You know that these patients are radioactive iodine refractory because they already got radioactive iodine, almost all of them. And so then you have to do your due diligence to clear it. Otherwise, your next step is possibly external beam radiation therapy. Or if they recur in the future, you're starting to resect trachea and larynx. So what do you have to do is a more comprehensive clearance, which often can result in injury to the recurrent laryngeal nerve. So that's why I really make a plea that when you're dealing with more aggressive thyroid cancer and you're dealing with medullary thyroid cancer, is to do your best to manage that Barry's ligament and go ahead and understand that you can work with a bipolar, microbipolar, you can work with a fine tip dissector, you can work with a 15 blade, and you can work with a variety of instruments to even mobilize that nerve away from a dense Barry's ligament or even tumor in that area. It's just going to take extra time. You can't be afraid of the nerve, even if the nerve actually loses its signal. As long as it's intact, we will hope that we will at least have significant tone to that thyroid retinoid muscle and the PCA muscle, so that that would allow for voice to be good. I mean, the nerve and the vocal fold may not work, or there may be significant motion impairment, but again, we can't count that it's always going to return completely the function. So follow the nerve all the way to the insertion point on these cases. And I think, you should do that on almost every case to know exactly where it is. Knowing where it is very helpful. Seeing is believing. Separate the nerve from the thyroid and or Barry's ligament. You can coagulate those bridging vessels crossing over the nerve into Barry's ligament. Bipolar cautery, microbipolar, you can get very close to the recurrent laryngeal nerve. You can take a cottonoid, you can take a Kittner dissector, anything you want to cover the nerve and mobilize it posteriorly and then you can do your due diligence in getting out all of that. So again, some of the tips that I'll give you, if you don't know where the nerve is, that's a problem. So if you don't see it, don't cut. When you perform the pretracheal dissection, always know where the trachea anterior face is. That's your good border and also landmark. Beware of the non-recurrent laryngeal nerve on the right. If you use nerve monitoring, very easy to. If you stimulate, okay, low and you don't get a signal, go higher toward the thyroid cartilage. If you're at the level of the thyroid cartilage and then you get a signal, then you know that you may have a non-recurrent nerve. Watch the nerve as you retract. Ventral delivery is risky until you see the nerve. Always keep the nerve under direct visual control. The anterior arch of the cricoid cartilage in the midline is another superb landmark. Bipolar cautery in areas where the nerve should be, when you're near the nerve, should be applied with caution. So very, very short bursts of the energy for bipolar cautery, not to leave it on and move in that area, leave it in one area. If the distal nerve looks thin, go back down and redissect to exclude early branching, and consider use of periodic stimulation if you're using nerve monitoring at a minimum to see if you have a change in your amplitude. Obviously, you see what I talked about with continuous monitoring. Parathyroid preservation. I think that this is actually very problematic. And I think that this is more of a cause of morbidity than sometimes even the recurrent laryngeal nerve. And there's studies out there that have shown that. You have to have a thorough knowledge of embryology and anatomy, meticulous surgical dissection, ensuring capsule ligation of vessels, and especially branches of the inferior thyroid artery. And if you have a compromised or inadvertently removed parathyroid gland, you should automatically think about autotransplantation. Understanding the relationship of the glands to the recurrent laryngeal nerve. This is a really nice picture that shows intraoperatively a patient with a papillary thyroid cancer, lymph node metastasis, recurrent laryngeal nerve running over the inferior thyroid artery, but the relationship of the superior gland that's on posterior to the recurrent nerve and the inferior gland that's anterior to the recurrent nerve. So this is very important to make sure you understand. One thing that I often see, whether I'm training the residents or the fellows, is that there's this concept of, I see the parathyroid gland, if I just stay on the capsule, I'll be fine. And oftentimes the inferior parathyroid gland, when it's on the capsule, even if you think you mobilize it and kept the blood supply intact, the blood supply usually comes from a cranial caudal area, and it's in the capsule itself. It's very hard to preserve that blood supply without appreciating this concept. So be very mindful of that. You can't just say, oh, I see it, I'm just going to come along the capsule, I'll be fine. Invariably, that blood supply gets compromised. So again, gentle dissection off the thyroid capsule. Try to avoid heat as much as possible. And if necessary to divide the vessels there, you can use a clips or fine bipolar cautery. You also may leave a small cuff of thyroid tissue with the superior parathyroid gland. Even if you're doing a thyroid cancer surgery on the side away from the index cancer, if you can do that with a little bit of thyroid tissue, at least for the superior gland, so be it. You always want to inspect your surgical field and the specimen. And this used to be something that would come with the skill of the surgeon. Now we have autofluorescence, and Dr. Randolph will be talking about that a little bit later. And I think it's a very nice complement to help augment whether, your eyes, to see if you had any retained parathyroid tissue in the thyroid within the capsule. Now, I think that when you first start in this field, you want to make sure that whatever you autotransplant is going to be, in fact, parathyroid tissue and not a lymph node metastasis or not something else that you don't want to reimplant. And so take a small amount of that parathyroid tissue for frozen section to confirm. And of course, now with autofluorescence technology, you can even just make sure that it has the significant autofluorescence characteristics that make you think that this is absolutely parathyroid tissue. But that's an evolution in practice. I think we still have to go with the basics until we prove further. Hard to tell which one of these is going to be the gland that's compromised versus normal functioning. This is venous congestion. This has no arterial blood supply. I'm not even sure about this one at the end of the day. So what can we do to do better? And I think that we know that this near infrared fluorescence technology is coming and it will become more refined. It's already here. The problem is that we can identify the parathyroid glands, but it's very hard to understand whether they still are in fact viable. The autofluorescence profile doesn't change. That's intrinsic to the tissue. So the issue here is that with the camera-based technology, I have to do an ICGO, indocyanine green injection, to then determine blood flow. And does blood flow necessarily correlate with parathyroid viability? What are you seeing exactly? This is very subjective. And the probe-based technology doesn't allow for any interpretation of viability. I do think, though, that in this really nice meta-analysis by Kim, that the diagnostic accuracy is a little higher in the probe-based technologies than in the image-based, that means the camera, but neither alone can assess perfusion. So I definitely think it's helpful to make sure that you know where the parathyroid glands are and that you're not extracting or removing parathyroid glands inadvertently. It would reduce that rate. I'm very confident of that, but I'm not sure still about viability assessment and that there's going to be any true difference in the immediate term on temporary hypopara. Possibly long-term permanent, we would think so. So again, these are good studies to know about, and I put them here for your convenience to read about them as well. Finally, we're going to get to central neck dissection. I have a few minutes left. This has been a real thorn in my side because I think that early on, there was a lot of recommendation for prophylactic central neck dissection for differentiated thyroid cancer, all comers. You got to be kidding me. We're at a point now where we're watching cancer. Who's talking about removing tiny lymph nodes that have no significance? But we realized that the literature had no standardization of the operation. So finally, we standardized that operation. We always include at least a prelaryngeal, easiest lymph node to remove in the neck with no consequence. I don't know why it doesn't get removed at every thyroid surgery. Recurrences here, I see 5 a year. It's embarrassing to the initial surgeon, A. B, sometimes if it grows and it grows into the cricothyroid membrane, then you have a more complicated process, but at least a prelaryngeal, pretracheal, and paratracheal component on one side. Let's remember, though, that when we're doing this operation, it's a little bit of a difference between both sides, too. And I will tell you that, remember, I just said I don't believe in prophylactic central neck dissection. I don't ever do prophylactic central neck dissection for differentiated thyroid cancer, low risk T1 and T2, when I trust my own ultrasound, which I do on every single patient, and I know I'm not going to miss meaningful disease. The embarrassment is that when we know there's meaningful disease, we see high recurrence rates because we're not doing a complete nodal dissection, whether it's in the central compartment or lateral. And that's because of this lack of standardization and appreciation for the boundaries of central neck. And when we have little tiny lymph node metastasis, which occur in a fair majority of patients, it doesn't affect survival, and the recurrence rates are only about 2 to 4%. So this is the data to support that. And there's some very nice studies that demonstrate that. Why are we worried about this? When we know there's disease there, we fail often, and that is on the surgeon. We're not relying on radioactive iodine to do that. So this is the low risk group, and this is what you typically see for patients with low risk papillary thyroid cancer, differentiated thyroid cancer, clinically N0, micrometastases, less than 5 small lymph nodes. These are the higher risk for recurrence. And so anytime I see a patient, I let them know that if they have these bigger lymph nodes, more than 5 lymph nodes greater than 3 centimeters, and extranodal extension, that are at higher risk for recurrence, and certainly good ultrasound is really important in their surveillance and follow-up. So I think that we need to have completeness of surgical dissection, especially when we have nodal disease. We need to do a formal compartmental neck dissection, and that's really important. So stop worrying about these tiny nodes that mean nothing. Prophylactic central neck dissection only hurts patients without gaining anything for them. But when you have disease there, you have to know how to perform a comprehensive central dissection. We know that there are lymph nodes both anterior and posterior on the right side. The most common area that I see recurrence in is posterior to the recurrent laryngeal nerve, because most surgeons only want to take a few anterior lymph nodes to the nerve in the paratracheal region. They don't touch these lymph nodes because they're afraid the nerve is going to stop functioning. I understand, but it's going to be even harder the second time around. You got to do it at the first surgery. This is a very complete central compartment dissection, feet here, head here. I doubt anything has a chance to recur in this central compartment with a highly aggressive tumor. Now, what you look here on the left side, actually you have the nerve running in a more cranial caudal course. This is the common carotid artery, the innominate vein. You can see the innominate artery coursing here, feet here, head here. And so this is more enveloped in its fascia, and we're able to keep this a little bit less of a dissection and manipulation of the nerve. Always gentle manipulation, no nerve hook is used, just moving it with a Kittner dissector or continoid. Remember, this compartment on the right has a three-dimensionality to it that allows for a consideration of the posterior component, and then the recurrent laryngeal nerve on the left. Most of that dissection is going to be over the top from the prevertebral fascia, esophageal muscularis, and over the trachea. So I think I kept on time. And so the summary here is that if you are going to endeavor to do great thyroid surgery is done by a lot of people, but there's very few who do it consistently well. You need to be devoted to improving your outcomes by honing your skills to establish a foundation just with your hands and your eyes, and then adding complementary technologies such as nerve monitoring and autofluorescence as it adds value. And I can tell you that expertise is a lifelong endeavor. Anybody who says, I'm the expert, I'm the best, I don't want to go to that surgeon, because every day we try to be better, no matter what level of experience you have, no matter where you are in your career. And when you stop, it's probably time to do something else, or certainly tell your family members not to go to that surgeon. So anyway, my pleasure to be with you this morning. And I hope you have a good rest of the day. I'll see you a little later as well.
That was an excellent, comprehensive, and explicit points delivered, Dr. Tufano. Thank you very much. Unfortunately, you won't be able to join the panel, but we'll be very happy.
I'll try my best.
Yeah. So that's great. If is it okay to circulate your email to delegates for any questions?
Of course. My pleasure.
Thank you very much. Thank you. We move on to our next talk, which is a pre-recorded talk by another eminent speaker. Dr. Elizabeth Pierce will be delivering a focused pre-recorded talk on Graves' disease in pregnancy. Dr. Pierce is a professor of medicine at Boston University School of Medicine. She is a former president of the American Thyroid Association. Currently, she's a deputy editor of the Journal of JCEM and has previously served as an associate editor for the journals of Thyroid, Clinical Thyroidology, and Endocrine Practice. Dr. Pierce is an ATA task force member of Guidelines on Pregnancy. She's the recipient of the American Thyroid Association's Van Meter Award in 2012. And that award was given for outstanding contributions to research on the thyroid gland. So let's enjoy the pre-recorded talk by Dr. Pierce.
Good evening. It's a pleasure to be with you. I want to discuss Graves' disease in women who are pregnant. I have nothing to disclose. And what I want to review today is first how we diagnose hyperthyroidism in pregnancy, how we interpret thyroid function tests and understand the etiology of hyperthyroidism in women during gestation. And then we'll review management considerations in pregnancy and also postpartum and preconception. Now, to start with, it's important to remember that when we're diagnosing hyperthyroidism in pregnancy, that we have to use thyroid in pregnancy specific thyroid function test reference ranges because the non-pregnancy reference ranges really do not apply in the pregnancy setting. One of the major drivers of change in thyroid function in early gestation is HCG. So recall that human chorionic gonadotrophin levels rise until about 10 weeks gestation and then decline again. And HCG stimulates the thyroidal TSH receptor. So when HCG levels are high, that will drive an increase in thyroid hormone production. That higher circulating thyroid hormone will feed back at the pituitary and cause a concomitant decline in serum TSH. So effectively in early pregnancy, when HCG is elevated, TSH will be a little bit low. And there's been some controversy over the years on how much of a shift occurs, probably not huge based on most recent evidence. And the current recommendations are that for most assays, you can take the lower level, the lower reference limit for TSH and reduce by about 0.4 to put your reference range in pregnancy for TSH, somewhere between about 0.1 and 4, at least in early gestation. Now, in assessing hyperthyroidism in pregnancy, of course, we need to look not just at TSH, but also at peripheral thyroid hormone. But this is fraught with some challenges. And because pregnancy increases circulating estrogen, which will substantially increase circulating thyroxine binding globulin, our free T4 assays tend to be confounded by that very high level of circulating TBG and tend just not to be very reliable in the pregnancy setting. So if you measure the serum from a single pregnant woman in a number of different free T4 assays, you may get quite different results. The assays are not very well harmonized with each other or with gold standard methods like equilibrium dialysis, and we don't have a great solution for this. If your lab still allows you to measure, rather than using a free T4 automated assay, to measure a free T4 index by measuring total T4, a measure of binding, and then calculating your free hormone, that actually does seem to be more reliable in the pregnancy setting, but recognize that a lot of labs have simply phased that out. Another workaround for assessing peripheral thyroid hormone in the gestation setting is to use total hormone, total T4 or total T3. And you can do this by effectively kind of constructing your own gestation-specific reference ranges, because we know that TBG levels, which drive increasing total thyroid hormone levels, will tend to increase in a pretty predictable and pretty linear fashion in early pregnancy. So TBG starts rising about week 7, it plateaus at week 16. And what you can do is to take your non-pregnancy reference ranges for total T3 or for total T4, to increase by 5% per week, starting at week 7 and ending at week 16, when you'll be at 150% of your non-pregnancy upper limit of normal. And you can continue to use that 150% of non-pregnancy upper limit for the duration of pregnancy. Now, in thinking about how to manage hyperthyroidism in pregnancy, we also need to pay attention to what does and does not cross the placenta from mother to fetus. Maternal TSH and HCG do not cross. Maternal thyroid hormone does in small but critical levels. But particularly important in thinking about Graves' disease in pregnancy, we know that the maternal TSH receptor stimulating antibody crosses the placenta, as do anti-thyroid drugs. And those entities can affect fetal thyroid function in the second half of pregnancy once the fetal thyroid starts to function. So we need to be careful about the reference ranges we use for defining hyperthyroidism in pregnancy. We also need to carefully determine the underlying etiology. Now, in general, in women of reproductive age, the most common cause of hyperthyroidism is always going to be Graves' disease. Other causes like autonomously functioning nodules in this age group tend to be much less likely. In early pregnancy, the most common cause of hyperthyroidism is not Graves' disease, but it's an entity that we know is gestational transient thyrotoxicosis, or GTT. And this is just really an exaggerated thyroidal response to HCG. So instead of getting just a transient increase in thyroid hormone production and a transient slight decline in TSH in early pregnancy, these are patients where HCG prompts true hyperthyroidism. Often this is seen in patients with higher HCG levels, like patients with twin or triplet pregnancies. Maybe this is seen in women with sort of more biologically potent HCG. And it's usually seen in women who have pretty significant nausea and vomiting, who may also really have hyperemesis. And that's because HCG, in addition to mediating these thyroid changes, is also the primary cause of nausea in pregnancy. Gestational transient thyrotoxicosis does not need anti-thyroid drug treatment because it gets better quite promptly as HCG levels come down. So typically we can provide some supportive care with antiemetics if needed, a short course of a pregnancy-safe beta blocker if there are severe hyperthyroid symptoms. But by and large, anti-thyroid drugs are not recommended, but in Graves' disease they might be. So it's important to try and distinguish between Graves and this gestational transient thyrotoxicosis entity. And we can do that using several different clinical clues. And the first, just want to always look on physical exam for stigmata of Graves' disease. If your patient has ophthalmopathy or a diffuse goiter with bruit, you know what they have and you don't need additional testing. Asking about the extent of nausea and vomiting is very helpful because it's really uncommon for women with gestational thyrotoxicosis not to report pretty significant emesis in pregnancy. The ratio of T3 to T4 may help a bit. It tends to be high in women with Graves' disease, as it outside the pregnancy setting as well, and a bit lower in women with gestational thyrotoxicosis, where the nausea and vomiting often sort of triggers some starvation type changes in thyroid functions and testing, and typically lower the T3 a little bit. And women with gestational transient thyrotoxicosis usually present with the concerns about the nausea and vomiting more than about concerns about hyperthyroid symptoms. But if you're not clear on clinical grounds, and sometimes you really just can't tell, the gold standard method for diagnosis these days is measurement of TSH receptor stimulating antibody. The assays we have for those antibodies these days are highly sensitive and specific and should be able to tell you which one this is. So once you've determined that a patient has Graves' disease, how do we manage? And the first thing is to do some peripheral thyroid hormone measurements to distinguish between subclinical hyperthyroidism from Graves' disease, where the TSH is low, but the peripheral thyroid hormones are normal, and overt hyperthyroidism, where the peripheral hormone is elevated above gestation-specific reference ranges with the low TSH. And the reason we want to be very careful to make that distinction is that we know from large cohort studies like this one led by Brian Casey that really subclinical hyperthyroidism in pregnancy does not appear to be associated with obstetric complications. So it is perfectly safe to simply observe that without therapy. However, overt hyperthyroidism from Graves' disease does need to be treated. Untreated, we know that there is increased risk for children with low birth rate due to intrauterine growth restriction. Women are increased risk for severe preeclampsia. There are higher rates of preterm delivery, pregnancy loss, stillbirth. Women can develop congestive heart failure, and women have been reported to develop thyroid storm at the time of delivery. So unequivocally, we do not want overt Graves' hyperthyroidism to go untreated in the gestation setting. The problem is, though, that we don't have an unequivocally safe anti-thyroid drug in early pregnancy during the period of organogenesis up to 10 weeks gestation. We have known since the 1970s that methimazole is teratogenic, but we only appreciated for the first time more recently with the publication of this Danish registry study in 2013 that PTU probably is also linked to birth defects. They cause different birth defects. So methimazole typically linked to anomalies of the digestive tract, the musculoskeletal system, sometimes to aplasia cutis, which is kind of an absence of a patch of scalp. PTU exposure in early pregnancy, though, is associated with children who may be born with anomalous cystic structures of the head and neck, or with anomalies of the urogenital tract, particularly in a male fetus. So these effects were seen in the Danish registry study, 800,000 mother-child pairs. You need really enormous data sets to see these effects because they're relatively rare. This has subsequently essentially been confirmed by an even larger registry study from Korea, looking at 2.9 million mother-child pairs. They saw the same types of birth defects associated with methimazole and PTU as has been seen in Denmark. The absolute risk in the Korean data set was a bit lower. So per 1,000 live births, in women who were exposed to PTU in early gestation, there'd be about 9 additional cases of fetal anomalies. For PTU, that number was about 17 per 1,000 live births. Unfortunately, in women who saw both anti-thyroid drugs in early pregnancy, the risk was also about 17, and those children were at risk for both sets of birth defects. So we don't want overt hyperthyroidism to be untreated in pregnancy. We also have reservations about use of anti-thyroid drugs in early gestation, and that has led really to a greater emphasis in the need for preconception counseling if the Graves' disease is actually known before somebody's actually pregnant. So I think it's important in our patients who are women of reproductive age who have a diagnosis of Graves' disease to have this conversation so that you're not kind of scrambling to make a game plan once she's already pregnant, but you sort of know how you're going to manage this. So I think it's important to discuss the risks associated with anti-thyroid drugs in early gestation. I think it's important to discuss the potential of using definitive therapy with either radioactive iodine or with thyroidectomy, in which case, if you do that prior to conception, there's not going to be any need for anti-thyroid drug exposure in early pregnancy. But those confer their own risks. Not every patient wants to, have to be on lifelong thyroid hormone replacement after definitive therapy. Thyroidectomy can rarely result in permanent, hypoparathyroidism, which isn't always so easy to manage in pregnancy. And women who get radioactive iodine need to wait a while before they become pregnant. We want them to wait at least 6 months before trying to conceive, partially because there may be a higher risk for congenital anomalies if women have that radioactive iodine exposure too close to conception, and also because it just takes a while for the radioactive iodine to work, and you want a woman to be on a stable dose of levothyroxine before she becomes pregnant. After thyroidectomy, you maybe don't need to wait quite as long, but you do, again, want to make sure she's on a good dose of levothyroxine and the TSH is optimized prior to her trying to conceive. And so patient age, how soon somebody wants to become pregnant play into this decision-making. Something else that should play into this decision-making is going to be maybe the baseline TSH receptor antibody titer. If that is very high in pregnant women, it can put the fetus and the neonate at risk for Graves' hyperthyroidism. And the different Graves treatment modalities have different effects on maternal TSH receptor antibody titers. So after initiation of anti-thyroid drug or after thyroidectomy, you can see that there is a decline in TSH receptor antibody titers. But after radioactive iodine treatment, those titers actually increase transiently. They'll be above baseline for about a year before they start coming down again, and then they tend to remain a bit more elevated. So in a patient where those titers at baseline are very high, I think that's another consideration in making decision about treatment. If a woman opts to continue on anti-thyroid drug therapy, it may be reasonable to switch her from methimazole to PTU preconception. So there's no methimazole exposure during early pregnancy, because certainly if you're going to have exposure to one or the other, the PTU is probably safer in early gestation. And this is a strategy that was outlined in the 2017 ATA guideline that has honestly not been prospectively validated to date. But this is a suggestion that in carefully selected patients, one might consider the anti-thyroid drug until that pregnancy test is positive and then immediately stop it. And the idea behind that is that often when you stop anti-thyroid drug in hyperthyroidism, you will get a period of time, maybe a few weeks before hyperthyroidism recurs if it's going to. So the idea is if you stop as soon as a woman knows she's pregnant and you buy her a few weeks of time before she needs anti-thyroid drug again, you might make it possible for her to get through most of the first trimester without actually needing treatment. Now, this is not for all patients because we don't want women to be profoundly hyperthyroid during pregnancy. It's not safe. So this is really just something to consider in those patients who you effectively think are already in remission but still on anti-thyroid drug. So these would be on women, in women who are on low doses of anti-thyroid drug, have really optimal thyroid function on those low doses, do not have big goiter, do not have high TSH receptor stimulating antibody titers. And if you're going to do this, it's important to monitor very closely, probably every week or two, at least initially, for with thyroid function testing, because what you don't want to do is to allow them to become overtly hyperthyroid and miss it. Now, if we're treating with anti-thyroid drug, again, PTU is going to be preferred through basically the first trimester during the period of organogenesis. Whether or not to switch back from PTU to methimazole after that is unclear. The argument for shifting back to methimazole is that PTU is associated with rare, but potentially lethal cases of fulminant hepatic failure, and that actually has been reported specifically in pregnant women. The problem with shifting back from PTU to methimazole, though, is that it's not a one-to-one dose conversion, and you run the risk of patients becoming transiently hyper or hypothyroid as you make that adjustment. So the ATA guideline doesn't really tell you what way to do this. In my own practice, I do tend to transition women back to methimazole. Just if nothing else, it's easier to take a once-a-day drug. But I think it's important if you do that to maintain pretty close monitoring of thyroid function across that transition. Also important, whichever anti-thyroid drug a patient is treated with, to make sure we are using the absolute lowest dose of that drug that we can get away with. And that's because pregnant women are less sensitive to the anti-thyroid drug than the fetus is. So if you treat a pregnant woman with enough anti-thyroid drug to drive her free T4 into the lower 2/3 of the normal reference range, a third of the time the fetus is going to be hypothyroid, because again, that fetal thyroid is more sensitive than the maternal thyroid. So therefore, the goal is to treat with the lowest possible dose to avoid fetal hypothyroidism. And that's going to be targeting therapy to a maternal free T4 that's at or even just a little bit above the upper limit of normal. We can't directly monitor fetal thyroid function without significant risk to the fetus. So we need to look for indirect clues to fetal thyroid function. And to do that, we need to collaborate with our maternal fetal medicine colleagues who can follow with fetal ultrasound in women who may be at risk. They can look for fetal goiter, which is shown here, which can be seen in either fetal hypo or hyperthyroidism. They can also look for delayed versus advanced bone age, and they can look for an elevated fetal heart rate. So tachycardia in a fetus is 160 beats per minute or higher when the fetus is at rest, not moving around. So those are all helpful to make this distinction. And the maternal TSH receptor stimulating antibody also can be very helpful as a clue. We don't want to forget our patients who look like this. So you can see from her scar that she's had a thyroidectomy. You can see from her eyes that her thyroidectomy was for Graves' disease. And here is her infant who was born with with neonatal Graves' disease. That it's important to remember that our patients who've had ablative therapy with radioactive iodine or with thyroidectomy can have TSH receptor stimulating antibody titers that stick around for years. And if they're high enough, they can cause fetal hyperthyroidism. And if you don't know to look for this, you're not going to have the patient on anti-thyroid drug because she won't be hyperthyroid anymore. So the fetus is going to see unopposed maternal antibody without anti-thyroid drug and be at particularly high risk. So the recommendation is that we should be doing TSH receptor antibody testing in our pregnant patients who have fetuses who might be at risk for hyperthyroidism. So that is any patient who has Graves' disease who's on anti-thyroid drug in pregnancy, or any patient with a history of Graves' disease who's had thyroidectomy or radioactive iodine ablation. We do not need to do this testing in patients with Graves' disease who are in remission and not on anti-thyroid drugs, because in those patients, if there's not enough TSH receptor stimulating antibody to stimulate the maternal thyroid, it's not going to be stimulating the fetal thyroid either. But in those patients who are at risk, the recommendation currently is to do that initial TSH receptor antibody test at the first antenatal visit. And if it's normal, or if it's at least lower than 3 times the upper limit of normal, we don't really need to worry about the risk for fetal and neonatal Graves. And these maternal antibody titers tend to decline as pregnancy progresses. So if those titers are low in early gestation, you're done. You don't need to repeat any testing. But if they're high in early gestation, it's recommended to repeat that testing around week 18 to 22, which is when the fetal thyroid is starting to function and starting to be at risk for the development of hyperthyroidism. And so if you see a TSH receptor antibody titer above 3 times upper limit, at that time point, important to alert maternal fetal medicine and sort of trigger that closer fetal ultrasound monitoring. And also to repeat the testing again about week 30 to 34 of gestation, at which point, high titers will sort of also alert us to the risk for neonatal hyperthyroidism, and where we may want to alert our neonatology colleagues about the potential for a child to be born with neonatal hyperthyroidism. Now, following delivery, it is safe to use anti-thyroid drugs at reasonable doses. This is true despite the fact that we know both of them are excreted in breast milk. Methimazole is excreted to a higher extent than PTU, but both of them at such tiny amounts that it is unlikely to shift infant thyroid function of the breastfed infant who's ingesting that breast milk. And in fact, we have a few small studies that have specifically looked at that and seen no effect on infant thyroid function. What you'd be most worried about in the period of rapid brain development in early life when this child is being breastfed would be adverse effects on thyroid function leading to adverse effects on cognitive development. This has not been very well studied, but there is one small study prospectively done in Iran by Faridun Azizi's group that suggested no effect of maternal anti-thyroid drug in lactation on child brain development. So the guidelines are, again, as always, use the lowest dose of anti-thyroid drug that you can get away with in lactation, but that it's probably safe for the breastfed infant to be using methimazole at doses up to 20 milligrams a day and PTU up to a total dose of 450 milligrams a day. And there's no need to do thyroid function testing in the breastfed infants. Just routine pediatric care with an eye to appropriate growth and development is enough. So I would conclude by noting that it's very important to use pregnancy-specific reference ranges in the interpretation of thyroid function tests in gestation, that the non-pregnancy reference ranges really don't apply, that when women develop hyperthyroidism for the first time in early pregnancy, it is very important to understand what the cause of their hyperthyroidism is, and the vast majority of the time it's going to be either Graves' disease or transient gestational thyrotoxicosis. If it's Graves' disease, it may need treatment with anti-thyroid drug, but if it's gestational transient thyrotoxicosis, it really does not. We can monitor thyroid function in those women, and we can just provide some supportive care. Because of the teratogenicity of anti-thyroid drugs in early gestation, and the importance of really optimizing thyroid hormone levels in pregnancy, preconception counseling is really critical in any patient with Graves' disease who is a woman of reproductive age who may at some point become pregnant, because again, you want to decide how you are going to manage the Graves' disease if pregnancy occurs before they're pregnant, preferably, rather than, once that pregnancy test is positive. And we may need to consider definitive therapy more seriously in patients where we're trying to really avoid any exposure to anti-thyroid drug in early gestation. But if we do need that anti-thyroid drug, preferable to use PTU rather than methimazole in early pregnancy, to always use the lowest dose you can get away with and to monitor thyroid function carefully. And again, in managing, Graves' disease in pregnant women, have to always be very mindful of the effects of your treatment, both on the mother's thyroid, but also on the effects on the fetus. And with that, I will thank you for your attention, and I believe we'll have time for some questions and answers during the panel discussion later on. Thank you.
Thank you, Professor Pierce. That was a very evidence-based talk. I'm sure we'll be having lots of questions related to this condition in pregnancy. Moving on, our eminent speaker, a very well-renowned speaker who has been joining us for our previous congresses, Professor Michael Tuttle. Professor Michael Tuttle is an endocrinologist and a professor of medicine and chief of the endocrinology service at Memorial Sloan Kettering's Cancer Center in New York. He has designed and validated the first real-time risk assessment model for thyroid cancer management, in which individual risk estimates are modified over time as a function of response to initial therapy. Of course, he has reached that stage after gaining lots of experience, vast majority of experience, not only in the United States, but across the world. His research continues to center on important management aspects of thyroid cancer, including efforts to better define the risk of recurrence and death from thyroid cancer, the role of active surveillance in properly selected patients with thyroid cancer, and the proper application of minimalistic management options to better tailor the intensity of therapy and follow up to the risk of undesirable outcomes. He has been serving a task force member of many guidelines of the American Thyroid Association. So let's enjoy, as we always do, the talk by Professor Tuttle.
Thank you very much. In this next session that we're going to cover, we're going to look at the new technologies of ablative therapy in the treatment of benign and malignant thyroid nodules. My only disclosure on this is we do have a research project with Alesta, which is a company from Italy, that's helping us learn how to do laser ablation of small thyroid cancers, giving us institutional support. We'll look at ablative therapy in thyroid disease, really starting with the background information on thermal ablation in benign nodules that's well recognized and been done for many years, but to give the ones of us that haven't used that as much sort of information about the ablation options that are out there, some of the potential risks and benefits. And then in the last part of the talk, we'll look at how we're starting to think about using this in differentiated thyroid cancer, because that's the new sort of quasi-experimental sort of new way that we're going, really with a focus on proper patient selection. So let's start with a real case, because all of this in my clinic is based on real patients. So this is a 56-year-old female. As often happens, she had a carotid ultrasound that was fine, but showed a little asymptomatic thyroid nodule. The ultrasound, just a 9-millimeter nodule that was very, very suspicious for thyroid cancer, and her local doctors decided to do a biopsy and confirmed it was papillary thyroid cancer. Now, she's very concerned about this cancer. She wants it destroyed, but she's really clear that she doesn't want a surgery. She would not even entertain active surveillance because in her understanding, it's a cancer, it needs to die. And she's seen 3 different surgeons. And the surgery she's asking for is just take the nodule out. Leave my thyroid behind. Why are you taking my entire thyroid out? I just want that small area destroyed. And then she heard at our place and other places that maybe we were using some of these thermal options to destroy these small thyroid cancers, and that was very appealing to her. So let's look at the information on thermal ablation and what's out there, and then at the very end of the case, we'll come back and I'll show you what we offered her. Now, this is a field that's changing dramatically. Up until the last few years, radio frequency ablation and laser ablation was something that I'd heard about really being used largely in Europe for big multinodular goiters. In the last 3 or 4 or 5 years, this technologies have really taken off here in the United States. Everything from alcohol ablation, where they're putting a little bit of alcohol into the thyroid cancer, to a variety of ways to basically heat the thyroid cancer with radio frequency or laser, microwaves, high intensity, HIFU, ultrasound. All of these are techniques that put heat specifically on the area. Now, it's important to recognize that interventional radiology in all different cancers has grown, and this is a picture of one of our interventional radiology units that looks like Star Trek in an operating room, where our radiologists routinely do these kind of procedures for prostate cancer and lung cancer and metastatic disease to the liver and you name it, brain metastasis. We're doing lots of this. And when we went to them and said, we want to think about doing thyroid cancer, they said, what, you want us to kill little things? Everybody else just wants us to kill big things. So they were totally on board with this. Now, one of the real things to understand is this truly is a localized treatment. It's just going to treat where we heat things up. In a benign nodule, it's going to make it shrink. In a thyroid cancer, it's going to treat just that small spot of thyroid cancer. Not going to treat the rest of the gland, not going to treat lymph node metastasis. This is truly a localized therapy. That we recognized with Dr. Hedges and Dr. Miyauchi really now a couple years ago that this field was really changing, and it was Laszlo that wrote this title that says thermal ablation of thyroid nodules, not if, but why, when, and how. And today we're going to really look at why and maybe a little bit of the when. Now, I'll point you to this reference, which I think is a real tour de force, largely led by Dr. Greg Randolph here in Boston. Lisa Orloff from California was one of the lead authors, but you can see most of the major groups around the world that are involved in laser ablation participated in this consensus statement that was really very, very well done. And there's lots of details in here about the procedure and how it's done. I'm going to give you the highlights of some of it just so that you're aware that it's out there. Now, clearly, most of the data that we have has come from radiofrequency ablation, a little less from laser, cystic nodules, largely the alcohol ablation, and then a little less data from microwave and HIFU, but all of the data is really confirmatory. And it shows that in the benign nodule ablation, and these are usually patients with big multinodular goiters, symptomatic nodules, they don't want a surgery, maybe they don't even need a surgery, it's been biopsied a couple of times, we know it's benign. Maybe this is our older patients that surgery would be dangerous or difficult, and all they really wanted was to shrink that nodule. And if you look at the average nodule shrink by about a year, it's about a 75% volume reduction. So that's a pretty substantial decrease, improving the nodule-related symptoms if they were having some fullness or cosmetic symptoms. And when compared with surgery, clearly fewer complications, you preserve the thyroid function, and sort of better quality of life. It's also been used to treat hot nodules, although probably not as effective as radioactive iodine in surgery, but there are patients that for whatever reason, we don't want to use radioactive iodine or surgery, and therefore using these techniques to kill a hot nodule, not our first choice, but possible. And so you'll see the first recommendation there is that ultrasound guided ablation procedures can be used as first-line alternative for surgeries in patients with benign nodules for compressive symptoms or cosmetic symptoms, and you can use it to destroy hot nodules, but sort of as a second or third line alternative. Now, the field that's rapidly been emerging has really been the use of it in thyroid cancer, because as always happens, if you can destroy something that's benign, we begin to think, can we use that technology in cancer? And we've spent the last sort of 10, probably 20 years with our colleagues in Japan really understanding that these small papillary thyroid cancers usually don't require an immediate surgery, and so the field of active surveillance has developed. But we all see patients that are unwilling for active surveillance, that yes, they understand you could watch this and they understand that it's small, but they're just not interested in that. They can't conceive that you would leave a cancer in their body for any reason, and they want it destroyed. Now, many patients want the whole thyroid taken out because they understand if there's one spot of thyroid cancer here, there may be other spots in the thyroid. That's fine. Other people just want half the thyroid. And then we've all met those patients, like my patient I started with. She doesn't want the thyroid out. She just wants that cancer killed. So in that group of patients, these are multiple papers now, nearly 2,000 patients and there's more published. I quit looking at this back in December of last year. Microwave, radiofrequency ablation, laser ablation, and you can see complete resolution of the ablation zone 90 to 100% of the time. And even when it's not completely ablated, what's left behind is usually just scar tissue. Recurrence in that ablation zone in the majority of studies is almost nothing. And the primary sort of complication is a transient voice change, probably from some pressure on the recurrent laryngeal nerve from the procedure. But to this point, everything has been described as transient. So with that background, it's probably not a surprise that the third recommendations that Dr. Orloff's group made was that the ultrasound procedure with ablation could be considered in patients with small papillary microcarcinomas, not really as first line, but if they were unfit for surgery, or they refused surgery, or they refused active surveillance. So we don't want to get in the business of lasering or radiofrequency ablation or microwave every one of these little small thyroid cancers across the world. The majority of these can be watched, but there are some either that the patients refuse to watch, or some of them that I'm watching that have grown from 8 to 10 millimeters. They're slowly growing over time. Well, then using this as a procedure to destroy them rather than continuing to watch is probably a reasonable alternative. Now, if you take it one step farther, we all have those patients that have had multiple recurrences in the neck. They've been operated on multiple times. They've had neck dissections multiple times. That every 4 or 5 years, there's just another little lymph node there. Now, the majority of these can be watched with active surveillance as we do, but again, some of them are growing. Some of them, the patients just want them destroyed. And so there are multiple sort of small reports of using ethanol to destroy these little lymph nodes, or lasers, or radiofrequency ablation. So this is less well worked out than the benign nodules, certainly, and the primary thyroid cancers, but it is on the things that we think about in those appropriate situations. Now, I don't think this replaces a well-done neck dissection, I doubt that I would do this in somebody that already hasn't had the lateral neck or the central neck cleaned out, because if you see one small lymph node, there's other lymph nodes in there. So we largely reserve this to situations where people have had prior comprehensive neck surgeries for the lymph nodes, and then there's still some left over. And so the third recommendation here is that in recurrent papillary, you can think about this, but again, unfit for surgery, decline surgery, or active surveillance. Now, as we began to think about how we would implement this, one of the things that we realized very early on, when we're trying to kill a benign nodule, and frankly, I don't have any experience with that at all. I don't treat benign nodules, but when I hear that colleagues talk about treating benign nodules, they're just trying to destroy the middle of the gland, the middle of the nodule, right? You don't have to kill the entire nodule. And we call 75% success shrinkage of a great big nodule terrific. That's great because you're shrinking it for cosmesis or for local symptoms. But when you're dealing with a thyroid cancer, you have to just kill the thyroid cancer and also a normal margin around it. This is well worked out in all the ablations of other tumors and other cancers around the body. Nobody just kills the cancer. They kill the cancer, and then depending on the cancer, a 2 millimeter, maybe 3 millimeter safety margin around that of normal tissue, so that you know for sure you've completely destroyed the thyroid cancer itself. And so you can see on this one, there's plenty of room between the cancer and that anterior nodule to have a safety zone without getting outside the thyroid. Alternatively, this little small tall cell variant of papillary thyroid cancer is invading the overlying strap muscles. This is not one that we're going to treat with radiofrequency ablation or lasers or microwaves, because the margin would be into the strap muscles. Now, that's not to say we would never make the decision in the future to do this, because I can imagine somebody that we would say, well, burn some strap muscle, we'll burn the thyroid, but I think that's getting way out there. So on ones like this, we'd say, no, you're not a good candidate to have the ablation. One of the things that's been sort of surprising to me is in all of the papillary thyroid cancers that I follow, they seem to be disproportionately in the subcapsular and near the capsular region. There are very few that are right in the middle of the thyroid lobe, and I don't understand why that is, but they tend to distribute around the capsule. And here, the three on the top, they're either touching or very close to the capsule anteriorly, which doesn't bother us too much, because if you have a little microscopic invasion anteriorly outside the capsule, well, that's really fibroadipose tissue and skeletal muscle, and the surgeons can get a complete gross resection of that. There's really nothing to hurt out there. On the other hand, if it's invading the posterior capsule or the medial aspect, there are important structures that run beside the thyroid. So when we're using these thermal ablations or alcohol ablations, we have to think about not only what are we destroying in the thyroid, but if we're near the edge of the thyroid, what are those structures that are running beside the thyroid? In the consensus statement, they described what's often been called this danger triangle. Right there in the TE groove, where the thyroid lobe sits right against the trachea in that bottom part, that's often where the recurrent laryngeal nerve runs. And then you see out farther to the left-hand side the vagus nerve. The vagus usually runs lateral to the carotid, so it's not usually a problem for us, but rarely it will run medial to the carotid. And so if you have an area of the thyroid tissue that's touching the outside tissue of the carotid there, you always have to worry that maybe there could be a vagus nerve running there. Now, our view of the danger triangle is a little bit broader than that. We differentiate based on the anatomy of the recurrent laryngeal nerves, where these nerves might be when we're selecting nodules on the posterior capsule or nodules that are toward the capsule near the trachea on either side. If we're selecting them to follow for active surveillance, we would be worried if the little nodule was on the capsule beside the nerve, certainly if we were going to do an ablation. So this picture for me helped understand that on that left-hand side, yes, it runs in the TE groove, the left recurrent laryngeal nerve, we know where that is. On the right-hand side, that nerve goes behind the thyroid on the right-hand side starting kind of halfway out on the thyroid at the lower pole and then moving more medial. So anything in that right lower pole on the posterior capsule, we're going to be very careful about and likely choose not to do an ablation on that. And you can see there the carotid arteries running lateral, the vagus nerve running lateral to the carotids, which is where they would normally be. But if that was running more medial, you could see how the thyroid could be involved or close to it. Now, one of the traditional well-established techniques in all of ablation and all different types of tumor is hydrodissection. This is very commonly used, often with a little bit of lidocaine, some normal saline, where they'll inject around the nodule itself or just outside the thyroid to get a heat barrier. This is a small one that we treated with laser a couple weeks ago. And you can see on that bottom picture with the needle in there, we're inside the nodule that's about to be destroyed with the laser, and we've got a nice hydrodissected area just outside that. And so recommendation 7 certainly recommends hydrodissection when it's appropriate, both to minimize discomfort, because a lot of the nerves in the thyroid are in the capsule, so hydrodissection with lidocaine helps numb that up, and also unintended thermal spread, sort of as a heat sink. If you look at how safe this is, I think you always have to compare this with thyroid surgery. So if you're thinking about doing an ablation, what's the risk of a lobectomy or the risk of total thyroidectomy? And I think in most papillary microcarcinomas, the appropriate sort of comparison is the risk for a lobectomy. Pretty small, mostly transient, so about 1.5% when they're doing thyroid nodules. A little higher if you're doing lymph nodes in the central compartment, which is what you would expect because you may be closer to the recurrent laryngeal nerve. There are other things in the neck to remember, particularly when we're getting outside the thyroid in lymph nodes or treating thyroid nodules that are sort of outside the traditional thyroid bed, including vagus and sympathetic chain, brachial plexus, phrenic nerve. So really understanding the three-dimensional anatomy beyond just the thyroid is really important in these. Tracheal necrosis, very rare that you would see that. You can always do hydrodissection or avoid those areas, the occasional nodule rupture, and then the occasional hematoma. So by and large, one of the other things that the consensus statement recommended is one of the advantages of doing these procedures under local anesthesia is that the patient can talk to you and you can find out if there's complications early on. Some of the groups do these procedures under conscious sedation. The advantage of that is the patient is very still and very comfortable and not moving. So depending on the person, depending on the technique, depending on lots of different aspects, many of these are done under local anesthesia, but some groups prefer the conscious sedation. Now, when we began to sort of think about active surveillance and we began to think about selecting nodules for observation and selecting nodules for thermal ablation, and in fact, selecting nodules for lobectomy. That's all minimalistic management approaches, and you guys are aware that we've written about what are the tumor characteristics, what are the patient characteristics, what are the medical team characteristics, and we've spent most of this talk talking about the tumor and the ultrasound characteristics. We've touched a couple times on patient characteristics because clearly there are some patients that do not want to watch. There are some patients that would never accept an ablation. So they certainly have to put their values in it. How much do they value their normal thyroid function? How much are they worried about surgery? How much are they worried about those complications? Do they want to take thyroid hormone pills? So all of those sort of go into their decision-making process. And I think for these ablation things in particular, the medical team characteristics are also really important. For us to decide for any individual patient, are they the ideal patient for minimalistic management? Are they appropriate, which means it's okay, or is this really the inappropriate patient? And they could be inappropriate because of the ultrasound findings. They could be inappropriate because of their personal preferences and risk and benefits. And they could be inappropriate because of the medical team. The consensus statement spent quite a few recommendations saying, look, this is not necessarily a simple procedure. Yes, it's easy to learn. Yes, the learning curve is fairly short. But this is not something you're going to watch on YouTube and then turn around and start doing in your clinic the next day. So advanced training, biopsies under already knowing how to do ultrasound guided biopsies. That makes you very sort of ready to go with this. Doing it under phantom models. At Memorial, we have a large animal lab that works out of interventional radiology. So we did 12 or 15 pigs with the entire human setup, it felt exactly the same. We just had an animal model that we could use that made us very comfortable before we did the first patient. And even then, we had experts that knew how to do it in the room with us, with my interventional radiologist, who was incredibly skilled, to make sure that everything went well. So with all that background, what should we offer this patient? I think she's the perfect patient to do a laser ablation or a radiofrequency ablation or a microwave ablation. Small nodule, not near the edge, right in the middle, not near any important structures, lots of normal tissue around it. We've got the facilities, we have the expertise, so we've got the medical team to do it. She's exactly the perfect patient to do it because she's rejecting surgery, she's rejecting active surveillance. So in her particular case, this was a wonderful option for her. So at the end of the day, I hope what I've given you a little flavor for is sort of how much this laser ablation for both benign thyroid nodules, possibly hyperfunctioning thyroid nodules, probably small volume thyroid cancers, and maybe even lymph node metastasis is really evolving into our daily care. I think the benign nodule is clearly well within standard of care. The papillary microcarcinomas are right on the borderline between standard of care and what should be done in a research project. And I think we still have to be careful with the lymph node metastasis. That's sort of borderline there. So at the end of the day, I think all of us are going to have to sort of think about when we're thinking about minimalistic management in these small thyroid cancers, in these benign nodules, which patients would be best served with something avoiding surgery and using a localized therapy as an alternative to treatment with surgery. Thanks very much.
That was an excellent talk as usual. So for the questions, if you guys have any questions, you will find the question box at the right bottom corner of the screen. So please type in your question and we will be sharing these questions with our expert during the panel discussion. Moving on to a pediatric topic with our eminent speaker who has joined us yesterday with marvelous interaction through the MDT discussion and the panel discussion. Professor Andrew Bower. He's a pediatric endocrinologist, a professor of pediatrics at the University of Pennsylvania, and the director of the Thyroid Center at the Children's Hospital of Philadelphia. Dr. Bowers has established a translational science research program to better define the molecular landscape of pediatric thyroid cancer. Dr. Bower and his team were selected as a CHOP Frontier program for their contributions to thyroid cancer literature. Dr. Bower has served as a medical consultant for the Thyroid Cancer Survivors Association and for the International DESIR-1 Registry. He is the chair of the American Thyroid Association Pediatric Thyroid Nodule and Thyroid Cancer Guidelines. So please welcome Dr. Bower on board and enjoy his talk.
Thank you very much for that kind introduction. So this is the topic that we're going to talk about for the next 25 minutes or so. So optimizing thyroid hormone replacement and suppression in patients with acquired hypothyroidism. So first, thank you, of course, to the steering committee and everyone helping to pull the conference together. I'm honored to be listed with the other eminent speakers, some of which are mentors, of course. And of course, thanks to the attendees. And I look forward to questions that you may have, because I think this is a topic that's very, very, important, but is a topic that needs more research, especially within pediatrics, and as well as in adults. These are my disclosures. So I do provide some consulting services to a company that makes a thyroid hormone and one that makes a thyroid mimetic. But I don't think either of those will make a big impact with what's in my talk today. So we're going to talk about thyroid hormone replacement. And I think the important part of just looking at the thyrocyte and what will be important as far as the talk, especially for thyroid hormone replacement, is to realize that besides all the mechanisms that are important with TSH binding to the receptor and increasing iodine absorption and thyroglobulin synthesis and thyroid hormone production, that there's a protein that's important for egress of thyroid hormone from the thyrocyte, that's MCT8. And when the thyrocyte is producing thyroid hormone, it produces it in a ratio of about 15 to 20 to 1 when we think about T4, the prohormone, to T3, the active hormone. As we know, in the periphery, T4 is converted from T4 to T3 by two different deiodinases, type 2, which is certainly more prominent as far as in normal health and development, which is expressed in the thyroid, heart, and brain, but also type 1 deiodinase, which seems to be preferentially activated in autoimmune hyperthyroidism in Graves' disease. We will not talk about type 3 deiodinase, which is important in converting T4 to reverse T3, so inactivating the prohormone T4. Once thyroid hormone enters the cell, it binds to nuclear receptors. And so there's an alpha and a beta receptor. These are preferentially expressed in different tissues. And we know clinically that patients can have mutations, typically autosomal dominant in inheritance, that are associated with resistance to thyroid hormone, with resistance to thyroid hormone beta being more common than RTH alpha, but both of them existing in clinical practice. The one thing to think about, and I think that is undergoing further study, are thyromimetics, and the current field within thyromimetics is really being led in trying to figure out how we can treat patients that have deficiencies in the ability of thyroid hormone to enter into cells. The most common of these uncommon disorders is MCT8 deficiency, known by the eponym of Allen-Herndon-Dudley syndrome. And we won't go into the details of it, but it's a terrible disease where centrally patients are hypothyroid and peripherally they're thyrotoxic, because MCT8 is important for T3 to enter the cells in the CNS, but peripherally T3 levels, which are elevated in these patients, enter into peripheral tissues and associated with hyperthyroidism symptoms. And where these thyromimetics are starting to be playing a factor, and I'm currently involved in an international study, is that these bypass these receptors. And so it may be an opportunity, it appears to be an opportunity to improve the health of patients with these syndromes, currently MCT8, but potentially resistance to thyroid hormone. And then we need to start thinking about if and how and when these types of thyromimetics might play a role in other diseases as well. So we're mostly going to focus on just typical replacement therapy. And within this context, we're going to look mostly at acquired hypothyroidism. And within that context, we're going to look mostly at acquired surgical hypothyroidism, not autoimmune hypothyroidism. So peripheral hypothyroidism typically associated with definitive surgical therapy for Graves' disease or for treatment of thyroid cancer. We're going to start just thinking about monitoring. All of us know this, of course, in primary thyroid disease, TFTs have high predictability as far as predicting what the patient is, what their status is, but they have to be interpreted, ordered first, and interpreted within the context of the patient, signs and symptoms, physical exam, iodine status, and if there's other medications that are impacting thyroid hormone absorption, as well as thyroid hormone testing. And unfortunately, all of us realize in clinical practice that thyroid testing is sometimes not within an appropriate clinical practice. And so people are always looking for reasons to think about the thyroid or blame the thyroid, as sometimes we say as endocrinologists, particularly for why weight is an issue and why patients are gaining weight despite efforts to watch their diet and to improve activity. And so within that context is a classic example of how do you interpret thyroid functions. And we know that in patients that are overweight, it's the weight that can move the TSH curve to the right. And oftentimes you'll find a TSH between 5 and 10. And if you can convince your patient or work with your patient to lose weight, their TSH will normalize. So when you send thyroid functions is critically important. And I think overweight and obesity are classic examples of that situation. When we also think about monitoring, and maybe things we don't pay as much attention that we should, is consistent time of day is important. So in relation to the dose, especially because we're going to talk about T3 dosing, that becomes important. T4 a little less so because it has a longer half-life. But if it's morning or night, and there's actually some diurnal pattern to TSH. So consistent time of day is important, especially when we're trying to fine-tune TSHs. And then other things that can impact absorption or lab assessment. And the classic one, which has been in the literature in the last couple of years, of course, is biotin, because high-dose biotin as a supplement, which is sold to help with hair and nail health, can cause pseudo hyperthyroidism. So it can falsely elevate the T3 and T4 and falsely lower the TSH depending on the assays. And so for patients that are taking this, I tell them, you can take it. I don't know if it helps or not, but you certainly need to stop taking it 48 to 72 hours before testing. And then there's less potential impact on interpretation of the thyroid function tests for that individual patient. There's many situations where thyroid testing can go wrong, and I list them here. We're not going to go through all of these, but when things don't make sense, sometimes it's the patient, and you worry about how they're taking their medicines and how frequently they're taking them and how consistently they're taking them. But there's definitely many opportunities besides biotin where there's assay interference. And so we always need to think about, it's not the patient's, not being compliant if their thyroid functions aren't as predicted based on, what treatment they're on, what their diagnosis is, and what we expect for results. But are there other things, especially in autoimmune thyroid disease, that might be interacting the assays? And oftentimes these can be heterophile antibodies that can give macro TSH or combined and can either falsely lower or falsely elevate other of the sandwich immunoassay testing that is typical of thyroid hormone analysis. There are papers that go through this. Again, I just list this as a reference. And so having these types of tables and figures somewhere in your clinical practice, I think, is also helpful to help figure out, when you have numbers that don't completely make sense, what's the differential diagnosis, looking at the T4, T3, and TSH to try to figure out what the potential confounding variables are for results that you did not expect. So treatment of hypothyroidism is what we're going to mostly spend the rest of the talk on, and kind of go through the history, where we started, where we are, and where we might be heading, or maybe should be heading. And so this started in the 1800s, and before we had synthetic T4, we had desiccated thyroid hormone replacement. So it was transplant of animal thyroid tissues, and then it was desiccated thyroid hormone. And the reality is most of this was, of course, combined therapy, because if you take out a thyroid, you're going to have both T3 and T4, as well as other forms of thyroid hormone. In the 1950s, the synthetic sodium salts of T3 and T4 were produced. And then in the 1960s and 70s, even though we had these synthetic hormones that are now being produced in the lab, it turns out that desiccated thyroid was still being prescribed more frequently. So 4 out of 5 patients in the 1960s and 70s were still on desiccated combined T3 and T4 therapy. And when we started, then in the 60s and 70s, what happened is there was improved testing for thyroid hormones. So the TSH radioimmunoassays were discovered, T3 and T4 assays in the early 70s, and people started to have more accurate measurement of thyroid hormone in patients being treated with desiccated thyroid hormone. And we realized that patients were kind of being overtreated, or at least overtreated in parentheses, because we may be undertreating some patients currently just on monotherapy. And so it turned out that the equivalent for some of these patients, when you looked at their thyroid function, was quite high compared to what we typically think of as LT4 monotherapy replacement or even suppressive dosing. We also realized, as the discovery by Braverman in the 1970 that T4 is converted, the prohormones converted to T3 by deiodinases, and the ability to test these things, that if you use desiccated thyroid, it's not better, because we have some patients that think it's organic and so it's better than synthetic. It's combined therapy, but the problem with it is that the ratio is different. And so pig thyroid ratio T4 to T3 is much higher. There's much more T3 in the desiccated forms of thyroid hormone than what we as people, as humans, produce, that 15 to 19 to 1 ratio. And if you use desiccated thyroid hormone, or if patients are prescribed desiccated thyroid hormone, they're being prescribed more T3 than T4. And it's also hard to adjust the dose because it's a single tablet. So in the 70s to 2000s, LT4 monotherapy has been and continues to be first-line therapy. The nice thing about LT4 monotherapy is that it has a long half-life, so 5 to 7 days. It can be taken once a day. If you miss a dose, you can double up. There's even been studied in adults, and we don't recommend it, that you can take it 1 day of the week and not take it for the next 6 days, and you get a small peak, but you can maintain your therapeutic levels. And so it has a very high safety profile, and it has predictable and stable manufacturing. When our patients ask us, and when we think about generic versus brand name, there's not much difference except for the reality of how the FDA defines bioequivalence. And this was established in the early 60s. And so the biggest difference between generic and brand name dosing is that brand name is a single manufacturer. If someone's prescribed Abbott, then they're on brand name and they're on a particular dose. And the likelihood of a difference between the same dose from that one manufacturer is 5%. But for generics, it can be up to 12% different between generic company A versus company B versus company C. And if you're prescribing generic, the pharmacy, depending on what the supply chain is, can provide any of the generics that are currently available. In practice, it becomes less of an issue because generics produce the supply chain has been stable, in 2022, despite what's happened in the last couple of years. And so for most patients that are picking up a generic form of thyroid hormone replacement from a particular pharmacy, the same generic company is being used by that pharmacy on a repeated basis. And so you just have to warn your patients if they're on generic that the dosing color is similar, right? All the colors are similar for LT4 therapy, but if the shape or the markings of the pill change, there may be a change in the generic company. They should let us know, and then you can repeat thyroid functions potentially a little earlier just to ensure that the dosing that you prescribed is the same between those two different tablets. Desiccated thyroid is not that it's not FDA approved, and I think it's gotten a bad rap. But the reality is it isn't as under the same stringency of quality assurance because it was brought to market before FDA defined bioequivalence. And so the two things that are difficult for desiccated is three things. The T3 ratio is the T3 amount is too high. It's a combined dose, so you can't individually alter the T4, the LT4 and the LT3. And 3, it may not be under the same stringency as far as quality assurance that is regulated by the FDA. So it still is an FDA prescribed marketable drug, but there are some things that make it difficult to use in clinical practice. And so this has been the pendulum, right? And that's the way medicine goes sometimes. We have a pendulum of what we did in the past, where we are now, but there's something hopefully in the middle where we're working towards. In pediatrics, when we think about LT4 monotherapy dosing, that is weight-based, and I just show a table here. This is available in many different references. And by the time patients are 16 years of age, we're on about equivalent dosing as far as replacing between pediatrics and adults, about 1.6, 1.7 micrograms per kilo per day. As I said, it's once daily. Morning or night is another discussion that we can have. Most patients are prescribed it in the morning, 30 to 60 minutes before breakfast, and avoiding calcium, iron, and soy. But in practice, if this is a daily medicine, I counsel my patients, and I have many patients that are on actually nighttime dosing. And that is certainly an option and oftentimes easier, especially for pediatric patients where there's sometimes chaos in the morning trying to get up and out and get to school. And so the goal for LT4 monotherapy for non-thyroid cancer patients where it's not suppressive is to normalize the TSH, but there are shortfalls to doing that. So we typically try to get the T4 in the upper range, in the upper half of the normal range, and the TSH in the mid to lower half of the normal range, but there certainly are problems. And most of this data that we have, again, it's an area that needs to be studied in pediatrics, is adult-based. So as people know that our adult attendees for this conference, 10 to 15% of our adult patients express dissatisfaction with LT4 only therapy. And they continue to complain about signs and symptoms of hypothyroidism. But as we discuss with our patients, these are very non-specific symptoms, signs and symptoms. And so it becomes difficult to figure out if it's the person, if it's the replacement, or if it's a combination of both. But it's not that it's not possible that we're not doing an adequate job with monotherapy. There's also confounding clinical variables. So you can read here, toxicity of non-thyroid therapy, and that's particularly important for patients that are, thyroid cancer patients that have many other confounding variables as far as their behavioral health and the stress and worry of being a cancer patient. Physical fatigue just from being overstressed and overworked, and all those things impact, of course, on signs and symptoms that cross over between hypothyroidism and just general life in 2022. But it's also possible, as I mentioned, that we're not doing an adequate job with monotherapy for every single patient. And the data that's come out from adults is actually quite interesting. And so this has been known for over a decade now, that if you take patients and you put them on LT4 monotherapy, not only will 10 to 15% still have signs and symptoms consistent with hypothyroidism, they'll actually have levels that are below the normal range. So 15% of patients will have a T3, the active form of the hormone, that's below the normal range if it's measured, despite having a free T4 that's above the upper end of the normal range. So there are patients that are not adequately deiodinating, converting the prohormone to the active hormone from T4 to T3. This has been also studied. This is a paper from Jackie Jonkless, looking at patients that have post-surgical hypothyroidism and looking at the ratio, the T4 to T3 ratio, and you can see T3 levels are lower, the ratio is higher on monotherapy after thyroidectomy. And so the question has come up, and there's been some studies to say, were patients better off being overtreated on desiccated, or at least some patients, versus monotherapy? Why some people don't adequately convert, I think there's a lot more investigation that needs to happen. But we do know that there are some patients that have single nucleotide polymorphisms that impact the efficiency to convert T4 to T3. And this has been studied and confirmed in a number of different papers now, but it's not really part of our clinical evaluation. So what's the best thyroid hormone replacement? Well, there are guidelines. I was fortunate to be involved in the ATA guidelines that were published in 2014 as one of the co-authors. And there is a pediatric specific recommendation that Chuck Sklar from Memorial Sloan published in 2018, looking at a specific group of patients, as you can see here, because Chuck has been actively involved in moving the field forward for cancer survivors. If we look at editorials looking at what about T4 and T3, or manuscripts looking at T4 and T3 replacement in adults, there's a number of them now, and there are more experts in this field and have gone through really lovely presentations and gone through what are the adequacy as far as the research design to interpret these studies. And there, again, is room for improvement on improved research design so that there's data that's a little bit more interpretable. But there's a long list and an increasing number of papers that are being published. If you look at the data looking at quality of life and neurocognitive function in patients on combined T4, T3 therapy, again, adults, 13 trials and only 2 that showed improvement, and for quality of life and neurocognitive function, 10 trials and 2 that are showing improvement. So these trials, which may not be adequately powered, haven't been completely supportive of combined therapy, but that still doesn't mean that some patients actually do better on combined therapy. And I think it's up to us to at least consider it and think about if an individual patient might benefit. What's been done in pediatrics is nothing. There's actually no studies in pediatrics. We're working on a paper right now looking at our patients that are post-thyroidectomy, both for Graves' disease and for thyroid cancer, mostly our papillary thyroid cancer patients. And what these bar graphs show is that despite our pediatric patients having high free T4s, most of the patients still have T3s in the lower end of the normal range, if not below. So a similar type of thing that Jackie Jonkless's paper showed in 2008, that's been shown in a number of patients. The same thing is true, and it makes sense. There's no reason why an adult would have different deiodinase activity, and so pediatric patients are at the same risk as adult patients to have 10 to 15% of our population not adequately treated as far as maintaining or achieving normal T3 on T4 monotherapy. So what's the best replacement? LT4 monotherapy. I don't think that's changing. I think that's true. And the majority of our patients will be adequately replaced on LT4 monotherapy. But I think it's incumbent on us to at least start looking at T3, not just in our hyperthyroidism patients, but on our hypothyroidism patients, whether it's congenital hypothyroidism or acquired hypothyroidism. So moving forward, there's an increasing effort to try to figure this out. There's now newer formulation of T3 that are being studied, and Tony Bianco has a couple of papers and actively involved in researching how to have a T3 formulation that doesn't require multi-day dosing. And so this is going to become a more discussed and more important and greater opportunities to incorporate T3 therapy into clinical practice. Tablets, generic versus brand name, I kind of talked about tablets versus solution. What we do know is that compounded forms are not adequate, and there's a nice review article in 2020 now. It's not stable in solution, and so they should not be used as far as compounded things, but there are commercially produced solutions now. And there may be some benefit, again, to not just thinking about tablets, but if patients aren't tolerating tablets, both gel caps and solutions have some advantage because it doesn't require the same gastric pH. They're already in a solution in a form that allows greater and more rapid absorption. So again, most patients do fine on LT4 monotherapy tablets, but there are some patients where gel cap solution would be a better form for them and for instance, less impacted by food and other things that can decrease absorption. When do we think about using T3? Well, in my practice, this is when I think about it. So if they're on full T4 replacement and I measure their T3 and it's low and the TSH is either normal or inappropriately normal or elevated, or just not at the target that I want it to be at, I'll think about T3 therapy. So it's not a lot of patients, but I do have patients that I prescribe LT3 therapy. Why? LT3 is still not a great single day dosing. So if you use it, you do have to separate it into 2, if not 3 times a day dosing. And these curves, the blue curves, just show you when you ingest combined T4, T3, you'll have a peak in your T3 that then wanes over time. And if you don't have a second dose later in the day, the TSH actually can elevate it. And in contrast, the red graphs show that T4, because of it has longer half-life, 5 to 7 days rather than hours, you can maintain a therapeutic level longer and you have a more predictable TSH as far as maintaining the TSH in your target range as well. So T3, if you're going to use it, is best used as a 2, if not 3 times a day medication. We typically start with 2 because if you go to 3 times a day, compliance obviously decreases. As I mentioned earlier, desiccated is not the greatest. It's better to use separate LT4 and LT3 tablets because the wrong ratio and because you can't easily adjust a combined tablet. And so there are some patients that I have, I'm going to be honest, that are on desiccated, whether they convinced me that I had to prescribe it or more commonly that they were prescribed by somebody else, and then we're adding other medicine to it because they won't stop their desiccated thyroid hormone replacement. So just to end, in the last slide is how to incorporate LT3 if you're on LT4 only dosing. So we typically decrease the LT4 dose by 12.5 to 25 micrograms, and then we'll add liothyronine LT3 5 to 10 micrograms twice a day and try to then get our targets, whatever those be, if it's just thyroid hormone replacement for a post-thyroidectomy Graves patient, or if it's a thyroid cancer patient where we're trying to keep the TSH lower, try to get the TSH, T4, and T3 into the target range for that particular patient based on their particular diagnosis. So with that, I'll end, and I'm really looking forward to see if other people have other ideas about if T3 therapy is being used in clinical practice, if you think it's quackery, or if you think it's actually a good thing that we should be thinking about. But I think in 2022, this is a topic that we can't continue to ignore. Our patients are bringing these ideas to us, and there are increasing data to show that there may be benefit for a subgroup of patients, and greater opportunity as far as new formulations of T3 that are on the horizon that may allow for single day dosing. So with that, I'll end and look forward to questions during our question opportunity. Thank you.
Thank you very much, Dr. Andrew Bauer there. As he mentioned, he'll be joining for the panel at the end of day 2. In the interest of time, we will move swiftly on to the Congress Symposium now, sponsored by Horizon. The title is New Era, in management of thyroid eye disease. And we're delighted to be joined by Dr. Raymond Douglas, who is a board-certified aesthetic reconstructive and oculoplastic surgeon. He's a thyroid eye disease specialist and cosmetic restoration expert. He's AKA the Eye Guy. He's also an anti-inflammatory lifestyle author and a key authority in this subject. Dr. Raymond has sent an extensive and impressive bio, but in the interest of time, I would just pick out a few parts. He's experienced board-certified aesthetic and reconstructive oculoplastic specialist. He graduated with distinction from the University of Pennsylvania, and he has completed a subspecialized fellowship in orbital facial plastic and reconstructive surgery at the UCLA Jules Stein Eye Institute. And he has held several prestigious positions in the UCLA School of Medicine, Harbor UCLA Medicine Center, the Greater Los Angeles Veterans Hospital, the Veterans Admin Ann Arbor Healthcare System, and the University of Michigan Kellogg Eye Center. He's a clinical research author, advocate, and educator, internationally recognized for his groundbreaking research on treatments and restorative surgical techniques for thyroid eye disease. He's published more than 100 peer-reviewed articles and textbook chapters, and a special interest in thyroid eye disease, and lectures extensively internationally and nationally. You can find his website, drraymonddouglasmd.com, on Instagram at drraymonddouglas, and I'm sure he will now give a very insightful and exciting Congress sponsored by Horizon. So Dr. Raymond, the floor is yours.
Thank you so much, and please let me know if there's any problems hearing me. It's my pleasure to be presenting to this group. Certainly know that it's quite a prestigious group to be involved with. And what I'm going to be presenting today is a new era in treatment of thyroid eye disease. And really, it's the explanation of what has been going on in thyroid eye disease, and also kind of an understanding of the new therapies. I do have financial disclosure in that I'm a consultant for a variety of companies that are looking for treatments for this disease, including Horizon Pharma. So the first thing to really look at is the faces of thyroid eye disease. And that is how diverse these patients really are. And when we think about it, you know, this disease attacks the thyroid, but also attacks the tissue around the eyes. And it does so in very different ways. And you can kind of see this as evident in these patient photos. And so one of the real questions is, how do we distill this heterogeneous disease process down into its fundamental molecular mechanisms? And first of all, we know that this is most commonly associated with Graves' disease. And at 80% of thyroid eye disease develops within about 18 months of that Graves' disease diagnosis. Most of my patients are female. And I'm sure everyone in this group has seen someone with thyroid eye disease, but it is quite variable. One of the hallmarks is eyelid retraction, which occurs in about 90% of patients, but also there's proptosis, infiltration of the extraocular muscles causing strabismus, double vision, but also in some patients, about 70%, a profound inflammatory reaction, but in 30%, almost no inflammatory reaction. But so the heterogeneity can be quite profound, but the tenets are usually eye bulging and proptosis, eyelid retraction, and strabismus. So when we think of this disease, the first thing to do is to turn to the anatomy. And here we can see that the eye is surrounded by the extraocular muscles, the adipose tissue around that area also. And it appears that the fibroblasts, and we'll present some data about this in a bit, are attacked in this disease, and specific receptors on those cells, and cause expansion, both of the cellular constituents, but also of the extracellular matrix constituents. And this also leads to, in some cases, profound inflammation and expansion of these tissues within that bony confine of the orbit. Overall, as far as patients, the disease follows a rather predictable course in the vast majority of patients, which is also rather unusual for an autoimmune process. It starts off as an active or progressive phase where there is actually movement and progression of the eye disease and eye bulging, including double vision, potentially inflammatory processes, and even in some cases, profound vision loss. And this typically then goes to a more chronic phase, or what becomes an inactive phase, where the disease doesn't change, but those manifestations don't go away. They may improve slightly, but they tend not to go away. And this has often been considered the surgical area of disease, but we'll talk a little bit today of how the underpinnings of the disease may be quite similar throughout all stages. So in the natural history of disease, we've thought of an ideal therapy early in this disease phase, during this progressive active phase. And in the past, that's largely been steroids, some biologics, including rituximab that we worked with quite a few years ago, tocilizumab. But what we're seeing is that by thinking of this more as a continuum and targeting the orbital fibroblasts or the periorbital fibroblasts, we can start to really open up the therapeutic window of what might be possible. And I'll talk a little bit more about that and some of the data and what we've seen. The first step is to now dive into the pathogenesis. And I showed this slide before, but I really want to come back to it. It really is important to think about how can we delineate the common molecular mechanisms that could interrupt this process. And I think of this as a tree. I was in Europe one time speaking to a group, and putting all this heterogeneity together is almost like a tree. It has many different branches, and those branches may look a little different, but they have a common trunk. And one of the things we're looking for is the common molecular mechanism that could interrupt that process. And that has led us to look at the insulin-like growth factor 1 receptor. This receptor, with my colleague, Terry Smith, who was my mentor for many years at UCLA and still quite a close friend, introduced me to this idea of the overexpression. And for 15 years, worked to delineate the overexpression of this receptor and its signaling on the orbital fibroblasts and other cells that are composed in this disease, including immune cells, but also cells that might be migratory to the actual inflammatory process. And what we found is that these cells all overexpress IGF-1 receptor in the disease process. And in fact, the signaling in the immune cells and what happens upon signaling, at least in vitro, very much mimics what could happen in the pathologic findings. And there appears to be some antibodies to these receptors, or even autocrine production of the IGF-1 molecule itself. What's really, I think fascinating about this is that we never had a mouse model or a human model to investigate these findings, but we'll see how we advanced very much into human therapy with some of these background findings. So just to reiterate, the overexpression of the IGF-1 receptor appears to be a hallmark on many different types of cells, including CD3 T cells, B cells, and orbital fibroblasts. And we published this way back in Journal of Immunology in 2007, which seems like a lifetime ago at this point. These cells are not only more frequently in Graves' disease, but they're also restricted to Graves' disease. In fact, we looked at every twin in Denmark and found that only the twin with Graves' disease had overexpression of these molecules, where the twin without Graves' disease did not. And this also bears true in ulcerative colitis and rheumatoid arthritis, where that overexpression is not apparent. So this is not a universal phenomenon. Well, one of the biggest questions was, well, how does this fit in with the TSH receptor? I mean, we know that the TSH receptor is profoundly important in this disease, but how could two receptors be important, and why is there heterogeneity between thyroid dysfunction and orbital manifestations, et cetera? Well, it turns out that these two receptors are intimately associated, actually physically associated and functionally associated on the surface of cells, including orbital fibroblasts, but also thyroid. Turns out that the IGF-1 receptor is grossly overexpressed in orbital fibroblasts with scant TSH receptor, and the exact opposite is true in the thyroid. So it's the connection of these two receptors, probably the immune system recognizing both of them in many cases, that really seems to be the most important. So here's the mechanism with orbital fibroblasts fundamentally sitting at the center and then causing a variety of these issues. This is kind of summarized in the New England Journal summary, where really overexpression and activation of the IGF-1 receptor appears to be most profound. So let's look at conventional versus novel treatment. Now, treatment for thyroid eye disease, as we discussed, has really been confined to short-term treatment, chemosis, redness, and that has been largely with steroids. And we'll look at the effect of steroids and the usefulness. But we also know that the long-term consequences are really what is most significant in this disease. And that's where we see lid retraction, proptosis, double vision. These are the manifestations that patients are left with for a lifetime. And we'll start with conventional treatments. So what conventional treatments exist? Well, the Yoga recommended steroid regimen has been useful for many, many years. It's an IV glucocorticoid therapy of at least in various doses of at least 4.5 grams of methylprednisone divided over 12 times, 12-week infusions. Various combinations have been used of this, etc. And it is helpful at reducing some of the inflammatory signs and symptoms. However, what it doesn't do is it doesn't reduce the proptosis and the double vision. And despite being looked at in all those studies, it just doesn't reduce those. We put together a compendium in JAMA Ophthalmology not long ago, looking at the response to steroids, also placebo response in moderate to severe thyroid eye disease as a meta-analysis, kind of looking at some of those papers and seeing, does it really have a long-term effect? Well, it turns out that these are the studies that, used that steroid regimen and had baseline proptosis measurements and were well conducted. You can also see that steroids at that period of time do have a substantial number of adverse events. But these were at least studies that were over a period of time that was reasonable. The patients were well characterized. And what we found was that the proptosis changed in each of those studies was a little bit variable. But taken together, the mean change of proptosis, even as early as 12 weeks, which is very early in this process and should be seeing some type of an effect, was pretty much negligible at 0.75 millimeters. And for people who are not familiar with ophthalmology studies, at least 2 millimeters or more would really need to be clinically significant or comparable to any type of surgery or to really be identified. In fact, our measurement tool is plus or minus 1 millimeter. So what we're seeing is even across the board of these studies have been published over 15 years, very negligible results for the use of steroids as far as proptosis. This is just another way of looking at these studies, just looking from paper, the pooled estimates for IV methylprednisolone. And here's looking at it for diplopia. And one of the things I think is most important is diplopia is hard to measure. It's hard to measure for ophthalmologists, much less endocrinologists. So there are scales of looking at degrees of double vision from 0 to 3. And you need at least 1 point change to notice the difference. And what we're seeing here is that there's really negligible change, all less than 1 unit in the double vision. And so what we can see is that the glucocorticoids really have very little effect as a long-term, for long-term improvement for these patients, despite, having a side effect profile that for this group, I certainly do not have to explain that it can be very difficult. So the bottom line is that steroids really don't reverse the underlying alterations of orbital tissue. They may be a good Band-Aid for a while, reduce some of the symptoms, but that does come with a trade-off of side effects. Now, rituximab was also used for a period of time. In fact, I published some papers on that also. And what we found is that it probably is fairly useful at eliminating or limiting the inflammatory response temporarily But what we also see is that, and you can see in some of these studies, these aren't nearly as well controlled just because of the nature of the studies. But in the studies that were well controlled, there was really no significant change that was seen in the proptosis or the double vision. Tocilizumab has been a relative recent entry into the field. And it's interesting because most of our basic science data looked at IL-6 is a prominent player early in this disease process. And so a few studies were conducted with this molecule which inhibits the IL-6 receptor. And these were primarily, at least initially, non-randomized studies, but then a randomized study. And it showed mild effects, and it may be limited much more into the early phase of this group. And it's been hard to replicate any long-term improvement of proptosis or double vision. Again, appears primarily on that early phase of the inflammatory response. So it leads to rethinking of the process. And Terry Smith and I have spent a lot of time in thinking about, well, if you're going to retarget, maybe the immune system is not the right target. We've inhibited all the B cells with rituximab. We've inhibited IL-6. I haven't even presented some of the studies that have just been pounding at the immune system with very little benefit. So maybe it's time to rethink this and target the antigen that might be the target of the immune system, and maybe driving the metabolism of the fibroblasts that could be involved here. And I think that's a different way of thinking about this, as far as this receptor may be driving the overproduction and the metabolism of these orbital fibroblasts. And so it led back to the insulin-like growth factor 1 receptor for all the reasons that I very briefly outlined here, but there's about 50 or 60 papers that go into this. Now, the mechanism of action of inhibiting the IGF-1 receptor really has been around for a period of time. It was actually first thought of in cancer, a variety of other mechanisms because of the overexpression of this receptor. But teprotumumab emerged as a potential because it's a fully human monoclonal antibody and it inhibits the IGF-1 receptor signal. So it's targeted binding to the IGF-1, one receptor, but it also inhibits the IGF-1 TSHR signaling complex, which I think is going to be very important mechanistically as we discern the details here. And by doing that, it appears that this could, at least when we were thinking about this initially, turn off signaling at the disease source. If overexpression of the IGF-1 receptor and increased signaling is the problem in an ultra simplistic way, well, maybe turning that down, turning that off would reduce that. In vitro data, which we've spent a lot of time looking at, would suggest that. But there's nothing like the human experiment. We didn't have a mouse. There is no mouse or animal model that's applicable here. But the idea was that if you can turn that receptor off, can you prevent the inflammation, the excessive cell growth, and the hyaluronan buildup in these cells that specifically overexpress the receptor to very high levels? Well, the idea in acute thyroid eye disease appears to be pretty straightforward, just as I've outlined. Well, we've seen an orbital fibroblast that has all these downstream manifestations. And if you turn this receptor off in vitro, we found that you could inhibit all these downstream manifestations, such as increased hyaluronic acid, inflammatory cytokines, etc. Now, what was interesting, and early on I thought this would be true, but I couldn't convince anyone, is that in chronic disease, you still see overexpression of the IGF-1 receptor. And you've probably come to some metabolic stable point of stability for these cells individually, but it's at an increased turnover of their metabolism. So if you would inhibit the IGF-1 receptor, could you then in patients who've had this disease for a long time have a reset of their hyaluronan turnover, et cetera, which turns over about every 7 days, and decrease their disease process too? That certainly no one was willing to buy in to a while ago, but it certainly seems to be true as far as moving forward. And then the question that's inherent in here is, well, does it reset the disease, or as soon as you remove that inhibition, does the disease come right back? And surprisingly, it appears to reset the disease, which I don't think we quite understand why it does that yet. So the first study that was done was a phase 2 initially, then phase 3, which I'll demonstrate here. Both were published in the New England Journal of Medicine. The phase 3, which was almost identical to the phase 2, I outlined as far as how that was done. It was active patients with active disease, meaning early onset disease, patients that everyone would agree that they would likely treat with steroids or be very concerned with treatment. Increased activity, clinical activity score, et cetera. And they were all euthyroid, at least by gross parameters. Teprotumumab and placebo were given as in a blinded fashion, double-blinded manner, and it was a treatment course of 24 weeks. And then patients were assessed at week 24 for reduction of proptosis. Now, this criteria had never been met before, so we were hopeful, but it really had to be something that was significant and change the long-term course of disease to be something we felt that would be useful. So proptosis as at least 2 millimeters was felt to be the minimal criteria endpoint at week 24. So the summary of the results were very positive in that the primary outcome of proptosis responders was much greater in teprotumumab than placebo. I'll show you that data. And that all secondary endpoints, we also looked at overall responder rates, the reduction of inflammation, patients who had improved double vision, et cetera. And those were also improved. Here's a patient who had placebo, and you can see not much change. In fact, maybe even a little bit worse over that period of time, but it gives you a flavor of the severity of patients that were treated. Here's a patient that was treated from the original article in the New England Journal in 2020 with teprotumumab. You can see dramatic reduction. In fact, this person was progressing toward optic neuropathy, had quit their job, and had a 6 millimeter reduction in their proptosis. And it was significant and early on, as you will see, patients respond usually rather quickly to this medication. Here you can see the clinical activity score reductions. And remember, this is a kind of a parallel to disease activity. You can see very early on, as early as week 6, with just 2 infusions, that there is an improvement of the clinical activity score. You see this both in placebo and in teprotumumab. Teprotumumab is the lower graph here, because the disease tends to improve as far as the inflammatory over time. Remember, it comes to that stable phase. What was really surprising to us was the proptosis response and the magnitude of that occurred early. So what we're looking at here are proptosis responders. Remember the number of the percent of patients who get to at least 2 millimeters of improvement. You can see as early as 2 infusions, these patients at week 6 are over 56% are achieving that result, and then that continues to improve over time. It appears to plateau in both studies about 80 to 85%. This is an intent to treat analysis, so any patient dropout for any reason is considered a non-responder. The magnitude, and so you can see the difference. Now, the magnitude of response didn't just stop at 2 millimeters. It continued to improve, actually, and you can see here is compiled to about 3.5 millimeters over this period of study over week 24. And the patients with more severe disease had a bigger improvement. So if you started off worse, you actually had well over 4 millimeters improvement in this disease process. This patient here had 6 millimeters improvement in the proptosis. And as you can see, about 0.5 millimeter improvement with placebo, almost identical to what we saw in those earlier steroid studies. Here are the MRI data, and we've spent a lot of time with MRI and CT data now, looking at volumetric measurements and seeing what changes behind the orbit, not just proptosis. In this small study, these were patients where we had pre and post scans and did 3D volumetric analysis of all the extraocular muscles and fat compartments. And what we found was that both the fat volume and the muscle volume decreased in these patients after treatment with teprotumumab. And you can see that it was quite significant. and correlated to the volumetric reduction and the millimeter reduction that we see in proptosis. So double vision, this is one of the most difficult things sometimes for patients to tolerate, and also one of the most difficult things to treat. Never has been really improved with any medical therapy in the past. This is a responder rate, again, of patients using a 0 to 3 point scale, just because it's a multi-center trial using this diplopia score. One of the things we again saw is an early improvement in the double vision, anywhere from 50, then improving to about 68% of patients had improvement of double vision over a period of time. Patients tend in placebo to also improve. It tends to also plateau. This doesn't go on forever. It tends to plateau after week 24 to about 25%. And we also saw quality of life improvement. And I think this was most interesting for patients because it's often underappreciated of how this really impacts patients. Patients can't go outside. Their eyes hurt, they burn, they don't want to be seen in public. It really disrupts their social interactions in so many different ways. In fact, some studies have placed it the same social impact as breast cancer for these, in as far as altering their lives. And here we can see certainly an improvement, both various subsets of the quality of life for these patients. Nothing is complete without talking about safety. And so overall, this drug was well tolerated with mild to moderate adverse events that appeared to go away or were largely diminishing after treatment. And we have much more data now after infusing this for about 2 years that agrees with these early adverse events from the clinical trials. Muscle spasms, alopecia, but just mild hair thinning, nausea and fatigue were the most common. Now, a couple to point out, one was hearing issues. Hearing issues kind of has emerged more recently. It wasn't seen as to about 10%, and it forms in 2 different ways. One is where patients will hear autophony, hear their own voice. This appears to be eustachian tube fat pad shrinking, and that 100% appears to come back. And then other patients who seem to be a bit older may notice a little decrease in their hearing, and that also appears to be significantly improved once stopping the medication. It can exacerbate diabetes, but that appears to be relatively mild. In the clinical trials, it was pretty well controlled and patients just adjusted either diet or medications. It is certainly something we monitor, but it certainly appears to be mild, at least in comparison to treatment with steroids. And then finally, inflammatory bowel disease is a watch out for this because it can exacerbate that condition, and these patients were excluded in the trial. So the response also appears to be durable, and that's one of the things that I mentioned early on, is that, well, how durable? Are we resetting things, or is it just going to work as long as you're on the drug? Well, it appears to be durable, 28, 60 weeks after initiation, which is, being off the drug for quite a period of time, seems to have a high rate of proptosis responders, well in the upper 80%, and with 95% still having inactive disease. And this was published in Lancet Diabetes Endocrinology. That was kind of the overview of this, but you can certainly see the composite and scores in proptosis and double vision remain high even at 60 weeks and a year after treatment. So as we start to think about characterization of this disease, we now know that early in this disease process, we have a potential therapy. Now, we also have been really looking at patients who've had this disease for many years because the overexpression of the IGF-1 receptor continues to be present. And we've looked at this very specifically in tissue samples, and both active and chronic still have a very high overexpression of this receptor throughout. It appears as a lifetime. And this is just some of the data that demonstrates that, both in inflammatory thyroid eye disease, non-inflammatory thyroid disease, and in which is chronic. So in chronic thyroid eye disease, maybe what we're doing by inhibiting this receptor complex is that we're actually altering the constitutive turnover of extracellular matrix molecules, which by deuterium labeled studies appears to be about every 7 to 14 days. So maybe establishing a new set point. It's a great hypothesis, but does it bear true? Well, it turns out that teprotumumab does reduce proptosis in patients with chronic thyroid eye disease. And this was a study that we did that looked at patients who have had disease for at least 3 years and found that their change in proptosis was almost identical to those patients who were newly treated. It was over 3 millimeters reduction in proptosis over this course of disease. And this is a slide, but it's worth looking at. This is a patient on attempted upgaze. This is before teprotumumab. You can see proptosis, etc. She's trying to look up. These are 9-gaze photography photos. Down below, she's looking straight. Here, she's trying to look up. She can't move her eyes. After treatment with teprotumumab, she had a 5 millimeter reduction in proptosis. But more importantly, you can see now she can actually look up. It's actually shrinking the muscles, and we've done the CT analysis of this, shrinking the muscles and allowing an improvement of that double vision and extraocular movement. And we think that it compares quite well to decompression surgery. I know that this is not that group's focus, but a surgery where I remove the bone between the eye and the brain, the greater sphenoid, has about a 3 millimeter improvement in proptosis. And that's about what we're seeing with this therapy. So I will close.
Dr. Raymond, thank you.
Thanks so much. Oh, and just one final comment about tissue-specific effects. I wasn't sure if someone was interrupting. And this will be very short, but there are soft tissue changes that are associated around the orbit. And what we've seen is that there's expansion of the orbital and facial and temporal fat expansion in addition to the lower face. And what we've seen is that these cells actually are the same cells that are in the orbit. We're expressing the IGF-1R. We use 3D imaging to capture some of the landmarks of these areas and to actually quantify and to see before and after treatment with teprotumumab, if the other areas of the facial changes have occurred. And what we found is a pretty dramatic improvement, especially as you can see in these photos before and after teprotumumab, in 3D facial appearances. It actually alters the face back to the normal structure that patients had prior to this disease. And in fact, up to 8 cc's of fat are actually shrunk over this period of time and is volumetric. So it's not only just the orbital tissue, it's the facial tissue where patients say that they look different. They really do. And we're able to return patients to this appearance. So just in conclusion, I want to thank the organizers for allowing me to give at least an overview of data that's been occurring over the last 5 to 10 years, and certainly my pleasure to be here today.
Thank you so much, Dr. Raymond, and thank you to Horizon for that symposium. If you do want to learn more, you can visit the Horizon virtual booth in the exhibition area, and also there'll be links to Dr. Raymond at that virtual booth too. So thank you very much. We will now hand back to Dr. Eiman, who will re-engage with the scientific symposiums. Dr. Eiman, the floor is yours.
Thanks, Jared. So moving on now onto an endoscopic surgical procedure will be presented by Dr. Tufano. Dr. Tufano is a professor in the Department of Otolaryngology, Head and Neck Surgery at the Johns Hopkins University of Medicine. He has served on the board of the American Thyroid Association. He has been the recent past chair of the American Academy of Otolaryngology's Endocrine Surgery Committee. His research interest is revolving around clinical outcomes in transoral thyroid and parathyroid surgery. Currently a director of the Sarasota Memorial Healthcare System, which is a multidisciplinary system to look after patients who have head and neck endocrine problems to deliver a better care in a holistic approach. The floor is yours, Professor Tufano.
Okay, well, again, thank you for the kind introduction. And it's really a pleasure to be here with everybody again. And so this talk is going to be specifically on transoral endoscopic thyroidectomy, the vestibular approach. And I'm going to provide to you a 2022 update. So these are my disclosures. A lot of what you've been hearing this morning really emphasizes the need for a discourse between all stakeholders involved in patient care. And this is really important. So you see here in this diagram, the patient is actually at the top. They are the focus, and they always have to remain the focus of care. We have endocrinologists, surgeons, pathologists, and of course, other additional disciplines that are working together to discuss all of the treatment options for a patient so that they can make the value-based decision that they feel is best for them. This can only be done when these options, first of all, are known about, and second of all, are presented without bias and only based on current evidence available. Now, that's a hard undertaking to do each and every day with each and every patient as you practice the care for the patients with thyroid disease. Let me speak about some of these things that you've already heard about during this conference. You heard Mike Tuttle talk about thermal ablation, directed ablation of thyroid nodules, thyroid cancer. We've talked about nerve monitoring. We've talked a little bit, and you will hear more about autofluorescence for parathyroid glands. So what you have to understand is that you have to have a familiarity with all treatment options, even if you don't perform them. And I think it's incumbent upon endocrinologists and also other stakeholders, including interventional radiologists within our field, to understand all of these options. We have an ethical responsibility because if we can't discuss these options in a really unbiased way with our patients, they in no way can make a value-based decision as to what's best for them. We have a professional responsibility. It's really our job to keep up with current technologies, current techniques, and then to critically assess them. I'm not saying that everybody has to embrace them. There's pros and cons to everything we talk about. We must critically evaluate this to further define the roles of these new technologies or techniques in our environments and society, even in our practices locally. But what we have to do is avoid this personal or subjective bias that we don't think something is good and we just say it's not so good because we're fearful that if we don't perform it, then what happens is that we'll be left out. And then the other thing we have to do is avoid paternalism. Paternalism such that I know what's best for you, patient. Just listen to me, stop asking the questions, and this is the best thing you should do. You should have a total thyroidectomy plus radioactive iodine for your 1.2 centimeter papillary thyroid cancer. This is how we do it, and we've done it for years, and you should always do it that way. No more questions. There's no role for that anymore in our field. When you're experts coming together, we have a responsibility to provide all the options for the patient. They demand that, and that's important. I think a lot of the discussion has centered around what to do with a particular nodule and as it relates to where it's located within the thyroid. And I can't emphasize enough how important it is to do your own ultrasound. And I know that there are political challenges and also resource challenges all over the world that sometimes hamper our ability to do this. But if you're going to be involved in the decision-making process for whether a patient should undergo a radiofrequency ablation or laser ablation of a nodule versus a surgery versus an endoscopic surgery or remote access or versus a active surveillance protocol, you have to do it. It's not enough to look at still images. You need to look at the dynamic images under your own hand to assess the relationship of the index nodule of concern with surrounding structures. It helps to inform you, obviously, when to biopsy, right? So you're looking at nodules and you may take care of the patient if you're a surgeon potentially at the time they present with the nodule, maybe to the time that they've had their interventional care episode. What about extensive disease? Surgical planning. How much surgery should I do? Are there lymph nodes involved? And if there are lymph nodes involved, should I change from that lobectomy to a total thyroidectomy? Yes, I would inform yes. It informs decision for additional imaging. If I have bulky lymph node metastases throughout the central and lateral necks, well, I want to know, should I get a CT scan if the thyroid nodule is very large and it's at the posterior medial capsule up against the trachea and maybe the tracheoesophageal groove? Yes, I want that additional information about extent of invasion. And I would tell you location, location, location is critical. You know, they say that about real estate, but I would tell you, as Mike maybe alluded to before, if you have a small thyroid nodule that's situated at the posterior medial capsule up against the tracheoesophageal groove, if it is a papillary microcancer, that's probably not a good situation for active surveillance. It's not a good situation necessarily for an ablation technique. And it's probably not a good situation for an endoscopic or remote access approach. We may have to treat that with conventional surgery to make sure we have the exposure necessary to manipulate the nerve from that area. And now, if I had a 2-centimeter papillary thyroid cancer situated within the inferior aspect of the thyroid, or let's say 1.5 centimeters, a little bit smaller, maybe normal thyroid parenchyma, way away from the recurrent laryngeal nerve, that patient is really a good candidate for, in circumstances, whether they want to do a radiofrequency ablation approach possibly, or a laser therapy approach. If they can undergo a remote access approach, they're really a candidate for all approaches. Now, this is very important to understand, because unless you're doing your own ultrasound and you're wholly involved in all the aspects of care and all the options available, you're not going to be able to help inform the patient's decision-making. And that's really, really important to understand. Well, I think many of us know that all over the world, thyroid surgery is performed by surgeons who have different levels of expertise. And certainly we also realize that not every patient heals beautifully, no matter what. Many surgeons say, this remote access stuff is kind of hokey. You know, I make small incisions and the patient never sees those incisions, and the scar, there's no scar. I don't know if those doctors follow those patients up for years. I don't know if they go home to live with them to make these kinds of outrageous statements. We know that the patients, again, those are paternalistic statements. We know patients have sometimes poor healing. We know they're afraid of having a scar. We know that some of them, by the medical literature, are very, very aware and concerned about a scar. And when they have a scar, they are to have a decrease in quality of life. So this is important to acknowledge. And people go on the internet and they see some of these horrific scars and they worry, is that going to be me? There certainly is societal value when you're looking at treating patients and avoiding a scar. And so we did some studies while I was at Hopkins with my team. We looked at patients, 7 with a transcervical incision/scar from thyroidectomy and 5 without. And these were 193 observers. And the perception was that the patient with the scar had was less attractive and had a lower quality of life, and that the casual observer would pay greater than $10,000 to avoid a surgical incision. And then we had 130 observers, and we looked at these patients, so these pictures of people who have had either an incision or and controls. And what we did was look at their infrared eye tracking, and observers looked at the neck longer when there was certainly a scar. So then what we did was we further said, okay, where are they paying their attention? And you can see that that's where they were looking. They were looking toward the scar more so than focusing on the patient's face and their eyes. And of course, when we have communication, when we're engaging other humans in communication, we want eye-to-eye contact. We don't want people being distracted during our communication. We want to get their full attention. So this is some additional work that we did, and we looked at these 3 kinds of situations. You would have the patients then with the casual observer. This patient has had a transcervical incision, and you can see that this actually is healed, although this is colored over a little bit. quite beautifully, and we're very careful to place this in a natural curvilinear skin crease and make it very small. In this area, this patient has not had any transcervical incision. They had the transoral, the endoscopic vestibular approach. And here the eyes are gazing a little bit toward this nevus, and this patient didn't have any surgery at all. So when I think about where we've come from, I realize that I've run the course of all the possible remote access treatments that have been out there. And I can't believe that I maybe am that old, but I started with MyVat back in 2006 after spending time with Paolo Micheli and Gabriele Materazzi, and then realized that even though we were making smaller incisions, we were still making an incision. And sometimes the patient had hypertrophic scarring. We then had the pleasure of learning from Dr. Chung in Korea the transaxillary approach and performed 30 cases very, very well at Hopkins without complications. But of course, complications have been reported with this that were never heard of with thyroidectomy, including brachial plexus injury and esophageal perforations, and also great vessel injury. So there was a move to go to the retroauricular approach. And this retroauricular approach by Dr. Ko was really something that we went and tried, but it was in fact a big posterior vertical limb incision. It was a very, very long haul to get to the thyroid. And our patients actually complained a lot of having a longer posterior incision in the hairline. So we realized that for those years that we were doing these operations, there had to be a better approach. There had to be an approach where we weren't going to make an incision in skin. And so we were the first ones actually to report on the transvestibular approach. And so what we did is we got a group of remote access and robotic surgeons together, Jeremy Richmond, Chris Holsinger, Imad Kandil, who was my first fellow, in fact, and myself. And we defined the initial intervention and the approach. So this is what we did in 2011. And oftentimes, I think it goes a little overlooked that we actually defined this. And we did say that we were going to try to use the robot, but this is the first iteration of the transvestibular approach. And we define all the steps that we use today in that document. Of course, since then, a dear friend of mine, Dr. Angun Anyuang, and then also Dr. Hun-Yu Kim in Korea, Dr. Anyuang endoscopically and Dr. Kim robotically were the ones who first started to take this approach and run with it. So let me present to you a case and I'll show you a little bit of the technique for those who may not be familiar with it. It is probably my favorite operation to do. I have many research interests, but this is one as far as the outcomes that I'm very excited about. So you can see this woman who had both a hyperfunctional nodule on one side and on the other side a nodule with a Bethesda 3 category and then an Afirma gene sequencing classifier, suspicious diagnosis. And so here is our approach, and it's a little bit of a fast speed for the video, but what you can see here is that this is the central working port, the two lateral working ports, and this is how we get access. Probably the most fun part of the procedure, I say, is creating this working space with CO2 insufflation. The visualization is absolutely remarkable. It's enhanced, and you have obviously the magnification, and creating this working space is actually the most fun part to even teach as well. And so it is a very, very clean, very nice working space where we establish the dissection all the way down above the strap muscles, even in our thinnest patients, so we don't have any issue with any dimpling of the skin. You can see that we have immediately the midline raphe very clear to our view, and we split the midline raphe just as we would do in open surgery very neatly with ligation, thermal ligation technology. One of the things I would say to you is you have to be very comfortable with thermal ligation technology. And if you don't use it explicitly in all of your thyroid surgeries on the open and you're still putting, clips and ties, well, this is not going to work for you. We're often able to take the Delphian lymph node. I made emphasis about that before in every case where we're possibly considering malignancy. And now we're getting into that area where there's some additional lymph nodes at the cricothyroid region, so additional prelaryngeal nodes that we're taking. And you can see the isthmus. In each and every case, we have to start by splitting the isthmus to define the trachea. And once we're able to do that, then we can start working on the respective lobe for the procedure. So you can see here the trachea very nicely underneath. We use this harmonic HD1000i dissector. You can use a ligature. I have no conflict with any of these companies. And you can see that we start to elevate the strap muscles on either side. Let me fast forward just a little bit here for us. And I'm going to go here and start to show the nerve dissection. So many people think, well, this is difficult and, you know, I have to take down the superior pole. I have the superior parathyroid gland here. How do you do this dissection when you're having to use heat? Can you even dissect the nerve out? And this is the most constant location for the insertion of the recurrent laryngeal nerve. This part of the harmonic is not active. Only the top part is active. So if you get that plastic part on the nerve, you can feel very confident that none of that heat is disseminated. And in fact, you can use nerve stimulation, and we use nerve monitoring. And if you use the harmonic or one of these technologies in your open approach, you would also know that you can actually get very close to the nerve. It just depends where the heated element is. And so you have to be cognizant of that during the entire procedure, because as you know, that actually stays hot for a little bit of time as well. Let's just fast forward here for the sake of time. We have the manipulation of the entire thyroid lobe, then up and over the trachea. You see us managing Barry's ligament. Many people ask, well, are you going to have to leave a whole bunch of thyroid tissue here? How do you do this? And isn't it going to be a lot of residual that you're leaving behind? You can see that we pushed this nerve posteriorly right at its insertion point. We've mobilized it. And you can see I'm very careful to turn the heated element away and maintain the neurophysiologic integrity of that nerve. That nerve is working beautifully from the beginning to end. So we intermittently stimulate it to make sure of that as well. And then so finally, we're able to remove the entire specimen, and people would often ask, you know, how are we doing this? You can see now at this point in time, we'll show you that we've taken out the entire side and that we haven't left any residual thyroid tissue behind, even at the nerve insertion point. And so we'll come a little higher and show that. So what we do is we'll put it in an EndoCatch specimen bag, and that allows us to feel very confident that we are not going to transgress or pop or rupture the nodule. Okay, so we'll go forward from there. So these are usually our outcomes, and the patient heals very, very well. Usually they heal very quickly. Remarkably, the pain scores are exactly the same as with open surgery. Most of these patients will only get a dilaudid dose and some narcotic the day of surgery, but most of them only require Tylenol after. That's very important as we continue to discriminate against people, against the use of opioids, you know, without really an absolute need. So we're able to do this very easily with using Tylenol and minimal pain management issues. So who is a candidate for this surgery? Anybody with benign disease, no definite size cutoff. You usually recommend that the entire lobe is less than 6 centimeters, but we've done bigger. And the nice thing is, especially for women, younger women or young men who are not interested in undergoing radioactive iodine therapy, are not interested in continuing medication, but want something definitive, we can do this for small to moderate volume glands with grades. It is the cornerstone, again, of management, the ultrasound, and I need to know where the location is, because if I'm taking down the superior pole first, if I have a small nodule even at the capsule of the superior pole, if I have to grab that with one of my working instruments, then there's a concern for rupture. So again, maybe that is not an ideal candidate, even though it's a small nodule. You may think, oh, you know, that should be a candidate. Again, it's about location. So if you have a fine needle aspiration biopsy, but there's the 3-4 category, molecular markers deem it to be suspicious, no real other concerning features on your ultrasound, appropriate location, then if it's 4 centimeters or less, we would consider it in that situation. And then also for the smaller differentiated thyroid cancers in a favorable location without bulky lymphadenopathy. And the beautiful thing about the transoral approach is that you can do it for both sides. It's not like before when we were doing transaxillary or even the facelift approach that was one-sided surgery, very difficult to treat the other side in a very comprehensive way. Here you have equal access. So the critical steps for success here are to do your own ultrasound and know the location of the pathology. We don't do any oral prep. We only give one dose of intravenous antibiotics. We keep the patient on antibiotics for a few days. We don't do any hydrodissection. We don't make this complicated. It's really simple. We use CO2 insufflation. We split the isthmus first. We take the superior pole down first. It's a little bit different than what most people probably do from an open approach. We're finding the nerve at its insertion point superiorly as opposed to more mid to inferior along the thyroid. You have to have an absolute comfort with thermal ligation technology in open surgery. You can't be saying, I'm going to use this and I'm only going to use it on the specimen side and I'm going to tie and clip on the patient side. This technology works. You just have to learn how to use it. No drain, and using nerve monitoring is appropriate. We first published the largest series in the United States, North America, 200 cases in March of 2021, our group. And what we showed was that there was really no difference in the incidence of major complications when comparing it to our traditional / open procedure. I think early on, maybe we had a little bit of a higher incidence of temporary recurrent laryngeal nerve paresis as we were pushing a little bit more on the nerve, and then sometimes not appreciating maybe the heat profile in and around the region. You can see though that this was very, very not statistically significant from different. And then temporary hypoparathyroidism was not an issue either. So the surgical technique did not alter the odds of complication. And actually in the United States, one of the knocks here was, well, if this is being done in Asia, that's a very low BMI. This is not necessarily applicable. We had issues with transaxillary with a large BMI or high BMI. But in fact, the easiest flaps to raise, and some of the BMI patients for me have been over 50, and they've had great value from this because this is what they wanted to do. They were already self-conscious about their weight. They wanted to avoid an incision. Who am I to tell them no if they were candidates? The higher BMI did not lead to a significantly greater odds of complication for the overweight and obese groups respectively. So I feel very comfortable in a traditional North American patient population to be able to utilize this approach, and even at the extremes. Not something that we can say before in the other remote access approaches. We've done together with my colleague, John Russell, who was my fellow in 2015 and 16 and stayed on at Hopkins, and we continue to work together on this, over 500 cases now. And our outcomes and our indications have certainly expanded. And I think that what we were initially concerned about were infections. Well, we've only had one infection. We see that our temporary vocal fold motion impairment actually has decreased as we continue to gain more experience and understand the heat profile of the instrumentation that we use and very cognizant of it. We have had one permanent vocal fold motion impairment out of 500 cases, and we reliably look at the vocal folds before and after surgery. And again, in anybody who has a voice complaint that develops even in the postoperative period, we follow these patients for at least a year. And then overall, what we're seeing is when those patients have had a total thyroidectomy and have been considered for radioactive iodine, in 6 out of 8 patients, there's been no uptake and an undetectable thyroglobulin level. This is same-day surgery for us. We're really not keeping these patients or treating them any differently than our open patients, and we use the same criteria. So if you look at some of the literature that discusses other studies, and this particular meta-analysis is very helpful. This was done from colleagues in China, Wang et al. And if you look at this, most of the comparisons between the transoral surgery and the conventional open surgery, if you look, there's really no significant difference in blood loss, transient recurrent laryngeal nerve palsy, permanent recurrent laryngeal nerve palsy, hypocalcemia, and even when they institute it for central neck dissection, which they do very much prophylactically, this is not even therapeutic. You know my thoughts on that from before. You can see that they're retrieving an adequate number of lymph nodes too as well. But what seems to plague most people, because I don't think that anybody is really establishing a significant volume with these patients, is that the operative time is much longer. And that's not something that we can ignore, especially in certain healthcare systems, like, for example, ours. If we can do 5 open thyroid surgeries, but only 2 transoral endoscopic surgeries, well, that may not be something that is sustainable if we're not able to produce a revenue that could substantiate our time in the office and the operating room, when we could be doing it in another way and be more profitable. These are real world implications. But I think for me and for Dr. Russell, as we continue to really push this technique and really get comfortable with it, I can tell you that we are very, very close, certainly with parathyroid surgery, focus surgery. We can do this in the same amount of time that we're doing our focused parathyroids open. And even for the lobectomies, and it obviously has to depend on the disease process, right? I mean, I'm not talking a bad Graves gland, but if I'm talking about a 1.5 centimeter Bethesda 3 category nodule that's in the inferior pole of the thyroid, you know, that's something that we can do very quickly. And so again, the more you invest in it, the more you try to hone your skills, the better you get. And we are really not seeing that difference. So in time anymore, it's really not noticeable, and it's negligible. What about the addition of the robot? You know, where are we with that? And wouldn't that be helpful? Sometimes I feel like I'm too much of a one-handed surgeon. We're always with the endoscopic approach, having to retract and then dissect at the same time, but I have one hand retracting. I always tell my trainees, you know, don't be a one-handed surgeon, but in fact, I am most of the time doing this endoscopically. So would the robot help us? And so Dr. Kim, who is very, very proficient in robotic surgery, and Dr. Chen in Taiwan, also Dr. Anyu Wang, who is, again, not a robotic surgeon, does all of this endoscopically, did a very nice study on this and looked at transoral robotic versus transoral endoscopic thyroidectomy. And what you noticed is that all across the board, there was a longer operative time for the robot than for the endoscopic approach. And it was not insignificant. I mean, you can see these numbers. So the process of docking the robot in its current iteration, which was the XI for this study, the process of going through the dissection with the robot, yes, the outcomes were excellent, but it took that much longer. So I don't think that this is going to be readily adopted here, for example, in the United States, until there are some improvements in the technology. So if you look at this, then what we have to say is also that it's harder to learn. We define the learning curve for transoral endoscopic thyroidectomy, the vestibular approach, as to 11 cases. If you're going to tell me it's going to take 25 cases to even start to get to be comfortable or proficient with transoral robotic surgery, that's not a lot. You know, a lot of people don't have the time to invest. A lot of surgeons don't have the time to invest in trying to get to this point without other support for their time. So I think that this is really important to consider. I do think, though, that this new technology will continue to evolve. We're talking about single port robotic surgery. We've tried to use the single port robot in its current iteration, and we elucidated many, many limitations of it at this point in time. I know that Dr. Ko in Korea is starting to do more by single port, and he's made some modifications as well. But we're looking for miniaturization and some modifications on this single port to help us continue in that way, because I do think that the single port actually would be very helpful for multiple arms to have for retraction and dissection. And I think it would be quite nice if we can actually adopt that and adapt it too, as well, to using it for thyroid surgery via transoral approach. Well, I think, you know, after looking at this for so long and saying we've tried everything, I think the transoral endoscopic thyroidectomy vestibular approach is the go-to operation now all over the world to try to avoid making an incision. It's the go-to remote access approach. So to try to avoid making an incision in the neck, you can see how really many countries now are actually employing this technique. We never saw this really with transaxillary robotic thyroidectomy nor facelift. And I think this only continues to gain more momentum. But what I would say is that things tend to lag. And I've realized that transoral endoscopic thyroid surgery is just another way to do surgery. But that this ablation technology that we had heard about earlier today is certainly disruptive. And that means it has implications for surgeons, but it also has implications for everybody who treats thyroid disease. And so in 2019, I believe I was the first surgeon in the United States to start using radiofrequency ablation and have encompassed a vast experience now in treating benign nodules and small thyroid cancers and some small lymph node metastases with differentiated thyroid cancer. And I truly believe that these therapies will continue to evolve and become refined. They will become automated. They'll become easier to use. And both the concept of active surveillance, watching a cancer, which is certainly an anathema here in the US, and surgery, which may be too extreme for some of these small cancers, will become less desirable. Most benign thyroid nodules and small cytologically indeterminate thyroid nodules and thyroid cancer will come to the ablation treatment. If the surgeon's attention is only toward these fancy remote access and robotic surgeries, I think we'll come to suffer the same fate as the dinosaurs, or maybe our cardiac and vascular surgeons. I think surgeons and other stakeholders involved in the treatment must come to acquire ultrasound, fine needle aspiration, biopsy, and directed therapy skills to remain relevant in all aspects of thyroid nodule and cancer care. You can't be just a little in. You have to be all in if you're going to treat this disease process, and you have to know about every treatment process that is available to treat this, and you have to be fully engaged and participating. I think the surgeon is best positioned because they understand the surgical aspects. They also understand the anatomy. They are doing their own ultrasound, and they're also able to reconcile the interventional treatments. And so I really employ surgeons to not be distracted by these novel surgical techniques. Yes, they're fun. Yes, I love doing transoral surgery, but I realize that it's going to have less and less import and less value as these directed therapy techniques evolve. So just keep that in the back of your mind. Maybe, just maybe, if you remember that I put that diagram up before, we're going to have to include this new oval in that discourse to make a value-based decision. The thyroid interventionalist, which can be the endocrinologist, the surgeon, the interventional radiologist, or as some of my colleagues have already demonstrated, maybe it isn't just one of these entities, but maybe a combination like Dr. Tuttle working with his interventional radiologist. Maybe that is what you'll see start to evolve in these centers. And maybe that is going to be the way we should manage this, including, as we always talk about, a multidisciplinary approach. So I think that this is a very prudent way to go about things. So let me give you a summary and finish here. TOTVA is now the predominant remote access approach for thyroid cancer surgery and thyroid surgery throughout the world to avoid a cervical or any cutaneous incision with potential for scar formation. It is not minimally invasive surgery by any means. It is maximally invasive surgery, but we must allow our patients to make value-based personal choices as to what's important to them without paternalism. So I'm having to do a lot of dissection to get down to that thyroid. But as I told you, the quality of life afterward is absolutely, from a standpoint of recovery and pain, similar, exact to the open surgery, but with the value added of avoiding an incision. And to some patients, or a scar that is, to some patients, that's very, very important to have that option. And they feel very happy to have that option. There's value to them. RFA is disruptive technology in these thermal ablation technologies, and there will be different types of technology or energies delivered that are not heated that are going to come about as well, that are going to allow us to treat these nodules in a very disruptive way. They're going to be very minimally invasive, and I think that they will continue to evolve and become more refined. So let's pay attention to this. Let's all who are interested in taking care of patients with thyroid disease, not just, especially surgeons, not just focus on the surgical aspects. Thank you very much for your time and your effort and your commitment to this course and spending time with us.
A very excellent, comprehensive way of presenting this topic. Thank you very much. Moving on to our next topic, which is an endocrine topic on thyroid emergencies by Dr. Mario Stan. So Dr. Stan is a consultant in endocrinology at Mayo Clinic in Rochester. He's an associate professor in medicine and the chair of the thyroid core group for the Division of Endocrinology at Mayo. He is primarily working on the area of autoimmune thyroid disease, thyroid eye disease in specific. He's a member of the American Thyroid Association task force focusing on hyperthyroidism and thyroid eye disease. So please welcome Dr. Stan, and let's enjoy his thyroid emergency talk.
Thank you, Dr. Eiman. I appreciate the opportunity to be with you again. My lecture on thyroid emergencies is pre-recorded, and I'll turn it back to your technical desk to play that recording, and we'll discuss later. Good evening. I have been asked by the organizers to present on the topic of thyroid emergencies. Fortunately, these are rare cases, but they are life-threatening, and I'm happy to share with you some of the cases that I have been involved with and discuss them. I intend to do that separating functional thyroid emergencies and structural thyroid emergencies. And we'll go over 3 such cases that illustrate the different aspects. The first one is that of a 37-year-old lady that was admitted to our hospital with congestive heart failure. She had a number of problems, medical problems. Most importantly, she was dealing with severe primary pulmonary hypertension. But on top of her chronic conditions, she was developing for the last couple months new symptoms which were very consistent with thyrotoxicosis. As you see, she was extremely tachycardic now. She continued to have normal temperature, but she was quite tremulous, sweating. She had multiple loose bowel movements a day, and she appeared to be rather agitated, even though she was able to control herself and gave a very good story. Her thyroid upon inspection was quite large at about 100 grams, and her biochemistry was clearly thyrotoxic. As you see here, the TSH undetectable, the free T4 above the upper range of the measurements that our assay typically employs, and also an elevated total T3. And furthermore, measuring the TSH receptor antibodies, we found them to be also elevated at 23. So what is the endocrine diagnosis, I have asked my fellow? And certainly in a large goiter with a positive TREB and thyrotoxicosis, Graves' disease is an easy diagnosis, but the severity of thyrotoxicosis is the more important element to be defined here. And the thyroid storm is what we're trying to put our finger on. This is an extreme form of thyrotoxicosis, and it's not answered by laboratory values. What we need to keep in mind is that it is the reflection of multi-system organ failure, multi-system organ involvement from the thyrotoxicosis. Fortunately, there are 2 sets of criteria that have been put out by investigators, and I think both Birch-Wartowski's score as well as the criteria put forth by Akamizu from the Japanese endocrine societies are valuable and ultimately pinpoint pretty much the same patients. When we're dealing with the diagnosis of thyroid storm, typically we find a precipitating factor, and the most common one in the literature seems to be the interruption of anti-thyroid drug therapy. Here is the set of criteria put forth by Birch-Wartowski probably 2 decades ago now, and we're seeing that they emphasize aspects regarding thermoregulation, tachycardia, cardiac rhythm, presence of congestive heart failure, GI dysfunction, CNS changes, as well easily identifiable precipitating event. The score that is considered to be indicative of thyroid storm is a score of 45 or above, which is exactly where our patient, the one that I just presented to you, was situated at the time of our evaluation. The criteria put forth by the Japanese Endocrine Society through Dr. Akemizu and his colleagues are separating elements into two categories. There are categories that are definite thyroid storm, and those you see listed here as TS1. There are two combinations there. And then suspected thyroid storm, which is TS2, and again, two combinations. They focus fairly much on the same set of elements that you would identify in the Birch-Wartowski, but they have a little different structure on the combination of elements to be utilized. How should we manage these patients? All of us identify very quickly that we use beta blockers and anti-thyroid drugs to bring thyrotoxicosis under control. I'll make the point that propranolol is probably the preferred beta blocker given the fact that it's able to inhibit T4 to T3 conversion. And the same can be said about PTU as opposed to methimazole, though there's data, particularly from Japan, indicating that patients treated with methimazole were able to reach euthyroid status at the same rate and probably over the same duration as patients treated with PTU. The next step to be considered once anti-thyroid drugs have been started is the use of iodine-containing solutions. Lugol or SSKI is what we use in the United States. And some of us will also add resins to inhibit the levothyroxine enterohepatic circulation as a binding agent. And I think we've learned over the last decade or so the extreme benefit that can be provided by plasmapheresis as a bridge towards thyroidectomy. And I'll have more to say about that one shortly. All these therapies should be provided in the ICU setting. Life-sustaining therapies are best rendered while at the same time tending to the other needs of these patients in ICU, and I think that ensures the best likelihood of survival for these severe cases. And now the idea of plasmapheresis. As we all understand it, this is aiming to remove the excess thyroid hormone from circulation. But obviously, it does not interfere with the mechanism of thyroid hormone production. So it is not a long-term solution, but rather a bridge towards something else. And for most of these patients, that something else is thyroidectomy. So the goal of plasmapheresis is to normalize thyroid levels or bring them close to normal, where the risk of a thyroidectomy is brought as close as we can to the thyroidectomy that we do for the other patients. The series that I'm depicting here is the experience of a French center where 22 patients treated with plasmapheresis were then reported. And what you see on the graph to the right is the impact on T3 values as well as T4 values. And what you see, hopefully, is the significant decrease, better on the monitor that it's being the recorded one. You see significant decrease on the T3 values and the T4 values, which is about 50% improvement on the pre-therapy values. This has allowed 16 of the 22 patients to go on and have surgery and have a successful outcome. One patient was treated with radioactive iodine, and 4 stayed on therapy as it seemed that now medical therapy sufficed for them. Unfortunately, they also reported 1 death, which is in keeping with the idea that this entity, thyroid storm, is a life-threatening entity. In our case, we've started with anti-thyroid drugs, added Lugol therapy, And unfortunately, the patient remained severely hypothyroid on this combination, reason for which plasmapheresis was added. And after 3 sessions of plasmapheresis, 24 to 48 hours apart, her thyroid levels were very close to normal. So within 24 hours of the last session, we were able to take her to the operating room. She did very well. She is still alive a year later, but unfortunately, she's still dealing with her main problem, and she's awaiting lung and heart transplant. The second case moves obviously to the other end of the thyroid dysfunction spectrum. This young man, 48-year-old, was brought to the emergency department by a friend, and he was brought in because he was confused. He was a patient with a known seizure disorder, and a couple months earlier, he was started on carbamazepine. Upon exam, he was found to be somnolent, he was hypothermic, and his pulse was somewhere around 50. There was no evidence of goiter or a scar over his neck. The laboratory data indicated hyponatremia as well as significant TSH elevation with low T4 and T3. What are we talking about? We're obviously talking about primary hypothyroidism that is going from the spectrum of severe hypothyroidism towards mixed edema coma. Typically, in these cases, we find a precipitating event. But we're looking, in order to solidify the diagnosis of mixed edema coma, we're looking for multiple organ systems to be involved by hypothyroidism. And in all these cases, the CNS deterioration, so cognitive neurological deficit, is present when we're talking about mixed edema coma. The history can include the typical elements of hypothyroidism. On exam, we should also look for the possibility of a scar over their neck or presence of a goiter. And I want to remind all of us that it is important to ascertain not only the thyroid status, but also the adrenal status for these patients. A second autoimmune hit for patients with thyroid dysfunction is possible, particularly when we talk about Hashimoto's thyroiditis. We should consider the possibility of Addison's disease. So assessing cortisol values is extremely important before initiating therapy. And one more element before we talk about therapy is to go back and acknowledge the contribution of William Ord to this field of severe hypothyroidism. The introduction of term mixed edema coma was brought on by him back in 1878 when he described the changes that he noticed, particularly in women. As we know, that's where autoimmune thyroid dysfunction is most likely to occur over the years. And he used these nice drawings to depict how the appearance, the countenance of women was changing with myxedematous changes involving not only appearance, but actually also involving cognitive status due to hypothyroidism progressing before there was available therapy. However, when we're dealing now with mixed edema coma, we know that these patients are in a life-threatening situation, and therefore, again, we want to treat them in the intensive care unit. We want to treat them with a combination of levothyroxine and liothyronine. And because of the severe GI dysmotility, this treatment should be administered intravenously. We should also use hydrocortisone intravenously, stress doses, until we have the answer about the adrenal status. So I will draw a cortisol and an ACTH as we evaluate them. I will not wait for those results to come back, but I will start them on hydrocortisone. And once those results are available, decide if we need the hydrocortisone or not. As the situation hopefully improves, and as we see that the GI transit has resumed, that is the time to convert from intravenous to oral therapy. And you might look at the situation where we combine T4 and T3 for myxedema coma patient, and contrast that with the fact that for most patients with hypothyroidism, we will use T4 alone. So if the question is, why would we use the combination in these cases? I would point out this study, which is now quite a number of years old, done in Belgium, where the investigators exposed cultures of lymphocytes to serum from different individuals. The purple column illustrates the results obtained from individuals with normal thyroid function. The red, individuals with SKMC thyroid syndrome, and then the yellow are individuals that were affected by myxedema coma. And what we see on the y-axis is the T3 production in these cultures of lymphocytes. And we obviously see a striking difference between the serum derived from normal thyroid function to those of individuals with myxedema coma. In other words, there is a significant impairment in T3 production in individuals with myxedema coma, which is the reason why T4 plus T3 is the approach used in these cases. The prognosis of myxedema coma actually is probably worse than that for thyroid storm. For many years, it has been reported to have a mortality around 50%, with some series as high as 80%. Obviously, older patients and those with persistent hypothermia or with pre-existing cardiac problems were those at a higher risk of dying. The recent series, though, have reported better prognosis, lower mortality, and probably that has to do with advances in our supportive care and ICU setting. And I think most authors these days would report mortality below 20%. In our case, we initiated combination levothyroxine and liothyronine in intravenous form, which we carried on for 3 days. And then as the GI motility resumed, we converted to oral therapy with levothyroxine alone. It turned out that the adrenal function was intact, and therefore IV steroids were discontinued. The patient had a remarkable response. He recovered fairly rapidly, but he remained hypothyroid. And it turns out he did not have any prior history of thyroid dysfunction, but probably he was with hypothyroidism slowly evolving over time. And we think that the carbamazepine initiation just increased the degradation of thyroid hormones, and it was the precipitating factor towards his myxedema coma. And that leads us to the third case, and this is a structural emergency of the thyroid that I'm going to illustrate, going through the case of this 68-year-old man that came in with a large goiter, but more concerning to him was a rapid weight loss along with dyspnea. He was reporting to have lost about 5 kilos, 10 pounds over the last month. He was also significantly fatigued, night sweats, had trouble swallowing more solid foods, and also noticed a changed voice, more hoarse, and progressive dyspnea. On exam, it was easily apparent that he had a large goiter, and more so, he also had bilateral cervical adenopathy. His thyroid tests were normal, and the imaging confirmed this large goiter with, on ultrasound, hypodense areas in the thyroid, as well as tracheal narrowing, which was noted on CT, and I'll come to that in a minute. So what is the diagnosis? What is the therapy of a process that seems to be a rapidly expanding thyroid, and in this case, associated with some of the systemic symptoms which we used to call B-type symptoms? Here is the CAT scan that illustrates the rapid enlargement of the right thyroid lobe. You can see the trachea displaced to the left and also narrowed. You can also see one large cervical lymph node. These are images of another patient with the same pathology. And again, we're seeing the wide enlargement of his thyroid. The goiter this time is symmetric. And you can see it from two angles here. This was the same pathology. And this is a third case, a PET scan illustrating significant uptake in the thyroid parenchyma of the FDG tracer. Obviously, all of these cases are affected by lymphoma. And when it comes to rapidly growing thyroid masses, this is one of the top elements in my differential diagnosis, along with the possibility of anaplastic carcinoma or poorly differentiated thyroid carcinoma. However, we need to keep in mind that procedures that we do on the thyroid can lead to complications. So very rarely we would see hematoma leading to a rapid expansion of the thyroid parenchyma after a biopsy, or extremely unlikely these days, an abscess evolving into the thyroid. It's very important to be aggressive about this diagnosis, to pursue it rapidly, and for that, I consider the core biopsy as the essential tool. Also, in parallel with pursuing the diagnosis, I'm very concerned about the tenuous status of the airway. So I involve my surgical colleagues on an urgent basis to help us secure the airway. The diagnosis, as I said, should follow the pathway of at least a core biopsy, if not an excisional biopsy of a lymph node. And occasionally, we need the surgeons to help us in establishing that diagnosis with a larger piece for pathology. And the reason for this is that cytological diagnosis is rarely sufficient in these cases. We need immunostaining. We need some architectural markings in order to ensure a good differential diagnosis, particularly when it comes to lymphoma. Therefore, I avoid fine needle aspiration since it is not able to provide sufficient material for an accurate diagnosis in more than half of cases. And we've reported on this challenge in our publication 4 years ago. This is the ultrasound appearance of the case that I discussed with you earlier, the gentleman that came with rapidly developing thyroid mass. You see how hypoechoic this mass was, which is the typical presentation for lymphoma. And on core biopsy, what you see here is the large abundance of lymphocytes, which ended up being a monomorphic lymphocytic population that turned out to be a case of B-cell lymphoma. Thyroid lymphoma, fortunately, is only 1 to 2% of thyroid malignancies. It tends to occur in the setting of Hashimoto's thyroiditis, so therefore more likely to happen in women, and tends to happen later in life, 6 to 7 decades. As I said, a rapidly enlarging mass in the setting of a known goiter or just Hashimoto's thyroiditis. The therapy is based on the type or subtype of lymphoma. Keep in mind that once steroids are used, these masses tend to shrink very rapidly, so the biopsy should be collected before the steroids are initiated. And the therapy for lymphoma also tends to increase the likelihood of fistulous changes that can develop between the thyroid and the esophagus most commonly. Unfortunately, most patients remain hypothyroid long-term after therapy. In this case, there was an excellent response to steroids, restoration of airway patency. Cytotoxic therapy was delivered by hematology, and the patient had an excellent recovery and was discharged from the hospital. But as expected, he did require lifelong levothyroxine therapy thereafter. In summary, functional thyroid emergencies are based not on absolute thyroid levels, but on the multitude of organ system involvement. In these cases, the care should be escalated rapidly in the ICU setting, And for cases of thyroid storm, I want to emphasize the potential benefit that plasmapheresis can bring. As far as structural thyroid emergencies, these require a rapid diagnosis. Core biopsy or excisional biopsy are the way to go. And in parallel, we should be mindful about protecting the airway while we're doing our diagnostic work and initiating early therapy. With that, I want to thank you for your attention, and I look forward to your questions in the Q&A session.
Thank you, Dr. Stan. That was very practical with new additions to already known therapies. Moving back to Dr. Pierce, who is a professor of medicine at Boston University School of Medicine, former president of the American Thyroid Association, a deputy editor for the Journal of Clinical Endocrinology and Metabolism, served also as an associate editor of the Journal of Thyroid, Journal of Clinical Thyroidology, and Journal of Endocrine Practice. An ATA task force member in the guidelines of pregnancy related to thyroid disorders. A recipient of the American Thyroid Association's Van Meter Award for outstanding contributions to research on the thyroid gland. So let's enjoy another talk from Dr. Pierce.
Good evening. It's a pleasure to be with you today. I've been asked to discuss thyroid hormone replacement in special populations. So the populations I want to cover today are those individuals who have just subclinical forms of hypothyroidism, how we should manage hypothyroidism differently in patients who are elderly, who are pregnant or in the preconception period, in infants and in children. And then we'll also talk a little bit about how management of central hypothyroidism differs from patients with primary thyroid dysfunction. So to start with, thinking about subclinical hypothyroidism, the concerns about what this could lead to if untreated. One is increased risk for cardiovascular disease. The other is that there may be attributable hypothyroid symptoms. Another is that patients who have just subclinical hypothyroidism at baseline may progress to becoming overtly hypothyroid. And then something we'll discuss separately in a few minutes, there's a concern for worsened pregnancy outcomes and fetal outcomes when subclinical hypothyroidism occurs in pregnant women. With regards to the likelihood that subclinical hypothyroidism will progress to overt hypothyroidism, I think our best natural history data come from this landmark study from the UK, the Wickham survey, in which there was a 20-year follow-up of about 2,800 individuals who had baseline thyroid autoimmunity and TSH levels assessed. And in patients who had positive antibodies, but a normal baseline TSH, the risk for progression to overt hypothyroidism was about 2% annually. It was higher at 3% annually in individuals with elevated baseline TSH but negative antibodies, and it was highest when both risk factors are present. So both subclinical hypothyroidism at baseline and detectable TPO antibodies. Now, the TRUST trial was a landmark clinical trial published in 2017 in the New England Journal of Medicine. This looked at the question of whether treatment of subclinical hypothyroidism improves symptoms and quality of life. This was conducted specifically in older individuals, those 65 years of age or older. They had to, at baseline, have a persistent TSH elevation in the range of 4.6 up to just under 20 with normal free T4 levels. And they were randomized either to treatment with low-dose levothyroxine or placebo. The dose was titrated to keep the TSH in the normal range. And at 1 year of age, you can see that there was a nice separation in the curves, that they did achieve more normal thyroid hormone levels, or at least TSH levels, in the patients who were treated with levothyroxine than in the placebo group. But there was really no difference in hypothyroid symptoms or in fatigue. With regard to whether treatment of subclinical hypothyroidism improves risk for cardiovascular disease and cardiovascular mortality, we do not actually have trial data. We do have some suggestive observational data, however. This is a pooled data analysis published in JAMA back in 2010 by Radandi and colleagues that looked at 55,000 participants across 11 cohorts and across about 500,000 person years of follow-up. And what they found in this analysis was that subclinical hypothyroidism at baseline was associated with increased risk for cardiovascular events and for cardiovascular mortality, but that risk was really much more substantially increased in individuals when the TSH was greater than 10 compared to those individuals where the baseline TSHs were lower. We don't really know whether treatment reduces that mortality risk because, again, we don't really have trials that have done that. We do, however, have this recent meta-analysis by Carol Peng and colleagues published just last year. And here they pooled data from 5 observational studies and also 2 smaller randomized clinical trials, which together included information from 21,000 adult patients who were subclinically hypothyroid. And what they concluded from their analysis was that use of thyroid hormone replacement did not protect against mortality in older adults with subclinical hypothyroidism. However, perhaps there's a mortality benefit in adults who were less than 65 to 70 years at baseline. Now, because we don't have perfect trial evidence to know whether treatment is truly beneficial or not, guidelines have been variable. There's a guideline that was published in BMJ in 2019 that took a fairly hard line against treatment of patients with subclinical hypothyroidism, really recommending no levothyroxine for patients who had a TSH less than 20 when the free T4 was normal. Although it's important to note, I guess, that in this guideline, they do suggest that this does not apply to patients who might become pregnant. This may not apply to younger adults less than 30 years of age. Now, that I'm not sure is really in line with what most of us do in clinical practice. And there are other non-concordant guidelines out there that I think probably are closer, certainly to what I do in my own practice. So there's an ACE, American Thyroid Association guideline for hypothyroidism published in 2012. There's also a guideline from the UK published in 2019 that have recommendations that I think probably make more sense looking at the totality of the evidence, even though we don't have perfect trials demonstrating evidence of benefit of treatment. So what is recommended in these guidelines essentially is to consider levothyroxine therapy for adults when the TSH is greater than 10, mostly to lower risk for heart disease and cardiovascular mortality, it said in the ACE-ATA guideline, mostly to lower symptoms, really it says in the UK guideline. One should perhaps consider treatment more strongly in those patients who do have suggestive symptoms, or where the TPO antibody is positive, because we know those patients are more likely to progress to overt hypothyroidism, or in patients with known cardiovascular disease or risk factors for cardiovascular disease. If we're going to try initiating levothyroxine therapy in order to try and reduce symptoms, it's important not to put patients on lifelong levothyroxine if it's not going to be beneficial. So there in younger adults, less than 65, if you're going to try a trial of levothyroxine, should normalize the TSH, should follow for 6 months, and if there's no symptomatic benefit, you should probably not continue therapy and should just go back to monitoring thyroid status. Now, in older patients, some special considerations apply when we're treating hypothyroidism. And the first is really just about how to define it. That we know that there seems to be just a physiologic upward shift in TSH levels with normal aging. That is really sort of beautifully illustrated by this analysis from Marty Sirks and Joe Hollowell, where they took data from the NHANES survey in the US. They excluded all individuals who were pregnant, who had anti-thyroid antibodies, who had overt thyroid dysfunction, or were taking any medications that could affect thyroid function. And then they just looked at the TSH curves stratified by age. And what you can see here is that in young adults in their 20s, probably the upper limit of normal for TSH is somewhere around 3.6. But in the oldest individuals they looked at, those in their 80s or older, probably a more reasonable upper limit for TSH is up to 7.5. Now, we need to be, I think, therefore, a bit more cautious about instituting thyroid hormone therapy for older patients with just a mild TSH elevation, because that may truly be normal for age. We also need to have some caution because older individuals are going to be at higher risk if we overshoot and over-replace their thyroid hormone therapy. So those individuals who are older, if we over-replace with levothyroxine, are at increased risk for cardiac arrhythmias, about 5 times increased risk for atrial fibrillation compared to older individuals with normal thyroid function, a global decrease in cardiac performance, progressive heart failure. We can trigger a loss of bone mineral content leading to osteoporosis and to fracture risk. We can cause catabolic muscle loss, cause cognitive disturbance, potentially leading to premature dementia, progressive impairment in quality of life. And there are even suggestions in the literature that over-replacement can increase mortality risk, particularly risk for cardiac death. So I would note that I think the evidence favors recommending against treatment of modest TSH elevations in older individuals. From the TRUST trial I showed you earlier, it does not appear that there's a symptomatic benefit. And the upper limit of TSH may be higher than we think, or than the lab would suggest in individuals who are in their 70s and their 80s. When we're treating older individuals, because of the concern of the increased risk for adverse effects of overtreatment, it's reasonable in those you think are particularly at risk, and that may not be every patient over 65, but certainly patients with cardiovascular risk, to start at a more gentle levothyroxine dose and to titrate gradually. And I would particularly, as I said, do that when there are known significant cardiovascular risk factors or known cardiovascular disease. Well, pregnancy is another time when we need to think a little bit differently about who to treat and how to treat for hypothyroidism. And we have observational data that strongly suggests that unequivocally overt hypothyroidism is associated with adverse pregnancy outcomes. And in overt hypothyroidism, we're fairly confident that treatment with levothyroxine will reduce risk. But even in subclinical hypothyroidism, there are observational studies suggesting increased risk for gestational hypertension, for pregnancy loss, for preterm delivery, and for having infants with low birth weight. And there's also increased risk with both overt and subclinical hypothyroidism for children to have lower IQ because of the importance of thyroid hormone for normal brain development in fetal life. What is less clear is whether if we treat with levothyroxine, we actually improve either the pregnancy outcomes or the child cognitive outcomes. With regard to fetal brain development, we have 2 trials in the literature now, both kind of landmark New England Journal trials. The first of these is this one from John Lazarus, done in women in the UK and in Italy. This is known as the CATS study. Here they screened 22,000 singleton pregnancies in early gestation in order to randomize to one of 2 strategies. So in the screening group, women who had a TSH in the bottom 2.5 percentile, or sorry, a TSH in the top 2.5 percentile, or a free T4 in the bottom 2.5 percentile, so subclinical hypothyroidism or isolated hypothyroxinemia, treated with 150 micrograms of levothyroxine a day. The controls were women where blood was drawn at the same time point in gestation, but not actually tested for thyroid hormone levels until after delivery, so there'd be no ethical problem with failure to treat. And they wound up with about 400 women in each group. They followed these women's children out to almost 3.5 years of age. They measured IQ as a primary outcome and saw no difference. So this was a conclusively negative trial, but one with, I think, a couple of very important caveats. So the first caveat is that randomization in this trial was at 13 weeks gestation, but we know from animal models and from the iodine deficiency literature that probably the most critical window for the importance of maternal thyroid hormone status on fetal brain development is in the first trimester. And so perhaps this intervention was simply too late to see an effect. The other concern with this trial, kind of in retrospect, is that they treated women who were only mildly hypothyroid at baseline with a high dose of thyroid hormone, 150 micrograms. And what we know today that wasn't known when this trial was developed is that both very low and also very high maternal free T4 levels may adversely affect fetal brain development, and it's possible that they treated too high a dose to see an optimal effect. Subsequent to that trial, we have a newer one also in the New England Journal, this led by Brian Casey and published in 2017. This was a multi-center US study that was funded by the NIH, and this was a huge effort. So they screened almost 100,000 pregnancies in order to place women into one of two parallel randomized clinical trials. In one trial, women with isolated hypothyroxanemia, which is defined as normal maternal TSH with a low free T4, were randomized to levothyroxine here at more rational doses compared to placebo. And in the parallel trial here, women with subclinical hypothyroidism, defined as we do currently in pregnancy as a TSH greater than 4 with normal free T4, again randomized to levothyroxine versus placebo. This was meticulously conducted. There was almost no loss to follow-up in this trial, and they assessed IQ in children of these women at 5 years of age and saw no significant difference. So again, another resoundingly negative trial. But again, one I think where there are a couple of important caveats. So the first is that the mean age at randomization was 17 weeks gestation, which again, if the first trimester is important, this may have been too late. The second is maybe this was underpowered. If you look at the raw IQ scores here in the children of the treated compared to untreated mothers, they're 3 points higher. And perhaps, we're seeing a signal of a more subtle effect, but the trial was powered to see an IQ difference of 5 points. And I'm not sure anybody's ever going to power a trial large enough to truly see a 3-point IQ difference if it's real. I would note in this trial, there was no evidence of any benefit for gestational outcomes or pregnancy outcomes of the levothyroxine therapy. So we're left with an observational database with fairly compelling evidence suggesting that even mild degrees of untreated hypothyroidism in pregnancy may be associated with adverse pregnancy outcomes, but we really don't have strong evidence of benefit of therapy. The ATA looked at these data, and the most current iteration of the ATA pregnancy guidelines recommends a stepwise approach to subclinical hypothyroidism in pregnant women. So that women with the TSH greater than 10 with recommended treatment. That's not based on pregnancy trials, because those trials haven't been done, and I'd argue probably wouldn't be ethical. But we would treat those women, as I told you, by and large, outside the pregnancy setting anyway. Women where the TSH is greater than 4 and there's a positive TPO antibody seem to be at the highest risk for associated adverse obstetric outcomes. There's a little bit of trial evidence for benefit for obstetric outcomes in those patients, and we did recommend that treatment. When the TSH is in the 4 to 10 range, but the antibodies are negative, or when the TSH is high normal, 2.5 to 4, but the antibodies are positive, we really don't know. There are not really trial data that have assessed whether levothyroxine initiation is helpful. I think many endocrinologists, myself included, do treat a TSH greater than 4 in pregnancy, but important to remember that we don't actually have a strong evidence base for that. And finally, we recommended against treatment of isolated maternal hypothyroxanemia because right now there aren't any trials demonstrating benefit. Now, that's the ATA's guidance, but there are other guidelines out there, and because I think of the uncertainty about whether there's a benefit of therapy, and if so, in what groups, the guidelines are fairly different. So the American College of Obstetrics and Gynecology really takes a pretty hardline stance against treatment of any form of mild hypothyroidism in pregnancy. So it recommends against levothyroxine initiation, even when the TSH is quite elevated. So regardless of TSH level, regardless of TPO antibody status. On the other side, the European Thyroid Association and the American Society for Reproductive Medicine both have guidelines that suggest treatment for all patients with subclinical hypothyroidism. So again, I think we don't have a perfect evidence base, and for that reason, we don't really know precisely what the right thing is to do. However, although there's uncertainty about who needs treatment, there's actually pretty good consensus about how to treat in the pregnancy setting. So we know that women who are on thyroid hormone replacement prior to gestation, even if their TSH is beautifully normal on their dose, most of those women are going to need an increase in their thyroid hormone dosing to maintain euthyroidism once they are pregnant, largely driven by increases in thyroxine binding globulin during pregnancy, but also due to higher rates of thyroid hormone metabolism because there's a fair amount of type 3 deiodinase in the placenta. And so the recommendation is that if you have a patient in your practice who's a woman of reproductive age who might at some point become pregnant, she needs to know pre-conception that if and when she ever becomes pregnant, she will need to increase her dose of thyroid hormone right away and will need to contact care providers for monitoring. So the recommendation currently is to empirically increase thyroid hormone dosing by 25 to 30% as soon as a woman knows she's pregnant. You can do that by increasing the daily dose by that much, or by increasing by 2 tablets a week if people typically take a pill once a day. And then TSH should be checked about every 4 weeks in the first half of gestation while thyroxine binding globulin levels are climbing. And this is all sort of dynamic and in a state of flux to make sure we're optimizing therapy. And that optimal therapy based on both American Thyroid Association and ACOG, American College of Obstetricians and Gynecologists guidelines, is to make sure we're not undertreating in pregnancy. So if a woman does require treatment, we should target a TSH during gestation that's less than 2.5. We should also only be treating with levothyroxine in pregnancy. There is no role for T3 containing therapies for desiccated thyroid. And that's because although that T3 in those therapies maybe crosses the placenta, it does not appear to get into the fetal brain. And if we treat a pregnant woman with both T3 and T4, she may maintain euthyroidism, but the fetus who's not seeing the T3 could be selectively hypothyroid with potential downstream adverse effects on brain development. We don't know very much about how optimizing thyroid hormone levels prior to pregnancy influences pregnant outcomes. No trials have looked at changes in thyroid hormone preconception and effects, but we do have this very large recent study from China, 5.8 million mother-child pairs examined here, and they looked at maternal TSH within 6 months prior to pregnancy and effect on gestational outcomes, and found that both low and high TSH levels preconception were deleterious, but particularly preconception TSH greater than 2.5 was associated with increased risk for preterm birth, for perinatal infant death, and for infants born small for gestational age. So these are not data that suggest that we should be treating all women preconception if the TSH is greater than 2.5, but I think it does suggest that if we are already treating those women for hypothyroidism, that we should really target that TSH less than 2.5 preconception. Now, in infants and children, we need to have special considerations. Congenital hypothyroidism, if it's not diagnosed and very promptly and aggressively treated, can lead to irreversible brain damage. So the goal is always to initiate levothyroxine very quickly after delivery, should really be within 2 weeks, with a fairly high starting dose of 10 to 15 micrograms per kilogram per day body weight, to target age-specific reference ranges for TSH and to monitor this quite closely because of the importance of the thyroid hormone levels for brain development, with labs every 1 to 2 weeks until things normalize, every 1 to 3 months up to a year of age, every 2 to 4 months until 3 years of age, and then you can relax a little bit and check every 3 to 6 months until growth is completed. In infants where there's not, who are not athyroidic, where you know there's thyroid tissue there and where there's not a clear underlying cause for their congenital hypothyroidism, it's reasonable at the 3-year mark, when you're not as concerned about the need for replacement for brain development, to reevaluate and see if they truly still need ongoing thyroid hormone replacement. And dose requirements for children will shift a bit as they age. The requirement per body weight will decrease as children get older. In subclinically hypothyroid children, typically the recommendation is if they're over 3 years of age not to treat, although one can consider treatment if the TSH is above 10, especially if children are TPO antibody positive, have hyperlipidemia, or show evidence of poor growth velocity. And finally, central hypothyroidism, we need to manage differently from primary hypothyroidism. One of the important things to remember is that we should not be initiating levothyroxine for central hypothyroidism until we are confident that there's no adrenal insufficiency, because otherwise in an adrenally insufficient patient, if you start levothyroxine without adding some glucocorticoid first, you pose the risk of inducing adrenal crisis. So always assess the adrenal axis before starting therapy. And then also very important to remember that we can't use TSH in patients without functional pituitary glands to assess the sufficiency of thyroid hormone therapy. We need to use the free T4 level, and the recommendation is to target a free T4 that's in the upper half of the normal reference range. When patients with central hypothyroidism, consider increasing levothyroxine doses if there is sort of evidence of suboptimal therapy in children, particularly concern about psychomotor or cognitive development. And also need to increase doses if we're going to start dosing with other medications that could increase those dose requirements, like growth hormone replacement or estrogen therapy, oral contraceptives. There may be higher requirements during puberty, during controlled ovarian stimulation for IVF, during pregnancy, where again, you'd target probably a free T4 just at or above the upper limit of the normal reference range. Weight gain might trigger a need for increased dosing. And then again, initiation of new medications that could increase dose requirements. So in conclusion, we need to consider life stage in making our treatment decisions about hypothyroidism. Overt hypothyroidism always needs to be treated, but the additional initial dose is going to be age dependent. There's not really a good consensus on subclinical hypothyroidism, and important to monitor free T4, not TSH, when hypothyroidism is caused by the pituitary rather than the thyroid gland. And probably a reasonable algorithm, although there's controversy in non-pregnant adults, is for overt hypothyroidism, initiate full dose 1.6 microgram per kilogram per day levothyroxine in younger individuals, lower dose for initiation and slower titration in those who are older. And for subclinical hypothyroidism, to initiate low dose levothyroxine in somebody planning pregnancy, where the TSH is greater than 10, where there are symptoms, and for other individuals to simply monitor. And with that, I will thank you for your attention.
Thank you, Professor Pierce, for the evidence-based approach to treating special population. Moving on to our session before the last one, that will be presented by Professor Gregory Randolph. He is a professor of otolaryngology and the chair of thyroid surgical oncology at Harvard Medical School. He has focused his research on recurrent laryngeal nerve anatomy, preservation, and monitoring during thyroid cancer surgery. He has led thyroid surgical missions in many countries, including Russia, China, Kenya, rural India, and in the Chernobyl region. He focuses and directs the Harvard thyroid and parathyroid surgery courses for surgeons and has directed international surgical courses in Italy, India, Germany, Switzerland, and Russia. He was director of the international affairs for the American Academy of Otolaryngology, Head and Neck Surgery. He has served as treasurer and on the executive board of the American Thyroid Association. He is now serving as the president-elect of the International Thyroid Oncology Group. Let's welcome Dr. Randolph and enjoy his.
Hello, I'd like to welcome you to our lecture on parathyroid autofluorescence. And this is Greg Randolph from Boston in the US, Harvard Medical School. I'd like to welcome you to the Emirates Thyroid Virtual Congress 2022 and thank our steering committee for the kind invitation to speak at this wonderful conference. I would like to speak on parathyroid autofluorescence and really focus on our initial experience with both probe-based and camera-based technologies as it relates to thyroid and parathyroid surgery here in Boston, and focus really that this allows especially our young trainees to ask questions which can be accurately answered during surgery. And so I think there are many possibilities as to how autofluorescence may help us in thyroid and parathyroid surgery, but one of them that I am quite sure of is that it will help our trainees become, have steeper learning trajectories in the field. I have no disclosures other than receiving research funding for a neoadjuvant clinical trial that we are running here at Harvard. So the surgical future is really what we're talking about, and these are some tools that are currently being incorporated. What is the rate of permanent hypoparathyroidism? And this varies on individual studies, individual centers, but large national databases really are ranging, from about 5 to 10% or so in the setting of total thyroidectomy. This is just one smaller national study that looks at the rate of hypoparathyroidism with a 5.4% rate. So this is 5.4% of patients are rendered permanently hypopara as a result of a total thyroidectomy. In fact, there are organizations all around the world whose membership rosters are contain individuals whom we have rendered permanently hypopara, entire organizations set up because of the surgery that we do and its complication. This doesn't seem to have blunted our enthusiasm with offering total thyroidectomy when we offer a thyroidectomy. And this is a large study in Maryland showing the increasing tendency over time to have a higher percentage of thyroidectomies be total thyroidectomies. And there are implications of this increased surgical aggression. And it is basically, as you would expect, that unilateral versus total thyroidectomy has a complication that is twofold. And this is true whether the complication rate is lower because the surgeon is a higher volume surgeon, or whether the complication rate is higher when the surgical volume is lower. Regardless of low, intermediate, or high surgical volume, in each circumstance, the complication rate doubles. So what are the consequences of this permanent hypoparathyroidism that we engender? And Anders Bergenfeld has done some wonderful work in this regard, looking at the Scandinavian Quality Register, a large national database, and shows that there is substantial morbidity in the permanent hypopara state, including substantial 5-fold increased risk of renal insufficiency, increased risk 2-fold of the development of any malignancy in ongoing follow-up, and an increased risk of cardiovascular events in patients known to have cardiovascular disease at the time of their surgery. So pretty substantial surgical morbidity from permanent hypoparathyroidism. In fact, Anders with Dr. Almquist have shown that there is actually a 2-fold increased risk of death. So increased mortality in addition to morbidity associated with the post-surgical hypopara state. All of this data set is with careful dissection, capsular dissection, with loop magnification. Capsule dissection and loop magnification is not good enough. That's how we've gotten here. We need to do better. And the emergence of parathyroid autofluorescence, I think, is the beginning of a application of technology where our eyes fail us, and I think is additively helpful. Think about tissue differentiation right now. It's like the blind butcher at the top. We excise tissue, we kill it to send it to the pathologist. Might it be better that we apply through some optical technology that the surgeon can apply to the surgical field, and perhaps then interact with the pathologist who may be in another room to determine whether, we interrogate a certain material in the surgical field and ask our pathologist who is hooked in with us, is this parathyroid tissue? And then they can say, yes, Greg, this is parathyroid tissue, without having to kill it to show what it is. So we've done some work in associated technology, which has shown us the potential for light interrogation of the surgical field through optical coherence tomography, and the ability of that technology to differentiate tissue in the surgical field. And this is basically a kind of a light being shown at the surgical field, and you can get a grayscale type image shown here with two different forms of OCT on the left, and compare that to the H&E thyroid biopsy that you see in the upper right. You can obtain information to help differentiate fat from adjacent other types of tissue. You can define muscle. You can identify nodal structures. You can diagnose parathyroid lesions with this light interrogation of the field. And what we're doing now is really miniaturizing that device to a handheld probe, and are having some ongoing studies looking at the probe interrogation of the surgical field through OCT in order to obtain tissue differentiation. What are now other tools, including parathyroid autofluorescence, as a tool of tissue differentiation, specifically to highlight the unique and bright autofluorescence signal of parathyroid tissues as compared to adjacent thyroid, fat, muscle, and nerve. So what is autofluorescence? This is the a near-infrared light is shown to the surgical field. This is at an excitation wavelength, and then this stimulates tissue to create an emission wavelength, which is perceived as the autofluorescent signal. The difference between that excitation and emission wavelength is called the Stokes shift, and this can be exploited to differentiate tissue because the emission of autofluorescence is elevated with parathyroid glands as opposed to surrounding thyroid, fat, muscle, and trachea. And so we can exploit this difference in emission with near-infrared interrogation of the surgical field to identify parathyroid glands. It's interesting, we don't really know exactly what the endogenous fluorophore is that is causing this autofluorescent signal in the parathyroid gland. However, we do know that this fluorophore remains active with devascularization, heat, freezing, and even formalin fixation. So we do not see the autofluorescent parathyroid signal as indicating viable parathyroid tissue. It simply indicates parathyroid tissue. So you cannot use this as a tool to determine that the parathyroid gland is adequately vascularized. There is a proliferation of papers on the clinical application of near-infrared technologies in several different equipment formats that have proliferated in the endocrine surgical field. And there are many different devices available. I'm going to look at two which seem to have risen to the top in terms of their accuracy, utility, and clinical ease of use. These are camera-based systems. I'll focus on the flow beam system, and a probe-based system. I'll focus on the PTI system. And these are really different pieces of equipment, but the same near-infrared interrogation, either with a camera that illuminates the surgical field and provides a surgical field image, or a probe which similarly provides near-infrared interrogation of a specific pinpoint area of the field with a probe touching that area. Otherwise, they're really quite similar. Probe-based versus camera-based, as I discussed. And this is a very good summary by Dr. Carmen Sorozano recently in surgery that discusses kind of state-of-the-art of parathyroid autofluorescence and discusses both camera-based and probe-based technologies and looks at the pluses and minuses of the probe-based and camera-based options. The potential applications here in thyroidectomy is to identify parathyroid glands, and in parathyroidectomy, again, to localize parathyroid glands, but also potentially, as I will discuss in a moment, differentiate between normocellular and diseased glands. Camera-based system, this is the example I'll discuss. This is a near-infrared camera that interrogates the surgical field. It's plugged to a monitor. It can also be plugged to a laptop. And I want to show just a couple of important papers that I think will help to show what we already know about the potential benefit or value and accuracy of these autofluorescent systems. The first is Dana Hartel's work, and as typical, she's an amazing researcher and surgeon and has provided us with really a histologic correlate to that intense autofluorescent signal. She correlated the near-infrared signal to biopsied, histopathologically proven parathyroid glands, so made that essential connection between the high near-infrared excitation signal and histopathologically proven parathyroid glands. Faris has done some beautiful work also looking at the biochemical consequences of application of near-infrared technology. And again, this is not shown in all studies, but in this large study, Faris found that there was an association of improved calcium profiles postoperatively in those patients in the near-infrared applied group, as opposed to the non-infrared standard care group. Quite poignantly different. He also found, in addition to that biochemical outcome parameter, that inadvertent resected glands were less when near-infrared was used, and the rate of autotransplantation of parathyroid glands was lower in the near-infrared applied group. It is important, as you interrogate the field with light and measure its excitation emission, that the ambient light is important. And so there are some practical ambient lighting issues that need to be dealt with in order that you harvest accurate information, which can be uniformly interpreted. And you see in Marseille, Lyon, Geneva, and Boston, we have different combinations of lighting. In Boston, we keep the overhead OR lights off, and we display the image in a laptop adjacent to the OR table. This is a camera that also needs to be held in a uniform distance from the surgical field to obtain standard and comparable images, about 8 centimeters from the surgical field. We initiated our work in October, and we have a very large group of individuals with which we work, my own research group, and the yellow circle is Amanda Silva, our fellow, who is the main mover and worker in this autofluorescence space. And I'll show you some videos here. This is an example of the camera-based system looking at fat with parathyroid in the most medial aspect, which you can see perhaps slightly visually, but it is accentuated with the autofluorescent signal, which is pretty poignant. Here too, you can see parathyroid gland, which is visually evident and then supported by an exuberant autofluorescent signal, also seen on the flow beam image representation on the laptop. And then here is an example of a parathyroid gland, which was not so evident visually, and in fact, inadvertently excised as part of our goiter surgery. And in this small section of fat, we found an exuberant autofluorescent signal, which was in fact parathyroid. So additive to your visual inspection. I have found that the camera interrogation of the lobar field, once the lobe is resected, actually has shown me in many circumstances parathyroid glands that I had not seen during the surgery. They were adjacent to the surgical field, not surgically recognized, and identified as a result of the post-lobectomy interrogation with the camera of the surgical field. On the left, a lower gland, on the right, an upper gland that was identified first with the camera. This is an interesting picture, a typical picture of a parathyroid adenoma. Adenomas and hyperplastic glands typically have elevated autofluorescent signal as compared to thyroid, but actually have a lesser and often patchy signal as compared to normal cellular glands. So this was a parathyroid adenoma that had a normal cellular cap, which the forceps are pointing to, and it typically shows the picture of a quite bright normal cellular cap with a more patchy and lower, but still autofluorescent signal of the hyperplastic of the, in this case, adenomatous gland. There is variability though, and you can certainly have parathyroid adenoma that are quite bright, such as this example. Thyroid glands have variable autofluorescence. In general, they are less bright than either hyperplastic adenomatous and certainly less bright than normal cellular parathyroid glands, but it varies. And you can see, for example, on the right, a quite bright and patchy thyroid gland. Goiters, again, showing patches of autofluorescent signal. And again, a goiter with a bright signal. There are false positives. And so, for example, this autofluorescent signal that I'll show you on the image is both left and right are thymus elements that can sometimes be quite bright, mimicking a normal cellular parathyroid gland. Here's an example also of thyroid nodules, can also be sometimes cystic, a colloid nodule, and can be quite bright relative to the surrounding thyroid tissue. And actually also the cauterized edge, when we use the harmonic scissors on a isthmus, you can see that this induces an artifactual autofluorescent signal on the cauterized edge of the isthmus margin. So false positives and false negatives, this is our list that we are currently building here. False positive, brown fat, metastatic lymph nodes, colloid thyroid nodules. False negatives, camera held at a too distant distance. Probe can be miscalibrated. I'll get to the probe in just a moment. The depth of the parathyroid gland, the camera does not penetrate multiple layers of tissue, and so you need really to see a portion of the gland in order for it to be perceived by the autofluorescent signal. And again, normal parathyroid glands and adenomatous glands have a variable and sometimes patchy autofluorescent signal. So here's again an example of a normal cellular gland here and an adenoma, showing that both are brighter than typical thyroid, but the normal cellular gland is a good bit more bright than the more patchy, bright adenoma. Again, here is an example of a parathyroid adenoma that is somewhat more patchy in its autofluorescent signal. And now I want to look at some of the flow beam studies. We've done this in conjunction with Aaron Berber at Cleveland Clinic. We've looked at a variety of different histologic and radiographic metrics, comparing it to the autofluorescent signal that is seen at thyroid and parathyroid surgery. And one of the things we're looking at and are especially interested in is the quantification of this image, because really the camera just gives you a picture. And so we're trying to look at the pixel per unit area in an area of interest and look at the quantification of that image and see if we can work with the quantification of that image to provide some quantifiable percent risk of parathyroid tissue or adenomatous tissue or thyroid tissue. So you can quantify through image processing the image that you get, and we're working with these numbers to see if we can do better to quantify, to get a number for the image. To switch gears now from the camera-based systems, which I've shown, to probe-based systems, again, still near-infrared interrogation of the field, but point now with the probe. You find an area you want to interrogate and touch it with the probe, and this provides a near-infrared illumination, records the emission wavelength, and then you are generating a ratio of that autofluorescent signal of the area in question to the previously determined baseline, which is obtained on the thyroid gland. Here you see the image on the left side, our left of the monitor, shows the actual hard number of autofluorescence signal recorded, and then the number on the right of the screen shows the ratio of that number to the baseline thyroid number, and that provides this detection ratio. The company says that over 1.2 would be positive for parathyroid gland, and we found a little bit different data, which I'll mention in some publications, but this is how with the probe-based system, you obtain a baseline. With the thyroid gland exposed, then you obtain 5 different measures. This gets a baseline thyroid autofluorescence signal into the machine, and then the interrogated point to look for parathyroid tissue is compared to this thyroid baseline. And so here's an example of that procedure once the baseline is obtained to look at normocellular parathyroid gland versus fat. So here is some fat. You see a low ratio, and then you go up to the parathyroid gland, and you see a ratio of now over 2, suggesting that area that you're interrogating, this is negative, and then that area where the ratio went higher is parathyroid tissue. And here's an example of, again, high ratio, the probe is on parathyroid, then you move it to adjacent fat, low ratio. And it's that discordance that allows you to identify the parathyroid. What's the nascent literature on this? Well, the bulk of this probe-based system has been through Carmen's work and Anita Jansen's work at Vanderbilt, and they found really in expert hands who are very familiar with this probe-based technology, excellent sensitivity and specificity for parathyroid gland. This gold standard here was not like in Dana Hartel's study, histopathology, but surgeon's judgment as to what the parathyroid gland was. That was the gold standard upon which the autofluorescence signal was compared. In Dana's study, it was histopathologic definition of parathyroid tissue. That was what the autofluorescence signal was compared to. And so basically, the studies of this group have shown that there is a quite accurate parathyroid identification with the PTI system. In our studies here, we've looked at the receiver operating curve for the exact ratio that we thought was most optimal. And unlike the manufacturer's specifications, we felt that the ratio of about 2.5 was the optimal ratio that would provide the best discrimination between parathyroid and non-parathyroid tissue. We've also preliminarily looked at an initial group of patients and found that PTH levels seem to be improved with the application of the PTI technology. The American Head and Neck Society has a soon-to-be published consensus statement. This paper is now under review and will be submitted to Head and Neck and out within hopefully the next 2 months or so, with a worldwide consensus on the application of both probe and camera-based systems to thyroid and parathyroid. And so this paper looks at the algorithmic way of using the probe-based system, how to get it up and running and how to use it. It looks at the same kind of sets of standard setup and uniform application for camera-based systems. And I would just say in summary, now having more than a year of experience with these systems, both camera-based flow beam and probe-based PTI, I would say several things. That I would say that the utilization of the technology accelerates the identification of parathyroid glands. You see them sooner when you have both your eyes and autofluorescence available. That's one statement I feel comfortable with. The second is it does confirm parathyroid identity. And so in that way, it's kind of competing with frozen section. Do you need a frozen section when you have autofluorescence signal that is exuberant in something that you feel is a parathyroid gland? It's additive information, and is competing, I think, with frozen section. The third is you definitely do find glands that you had not seen before when you interrogate the field with autofluorescence. The fourth is it does not correlate with vascularity. A good autofluorescence signal correlates with parathyroid gland identity, but it does not imply that that parathyroid gland is vascularized. That's important to understand. There are other technologies that are being evaluated, speckle imaging, OCT, that may provide a vascular information, which is certainly important. But I would say more than anything, the ability of our young trainees to ask questions, innumerable questions during surgery, and get them accurately answered in real time will, I think, steepen their learning trajectory. I think they will be better surgeons sooner if they train with parathyroid autofluorescence. I believe that. So we've talked about autofluorescence as it applies to thyroid and parathyroid surgery. We've talked about the main bottom line is that I feel that it will accelerate surgical education because asking questions is good and getting them accurately answered is even better. I want to thank the steering committee again for the kind invitation, for the honor to speak at the Emirates Thyroid Virtual Congress 2022. I want to offer up some invitations to our thyroid surgical course here at Harvard, which will be virtual, November 2022. My email address is there. And also to invite you to consider some of the World Congress on Thyroid Cancer programming. We have virtual meetings April and October set for this year, 2022. We also have planned in-person visits, congresses for London 2023 and Boston 2025, and I'd welcome you to those programs. The most proximate program we have is April, a virtual program. You can see this through the website, and we will have programming in that April 9th program on Hürthle cell carcinoma, worldwide thyroid cancer guidelines, medullary carcinoma and RET oncogenesis, a surgical module on autofluorescence monitoring, RLN management, and RFA, and also a thyroid cancer tumor board. And then at the end of the program, we break into a number of Meet the Professor sessions on MTC and ATC management, medullary and anaplastic management, a surgical pearls Meet the Professor, differentiated carcinoma follow-up Meet the Professor, TKIs, when to start and how to manage adverse events, and laryngeal assessment with thyroid surgery, as well as RLN surgical management, Meet the Professor. So it should be an excellent program, and we'd welcome you to visit with us on the World Congress on Thyroid Cancer. Thank you very much for your attention.
That was an excellent presentation by Professor Randolph. We'll move on now to present something different, which is some local research work performed here in the United Arab Emirates. Let me just share the slides. Gerard, are you able to see the slide? So this is some research work done here in the United Arab Emirates around thyroid cancer. So what is the rank of thyroid cancer here in the United Arab Emirates? So this is the most recent study, which was published in 2018. And that included data gathered between 1982 till 2004, and it included national cancer registries. So the study concluded that the top 3 cancers in males were lung, followed by gastric, and then the prostate in males. Whereas in females, the top 3 cancers were of breast cancer, coming on as a number 1 rank, followed by cervical cancer, and thyroid cancer was ranked as the 3rd thyroid cancer in females. So as you can see, it is one of the top cancers in the United Emirates, especially in the female population. So when we talk about cancer, it's better to start with explaining demography and looking at the presentation of thyroid cancer among the population, and understand how does it present among the population in each country. So the incidence rates of thyroid cancer in the United Arab Emirates, and that is per 100,000 population, as you can see, along the years, it's increasing along the years. So in 2000, oops. So as you can see here, if you compare the incidence starting from 2012 along 2015, the rate of cancer has increased. So it has reached up to 25 in 2015. And if you compare that incidence to South Korea or the United States, you will find a similar increase in the rate of incidence of thyroid cancer along those years. So what is the stage at presentation of thyroid cancer? So this is a study performed by our group, which has included, again, a national registry of thyroid cancer. And the majority of thyroid cancer was staged at a fairly early stage, stage 1A, and that was per TNM definitions. And the majority of those cancers were not associated with lymph node metastases. Again, over 98% of those cancers were not associated with distant metastases. So that tells us that the presentation of most of thyroid cancer is at a very early stage of presentation and not associated with malignancies, which is a burden in terms of morbidity and surveillance and frequency of follow-up visits. What about the stage? Again, majority of cancer, over 77% of all thyroid cancers were staged at stage 1. However, if you look at the anaplastic cancer, most of the anaplastic cancer were found in women. That is important to notice if you're studying any demography, so that you focus your screening, if there would be a screening modality on that certain particular group of population. What about the age group? So majority of patients who had regional lymph node metastases were aged from 30 to 39 years. So most of those patients were in this age group, which is compared to some studies are younger in terms of regional lymph node metastases. And over 50% of those patients with regional lymph node metastases were females. So what is the genetic makeup of those thyroid cancers? Not many studies were performed, but this study which I'm presenting is done by our colleagues at a tertiary care institution. And the study involved certain testing of mutations. So this study tested only BRAF and KRAS mutations in PTC only. So it was around 90 cases studying BRAF V600D mutation and KRAS mutations through the real-time PCR. So what they have found was that those PTC cases, over 46% of those PTC cases had the BRAF mutation, and the rest were having the KRAS mutation. Compared to the rest of the world, as you can see, this was a varying result. So for example, the 46% was somewhere in the middle between a very higher percentage, say like in some parts of Europe and in Saudi Arabia. However, in Italy, the rate was less in terms of PTC having a BRAF mutation. So there's a variation, and therefore each geographical area has to come up with its own genetic makeup study. What about the characteristics, further characteristics of that most common mutation which was found? So most of these BRAF mutations, over 74%, had lymph node metastases, and that resembles other studies published worldwide. Another studies performed by our group studied the thyroid cancer risk in multinodular goiter. So we have studied over 500 nodules with ultrasound-guided final aspiration biopsy. Study duration was from 2011 to 2015. So the overall crude prevalence was 10%. That's a varying, there's a varying prevalence, again, reported in the literature, ranging from 5 to 15. What are the nodal characteristics of the nodules that were cancerous? So over 41% of the nodes which had cancer had a size ranging from 2 to 4 centimeters. And most of them were hypoechoic or complex. Most of these nodules were not associated with lymphadenopathy. And over 70%, approaching 79%, of all these final aspiration biopsies performed turned out to be of Bethesda 2 category. What was the clinical practice towards the atypia? That was a study performed in 2 institutions, 2 tertiary centers. These tertiary centers obviously were referral centers. And we have studied so this is by our group as well, we have studied the practice, the clinical practice towards atypia. 50% of those nodules with atypia were sent for surgery. Among those 50% that were sent for surgery, 59% denoted a benign histology. And when we repeated the FNA for nodules that did not go for surgery, 17 out of 38 had a benign category, so a Bethesda 2 category. So that represents the same thing, the diagnosis of a repeated FNA cases. 44% had a benign, which is a Bethesda 2 category when repeated the biopsy. So here are some future thoughts on this limited data that we have presented. More studies need to be performed in terms of the risk factors associated with thyroid cancer, as we are seeing an increase in the incidence of thyroid cancer along the years. The increase in the incidence can be explained by the widespread availability of the ultrasound and its use in clinical practice. And along those years of the study period that I have presented, the ultrasound came into clinical practice around 2013 here in our institution. A similar study was performed in South Korea, has found the same thing, an increase in incidence, and they attributed that to the use of ultrasound in a widespread manner. However, we shouldn't ignore the environmental factor that we have to focus on. Is there more radiation? Is there more carcinogenic in the environment? Especially when we see certain type of pathology, aggressive pathology in certain geographical area in our country. Based on the practice towards the atypia, are we overdoing things? Since 50% of the surgically performed procedures on those atypia came back as benign when we looked at histology. So that will lead to us thinking and performing more research work on screening and detecting thyroid pathology, thyroid anatomical pathology. Are we over detecting thyroid nodules and overdoing subsequent therapies or management plans for an incidental finding of thyroid nodule? Since we also have a favorable stage, so most of the cancer were at stage 1, and as it's known with the new classification of 2000 that came in 2018, stage 1 people do very great in terms of mortality. And therefore, knowing that, do we still need to do the overdiagnosis and the over-management, over surveillance and following up of those cases? So that we need to reconsider, especially when we know that we have applied surgical intervention for those nodules which turned out to have a benign histology. And third, future thought is, can we imply and include some tools to improve our predictive values in the atypia category of nodules, i.e. some genetic sequencing to tell us that surgery is not indicated in this case? Now, without having this widespread use of applying genetic analysis, since it's not widely available in the United Arab Emirates, and because it's not covered by insurance, local insurance, we know what to do with the Bethesda 3 and 4 category. We only use the genetic analysis if patient refuses surgery. However, if we want to prognosticate or tailor a treatment with certain types of cancer that are resistant to refractory to radioactive iodine, there might be a role for this genetic makeup analysis. The last point is, I think, is the most important point here, since we have found the higher rates of anaplastic cancers in females. That leads to the need to think of a certain screening method or looking at possible factors in females in particular to have higher rates of anaplastic cancer. I thank my colleagues who have been working in the research field, and we hope to see more research work here in the country. So that ends the session, and we open the floor now for questions. We have many questions. for both surgeons and endocrinologists. Let me welcome the panel again. It has been a great talk, great talks presented tonight and yesterday as well, last night. So let me welcome the panel again. And we start with our first question. So that's a question to Dr. Pierce. Dr. Pierce, knowing that TSH can be accepted, TSH up to 7 can be accepted in elderly population. Shall we treat this subclinical hyperthyroidism in elderly individuals?
So I think we should not be treating subclinical hypothyroidism in older individuals unless there's a very compelling reason to do so. And typically, probably we should not be treating, TSH levels under 10 in that group because there's really not evidence of benefit. And
sorry, the question was
hyper.
Hyper,
sorry.
yeah.
Yes. Okay. That we know less about. And I think the concerns about subclinical hyperthyroidism in the elderly pertain to bone loss, risk for osteoporosis, and risk for atrial fibrillation. So I think recommendation would be to consider treatment in individuals with osteoporosis, cardiovascular risk factors, age over 65. And I don't think we have strong data, compelling data to suggest that the lower end of TSH in older individuals is radically different from the upper end of the TSH ranges, but the lower end, not so much.
Perfect. Okay. This is a question related to thyroid emergencies. So is it enough to heart block the patient prior to going to OR if knowing that plasmapheresis might not be available in some areas of the country?
I understand that you're referring to what extent we aim to normalize thyroid levels prior to thyroidectomy. And as I mentioned, the sequence of events there beyond beta blockers, certainly anti-thyroid drugs and Lugol therapy is what we employ routinely. Do we get everybody euthyroid just with these tools? No. It would be great, but unfortunately, some patients require additional steps. And in some cases, if plasmapheresis is not available, I think that thyroidectomy in the hands of an expert surgeon is still a better tool than waiting on the thyroid storm to run its course, which might be an unfavorable course. So sometimes we do need to embark on thyroidectomy while patients are still thyrotoxic. Fortunately, most of the time, those results are still good. Again, expertise is what grants those results.
So if the free hormones were like mildly elevated after you have initiated your first line and second line, is it enough to heart block up to 70, 80 beats per minute and go ahead with thyroidectomy, even with mild elevation of T4, free T3?
I think that's actually a very good response to beta blockers. If the heart rate is below 90, I feel that we've achieved adequate beta blockade. It is not only the cardiac status reflected in heart rate. Obviously, we want to see that the liver is in a position in which the anesthetic agents can be tolerated. Sometimes even anesthesia has to be adjusted according to the patient's overall metabolic status. And sometimes general anesthesia actually has been bypassed to a just local anesthetic approach. Probably Dr. Tufano can comment on his perspective on that, but we've been successful in managing patients even with cardiac rate above 90, but the goal would be less than 90 at rest.
Excellent. Okay, and can you explain why do we use Lugols before? Why do we use antithyroid medications we block before we use the Lugol solution?
That has been actually many times a board question for us endocrinologists as to the benefit of introducing an antithyroid agent first and then bringing on the iodine. which, as we know, in some cases, when we obtain a CT with contrast, we find patients to be thyrotoxic a week later due to the autonomy that is present that iodine might exacerbate. So there's an approach that we've all taken as in preventing further thyroid synthesis with anti-thyroid drugs before we bring on the iodine. The beneficial effect of iodine, as we know it, is to inhibit both T4 to T3 conversion, but also probably to decrease the vascularity of the gland. There's data providing or suggesting that there's less blood loss in iodine pre-treated patients at the time of thyroidectomy, and also probably to decrease the hormone synthesis altogether. So I think it's a multifaceted benefit that we get from iodine therapy.
Okay. And next is a question to Dr. Pierce. Do you recommend delay conception if patient had radioactive iodine treatment to her Graves' disease?
Yes. So the recommendation is that women should wait 6 months after radioactive iodine treatment to become pregnant, and that's for two reasons. One is just that it takes a while for the radioactive iodine treatment to fully have its effect, and for women to become hypothyroid and then to get stabilized on levothyroxine, which you want to have happened before conception. And the other is there are data suggesting perhaps a slightly higher risk of fetal anomalies when women get radioactive iodine within 6 months prior to conception. So for both of those reasons, a 6-month delay is recommended.
Okay. And what do you do with a positive TRAB, but normal thyroid function test pre-conception?
Pre-conception, I don't worry too much, because as long as the mother has an intact thyroid, you assume that the fetal thyroid is probably going to have a similar response to the TRAB as the maternal thyroid. And if the TSH receptor stimulating antibody titer is not sufficient to make the mother hyperthyroid, it will probably not be sufficient to make the fetus hyperthyroid, particularly given that antibody titers tend to decline as pregnancy progresses. So by the time we're midway through pregnancy and the fetal thyroid is working and at risk, the titers are probably going to be lower.
We thought that some people were thinking that with positive TRAB, you still need to treat even if the thyroid function tests were normal.
Not if the mother has an intact thyroid. The exception to that might be a mother who has a fetus who appears to have fetal Graves' disease, where the mother has an ablated thyroid. So she's not needing any anti-thyroid drug herself, and you can't use her thyroidal response to antibody as kind of a surrogate for what the fetus is doing. So in those rare cases, we sometimes give the mother who doesn't have a thyroid herself anti-thyroid drugs specifically so it can cross the placenta and treat the fetal thyroid.
To block, yeah. Okay. This is a question anyone in the panel, actually, your expert's opinion is needed here. This is in adults, certain brands have been experienced by this physician, without mentioning the brand names. With a certain brand, symptoms of hyperthyroidism were more pronounced, especially with the first at 4 hours of post-ingestion. Does that have to do with the bioavailability of the pill and the dissociation of the pill? How do we overcome that if we're treating thyroid cancer patient? Some patients will refuse to be on that particular dose to be suppressed because of the symptoms. So what's your experience on different brands, and which preparation was the least problematic in keeping thyroid cancer patients suppressed without complaints?
Oh man, nobody wants to answer this one. So the real truth is, hey, Dr. Seddeeqi, the real truth is, based in our practice in the United States insurance, it's very common for patients to have to switch between different generics and different brands based on theirs. And 20 years ago, I worried about that. Today, not so much. Most of the patients do fine when we're switching. I do have every once in a while somebody tell me one dissolves more in their mouth or is a little different. But by and large, I haven't seen any particular one that seemed to be associated with those higher effects, partly because I think these thyroid pills last for 7 days. They've got such a long half-life. I mean, we often give people 2 pills on a Sunday or 2 pills on a Saturday. So I think it's probably more related to the intensity of TSH suppression and less to the individual sort of doses from my standpoint.
Yeah, that's why we sometimes, as you say, we give 2 regimens in a week, 2 different regimens in a week. Dr. Bauer, any comments on that?
No, I mean, I agree with Mike. I think it's hard to provide a specific answer to without knowing what specific form of thyroid hormone replacement we're discussing. The data shows for the gel caps and the solutions, there's now 2 commercially available solutions, at least in the United States, 2 different companies, that absorption can be more rapid. So there are certain forms where the rapidity of absorption and potentially the peaks of T3 and T4 might be different if it's T4 only in T4. But I guess we'd have to hear a little bit more about the specifics and of that that individual person's patient's situation. But outside of that, I think, as Mike said, most of these drugs have, especially in tablet form, have a pretty uniform uptake. There is one, because our patients, pediatric patients often have to dissolve them in water if it's a young patient. I know some of the tablets dissolve more easily. Maybe that makes it more readily absorbed. I don't think that's ever been formally studied. It's just parents telling us that that's true in a teaspoon form. But if that's the case, switch to a different brand. I guess that's the beauty of it, right? We have other options for that particular patient.
Okay. And suppression effect on bone in cancer patients. I guess they mean, TSH. So what's the TSH target suppression? And so pediatrics usually will present with either a moderate or high risk for recurrence, if they have lung mets or neck nodal mets. So what's your TSH target? And are you worried about bone effect if you're suppressing TSH?
In pediatrics, we talked about it actually yesterday during our tumor board, I think, just very briefly. So our targets are similar to adults. We just don't have any prospective data to alter those targets as far as high risk, intermediate, and low risk. So, suppressed for the high risk patients and somewhere between, although Mike said, I think 1 to 3 for low risk, or probably in the 1 to 2 range in clinical practice, but not suppressed if it's the low risk patient that the data supports that they're in remission. And as far as impact on bone, it's a great question. So historically, clinically, what we hear from our adults is nothing so far. So I'm not sure either we're not communicating or just not hearing, but we haven't seen a cohort of adult patients that are pediatric eye cancer survivors that have had a significant negative impact on bone mineral density, increased risk for osteopenia, osteoporosis as adults, potentially related to or consequent to TSH suppression during their peak bone acquisition. But we do have a study actually in our hospital. We're just wrapping up the control group. So we've completed the subject group looking at bone mineral density acquisition during adolescence with thyroid cancer that are on TSH suppression. And we have bone density and CT quantification data looking at their bone health. And now we're getting age match controls. So we have something to compare to. So hopefully in the next year or so, we'll have some at least data within pediatrics that either shows or doesn't show. I don't know what the data will show yet, if there is a negative impact on bone acquisition, but it's a thing we think about and an important question.
Well, I think the worry in pediatrics most is because, so those adults, pediatrics, they have more years to live. In adults, we don't perform DEXA scan unless according to guidelines like age and risk factors.
We're not performing it for all of our patients. This is a study, a prospective study, trying to see if it's a negative impact on bone acquisition.
Okay.
And for young adults also, right, bone acquisition occurs into late 20s, right? So,
yeah.
And then we do everything we can to optimize, like everyone on the call, I'm sure, vitamin D status and calcium intake, everything we can do to provide preventative care.
Yeah. Okay, thank you. Questions for the surgeons. A single toxic nodule can be done through the endoscopic surgery? I guess that's a question for Dr. Tufano.
Yes, of course it can be done. I mean, we use the same criteria for consideration with benign nodules. And then, ideally, we really don't feel as comfortable tackling something bigger than 6 centimeters as far as a benign nodule goes, because the working space is limited, and we're going from the medial aspect of the sternocleidomastoid muscle on each side down to the level of the clavicle, sternal notch, and then up to the thyroid cartilage. In particular, obviously, with a toxic nodule, especially if you see on your ultrasound significant vascularity on your color, the Doppler assessment, and especially with friable capsular vessels, if you see a lot of capsular vascularity, that is a little bit more of a concern that you can have some friable tissue as you manipulate it and have some more bleeding. So there are some things that we do in that circumstance where we have the patient situated more in a reverse Trendelenburg situation, so such that their head are much higher than their feet. And you see the blood tend to accumulate a little bit more inferiorly. But as you recall, we're working where the meat and potatoes are, so to speak, or the important area is where the nerve is entering the larynx. And so that is higher up and more anterior. So there are ways that you can work around even a difficult toxic nodule with some friability on the capsule, vessels that are friable and some bleeding. And also for that petulant Graves' disease, a difficult Graves' case in a similar way. One other comment about toxic nodules, I think Mike made a comment before, is when we're treating benign nodules with radiofrequency ablation, we're just treating the center. That's not necessarily true. If you don't get the capsular vessels, you're going to have regrowth. And it's really important in a toxic nodule with radiofrequency to spend time getting the capsular vessels and the significant feeding vessels. Otherwise, you're going to have a patient who maybe you can quell the hyperthyroidism temporarily, but within a 6-month or a year period of time, they're going to be hyperthyroid again. So we have to be more thorough with a toxic nodule, more so than even a benign nodule. But if a benign, cytologically benign, non-functional nodule has hypervascularity, we want to spend time with radiofrequency to treat those feeding vessels. Otherwise, we'll have a significant risk of regrowth.
Mm-hmm. And do you treat the hyperthyroidism prior to ablating the nodule, i.e., introducing the antithyroid medications for 6 weeks, 2 months, at least before performing any procedure?
Yes, most of the times the patients have come in on some antithyroid medication, and so they're not typically floridly hyperthyroid when we see them, and they're amenable for an intervention surgically or with radiofrequency ablation.
And as I understood from your talk, for Graves' disease patients with the endoscopic approach, you perform subtotal. You leave some thyroid tissue.
We try not to. I think subtotal thyroidectomy has really gone by the wayside, because here in the United States, we found that if we're leaving a significant amount of normal thyroid tissue in the hopes of achieving a euthyroid status, that more often than not, it's hard to judge how much volume of thyroid tissue to leave behind to get to that point. 2, that if we leave too much, then there's a risk of becoming hyperthyroid again, and now the patient is facing the same situation. So now the recommendation, I think most would agree here, is to perform a near total thyroidectomy with thyroid hormone replacement as the sort of best scenario for our patients here.
Mm-hmm. Like when you ablate Graves' disease, the aim is to render them hypothyroid.
Correct. That's exactly right. So we really made that transition over the years. And I think now, I don't think anybody really would strongly consider performing subtotal thyroidectomy for Graves'. Mm-hmm. And even from an endoscopic standpoint, we're able to perform very comprehensive near total or total thyroidectomies in certain situations. obviously everybody has a different intimate relationship of the nerve with the Berry's ligament. Sometimes it's very easy to get all of that thyroid tissue at the Berry's ligament near the nerve insertion point, but sometimes you may have to leave a cuff of, hopefully what you're leaving is normal thyroid tissue. You've already made that assessment in that situation with the ultrasound, and certainly looking at the nodule, and it's, by palpation, by open surgery, or even with your instruments endoscopically, you can feel the nodule interface with normal tissue.
Right. The first talk you have presented beautifully, ways to identify the recurrent laryngeal nerve. How do you go about in situations where a patient has been receiving external beam radiation and you want to do a revision surgery? So how do you identify the recurrent laryngeal and the vital structures?
So that's a great point. First and foremost, as I think some of the speakers had already discussed at this conference, is that these decisions for treatment and what we're going to do are really rendered in a multidisciplinary way. So I would hope that if somebody was receiving external beam radiation therapy for a thyroid disease process or a thyroid cancer, that everybody would have declared that that was absolutely A, necessary, number one, and B, that if it was in a recurrent situation, that no further surgery would be really considered. But if somebody has had radiation therapy for a head and neck cancer, for example, of the upper aerodigestive tract, squamous cell cancer involving the larynx or pharynx, for example, oral cavity or pharynx, and the nodal basins in the neck, this is a very challenging situation. And it depends on the ports and where the radiation was administered. And obviously with IMRT now becoming, more and more in vogue, the fields can be concentrated in one area or another. So if it is in a field that's received, let's say, over 6,300 centigrade of external beam radiation therapy, then you are going to encounter significant challenges with fibrosis. And I think that's where nerve monitoring really helps, because now, like I said before, you may be flying the plane and it's a beautiful day and it's sunny and you see everything, but maybe the storm, now you're in the storm, and you take that nerve monitor and the nerve stimulating probe, and it may help you to map out where that nerve is through some of the dense, more fibrotic scar tissue from the radiation therapy. So I would definitely advocate for nerve monitoring utilization with nerve mapping. That means active stimulation in that area. Don't be so proud to say, I got to find it with my eyes. Maybe the stimulation will help you. And I found that that's helped me in multiple recurrent situations where I'm doing, maybe somebody has had 4 surgeries before me, and then I'm doing their 5th surgery or something like that. It's been very helpful.
Absolutely. Right. Question for Dr. Tuttle's session. Kind of anesthesia used for local infiltration, since you're introducing a painful substance? Is it a ring or a local infiltration, like a local anesthesia?
So that's a great question. I'll ask Dr. Tufano to help me as well. We're actually using conscious sedation. So that was our preference. So it's really easy. They're very quiet and they're very still. Ralph, you guys do conscious or local? How are you guys doing that now?
Yeah, so that's interesting. When we first started, we actually started under a research protocol for benign nodules in 2019, and we did it under general with a laryngeal mask. And then we decided, once we were getting good enough and were safe enough, we started and went to local and straight local. And I think there are a lot of benefits to just using local alone. And some of that you elucidated before, Mike, talking about getting some feedback as to if you're going to run into trouble. Why is the patient having pain or discomfort? If you're near the trachea, no matter what you do, they are going to feel it. So is that heat being transmitted to the trachea? They'll let you know. They'll be moving off the table. If you're too close to the skin, they are going to let you know. In fact, if you have a cyst and you have transudate or the fluid going outside from the heat, the patient will experience pain. And before they even declare that they may have a voice change, they'll have this intense pain that may radiate to the back of the neck or the ear, even the jaw. These kinds of feedback mechanisms are critical for tailoring your approach. I use 1% lidocaine plain, and I try to, as Mike showed before, do that hydrodissection and perform it over the capsule and make sure that I'm really getting the entirety of the anterolateral aspect of the thyroid. So I have a nice hydrodissection plane that you can see, almost a wheel on the ultrasound that you see, and that really helps. But I can tell you the two areas that you cannot anesthetize are the trachea. It is so sensitive to patients, and it's such a great feedback mechanism. And it tells you, boy, if you're getting heat there, you better know where your needle is exactly, and you better dial it down or create some space, like you said, Mike, or near the skin to avoid a burn. It is the patient, you just got to listen to them, because as soon as they say, you stop, and you know, again, alter your approach or dial down the energy and go a little deeper.
So that's very important to know, because when we perform biopsies, we infiltrate just subcutaneously, because below that, the patient doesn't feel the pain. They only feel the pressure, which can radiate.
That's right.
The ear. But that's very important to note. So thanks.
I think you're making the distinction between the nociceptors of the pain, receptors, the heat and the intensity. That is what we're trying to block out. But for you, when you're just doing a biopsy, it's really the pressure. It's not that heat emanating and causing a stimulation of those nociceptors that are giving that pain stimulus. So I don't think that that's absolutely that's necessary at all in fine needle aspiration biopsy.
Mm-hmm. Perfect.
The injection, yeah.
Mm-hmm. How long does it take for a nodule to be ablated using different procedures?
Mike, you can talk for a laser for the microcancers, and I'll talk about maybe benign nodules and RFA.
Yeah, so for us, these microcancers, the laser is usually on for a minute and a half. We use a single laser fiber, so they're pretty small. It's a single position, and because the laser makes this sort of flame arc around it, it destroys things there. So we don't have a lot of pullback and a lot of moving. So it's limited by a very physics sort of, we know exactly how many joules and how long to put it on. And we do it based on the volume and the location. So, laser time on is minute and a half, 2 minutes at the most for these little, the ones that we're looking at are largely 5, 6, 7 millimeters, very small things.
And what would be the ablation, the success rate, up to 70%, but over how long would you find a persistent shrinkage?
So this has been documented very well in the papillary microcarcinomas. They'll shrink for at least a year and a half. By 6 months, you still see this little scar tissue that's left over. And by 1 year, most of the time, it's really hard to tell where you even did the laser ablation. It just looks like normal parenchyma on the ultrasound. So, but there are several papers that have looked at volume, and you get this dramatic, well, first you get a little increase for the first month or 6 weeks that nobody wants to look at. And then by 3 months, it's starting to decrease down a little bit. Because remember, in papillary microcarcinomas, we're killing the cancer and a little safety rim of normal around it. So we basically don't even look at it for about 3 months and expect things to be a little bit smaller. And then usually by a year to 18 months, it's pretty hard to tell where you did the laser ablation in these small places.
Mm-hmm. Excellent. What about the other modalities of ablation?
Yeah, I'll speak to RFA. So for using RFA for microcarcinomas, again, patient selection is critical. I think Mike went through that. It's really important to understand that, again, those that we wouldn't really consider good candidates for active surveillance, we wouldn't be considering good candidates for necessarily these ablative therapies either, just to make that point. The radio frequency is a little bit more challenging because you have to practice this moving shot technique. It's a little bit more esoteric and operator dependent, where you're placing the needle, turning on the generator, assessing the degree of how substantive that nodule is. You may have to dial up the wattage, but you're using the needle to create basically a burn inside that, and you're heating it to see the microbubbles distribute throughout the nodule so that the whole nodule appears hyperechoic after you're done. And I agree with Mike that it's ideal to achieve a little bit of a 2 to 3 millimeter if you can, and usually the ones that we're treating, you can margin. It takes a little longer than laser. So it's going to take probably, once you have the acumen to do this, about 10 minutes or so when you're dealing with this kind of process. With the RFA, you're often looking back at the Doppler, seeing if there's any other area of vascularity, trying to treat those vessels. And I think, though, those are the patients, they tolerate pretty well. Now, when we look at benign nodules, I've gotten to the point now where I'm treating 8 or 9 centimeter benign nodules. I'm delivering about 115,000 to 120,000 joules to these patients. They're sitting assiduously on the table for about 40 to 45 minutes. And I'm trying to get all of those vessels too at the capsule. And I've actually had a few patients, and just recently had a patient return to me with a 65% volume reduction at 1 month, walked in the room, went, oh my God, he goes, this is, oh my God is right. I don't even really see it as much or feel it as much. And I think it's a learning curve where you keep working at it, you get faster, you get better, and you get more confident. And so I've been doing this now for 2.5 years. And at the first point, if I saw something bigger than 4 or 5 centimeters, I'd say, you're crazy, just do surgery. What are you talking about? Now I find it really hard for me to recommend surgery for a benign thyroid nodule, confidently benign, ultrasound appearance benign, at least, 1 fine needle aspiration biopsy, probably for the bigger nodules too, to reduce sampling error, to be sure about it. It's hard for me to advocate for surgery. I would love to give RFA a first chance. And we expect continued changes and reduction in volume as long as up to a year, as Mike said. So the remarkable shrinkage, volume reduction we get with the benign nodules is quite impressive. I'm very pleased with it. I would love to do it faster, but some of these just sop up the energy, and you've got to really keep working to make sure it's completely ablated to give you the best result. I think when Mike said before, where we see problems and failures, especially with benign nodules and significant regrowth or not enough volume reduction, is if we only treat the center. We really have to be devoted to treating the entire nodule as best as we can. The posterior medial aspect, as Mike spoke about too, with the danger triangle, one of the reasons why we wouldn't want to treat a papillary cancer on that area, it's hard to get a margin without hurting things. Same thing for a benign nodule. We tend to leave that posterior medial aspect of the nodule untreated, not too much heat in that area.
Excellent. A question for Dr. Tufano. You've advocated for central neck dissection through the beautiful procedure. How do you do that with a small incision, knowing that you need to go, the direction of dissection needs to go from top to bottom?
So if you're asking central neck dissection for the transoral surgery, that is something that gives you excellent exposure to bilateral paratracheal nodal basins, obviously prelaryngeal and pretracheal nodes, very easy. So you're dissecting the nerve from its insertion point on the right side to where it comes out from underneath the innominate artery, subclavian artery, and common carotid artery junction, and the left toward the clavicle, underneath the clavicle. And so you can actually, with a cottonoid endoscopic Kittner, mobilize that nerve and pick up the lymph nodes and work around the nerve and see all of the structures you need to see. I'm not advocating for big, bulky lymph node resection. That still needs to be an open approach. Again, we know our boundaries. If you have a few small sub-centimeter lymph nodes, you see them on the ultrasound, the index nodule permits you to do an endoscopic transoral approach. There's no reason to say, oh, I have a few like 6 or 8 millimeter lymph nodes, I can't do transoral anymore. No. So bulky lymph nodes, absolutely. A few small lymph nodes, you can do a very comprehensive central compartment neck dissection. And I don't perform prophylactic central compartment neck dissection, but just think that if there are no real lymph nodes in that area and you did do that and you wanted to make it part of your practice, it's very easy to do and it's very safe. So it takes a little time to just work with the instruments and get comfortable, but you can follow the entirety of that nerve and be very comfortable that you can protect it when you're doing your central compartment neck dissection through a transoral approach.
Mm-hmm. And have you ever aborted a transvestibular approach and converted to an open approach?
Yes, yeah, very early in our experience. I think it was in the first 100 cases, we had 4 conversions. And where we were troubled was sometimes a higher superior pole trying to take the entire superior pole down. And when we have to rely on the ligation technology, we're pulling the superior pole inferiorly, and we had a superior thyroid artery bleed. And so we've learned how to manipulate that a little bit differently with the instrumentation. That was probably in 2 cases. We had a very large nodule that we had bleeding with, and it was difficult to control, and converted that one. And I think my colleague had a more aggressive cancer and he felt compelled to open the case for that to have a better resection.
Excellent, excellent. Okay. A question from the pediatric colleague for Dr. Bauer. Consequences of delaying starting levothyroxine in the infant stage versus later on.
So it's well established for decades now as far as the goal of initiation of thyroid hormone replacement in congenital hypothyroidism. So the ideal is within a month of birth, sooner if possible. So newborn screening identifies patients usually in the first week, and initiation of therapy from that point forward. And brain plasticity is most prominent up to about age 3 to 5 years of age. So maintaining normal thyroid hormone status during that time frame, both fetally, as Elizabeth talked about, in the intrauterine environment, and then up to age 3 to 5 is critical. So you want to initiate early, you want to normalize, and you want to keep as consistent as possible during that time frame. If you don't, what we've learned before the 80s, before at least in the United States when we initiated newborn screening, is you permanently lose IQ points. So if there's a delay, the IQ points decrease, week to week, month to month, and that's a non-recoverable impact. So that's pretty well established. After that time frame, 3 to 5 year time frame, after the child's entering the school age, there's less impact on neurocognitive function as far as permanent deficits, but it just impacts quality of life and other issues. So we have many patients that present, kind of delayed profound hypothyroidism. And what you sometimes see with them is actually once you initiate thyroid hormone replacement, sometimes they flip the other way because they go from kind of someone who's able to sit down maybe more than they should have. And then you turn them into a normal 7-year-old or 9-year-old or 10-year-old, and they sometimes have a problem. And we warn our patients if they had profound, TSH of 50, 100, or sometimes we see the hundreds, 400, 500, 600, that once we start therapy, they may have attention deficit like issues, and may have to adjust to that. But it's not a permanent negative impact on neurocognitive function once you leave that time of importance as far as plasticity to the brain.
Yeah. I, in fact, treat thyroid cancer in kids and thyroid nodules. I biopsy them, although I'm an adult endocrinologist, but I do this along with co-management with my pediatrics colleagues. So in terms of suppression, when we started suppressing this post cancer, this patient had a kid who had a primary treatment for thyroid cancer. He started to, with bizarre behavior, very hyperactive in the bus coming back from school to home. Well, mother was relating that to the, since we have changed the dose of levothyroxine to make the TSH more suppressible.
There's confounding variables, for all of our patients. But again, as Elizabeth mentioned, I think early on, and I didn't bring it up, I'm glad you brought it up, hypothyroidism was our main focus, but it turns out hyperthyroidism also can have a negative impact, both during that neonatal up to 3 to 5 years of age. Again, potentially permanent negative impact if you over-treat patients. And then for our school age patients, we have to balance TSH suppression for our thyroid cancer patients without making them clinically overtly hyperthyroid. And because we don't have negative data showing that if you balancing between making someone attention deficit and dysfunctional, both learning wise and socially, because we think about both those things in our population, then you decrease, as you described for your patient, you decrease the dose. So try to achieve a TSH that's as low as possible. And if they are less symptomatic socially and academically with a TSH of 0.5 or 1, again, the disease-specific mortality in pediatrics or thyroid cancer patients is low. And so that's a win-win, I think, for that individual patient. You really have to balance not driving our patients crazy with over-treatment and over-suppression when we don't have any data to show negative consequence for reasonable suppression.
True, even for adults, once we, obtain symptoms, get history symptoms of palpitation, or I just don't feel right, we decrease the dose. We don't care about the suppression. Quality of life is important, and other complications along the road we think of is more important.
We know on Graves, and we have data that we're also working on hyperthyroidism, Graves' disease. This is a cohort. We've done neurocognitive batteries and looking at various domains of function with our brain behavior lab at Penn. Hyperthyroidism gives you signs and symptoms consistent with attention deficit. There's no doubt about it. And when you normalize the T3, T4 in a Graves' disease patient, those things go back to a more normative status. So you really can overtreat patients. And in that early plasticity phase, it may have permanent negative consequence. And in 5 through adulthood, it might just be amazingly impactful as far as, just socially and neurocognitively, which is also important, but recoverable, thankfully.
Excellent. Thank you. We have no more questions. And I thank all the elite speakers. We come to an end of the Emirates Thyroid Congress program. The event has featured an outstanding educational experience in delivering evidence-based practice guidelines and experts in the field opinions through a fruitful, interactive manner among delegates and the elite faculty members. That was, pronounced yesterday and today as well. The discussion around the local data, I hope, will be inspiring other research group to help improve practice. So on behalf of all of you all, I should like to thank the elite faculty and the organizer who have contributed make this event a great success. We look forward to seeing you all again in 2023, when we shall hopefully meet face-to-face. Thank you and have a good day.
Thanks to everybody. Stay well.
Thank you. Bye-bye.
Thank you.
Thank you.
Durant la journée à Bordeaux, seulement du côté d'Aurillac. Là, il fera très froid, mais c'est temporaire. Et puis ensuite, pour l'évolution de cette météo très